to apply your mind, because everything would be done by artificial intelligence. Till such time, I think we should learn these skills. Thank you very much. I think he is waiting. He wants to convey something more. Thank you very much.
Sir, it is always pleasure to listen to you, sir. And we are blessed to have you to learn not only neurosurgery, but life lessons and philosophy of life. Now I request Professor Ashish Pathak, sir, to kindly enlighten us with his vast knowledge and experience for all young neurosurgeons like us. Professor Ashish Pathak, sir.
Morning, Professor Rajkumar, Head of the Department of Neurosurgery, SGPGI. It's a real honor and a pleasure for me to be back in SGPGI after so many years. Professor Rajkumar referred to skill, knowledge, so many good things. I mean, very nice advice he gave. And I think skull-based surgery is one specialty where you show your humility. This is one of the main branch of neurosurgery where you join hands with others. You forget your ego. That's the most important thing in skull-based surgery. Because here you understand that even though you feel that you're a great neurosurgeon, you can't do much. Simply because Professor Rajkumar referred to the neuro-otologist. Let me give my experience. Neuro-otologist, plastic surgeon, maxillofacial surgeon, and of course the role of all these specialists to deal with the various invading, expanding lesions in the skull base is very important. If you have to do a transfacial surgery, I think it's about 20 cases now. I've done a leaf-out osteotomy to go into the base of the skull, and it's a huge, huge playground for you to operate. So the role of your colleagues in other specialties tells you that they are more important than you, so that you don't get trapped like Abhimanyu and lose the battle. So they would make the corridor, they would see to it that the corridor is sealed and closed and nicely done. So that's very important. So without losing much time, this vibrant city, this vibrant place, this vibrant institute and the vibrant department, I really congratulate you for having this great conference and the workshop. And the only thing I would end by saying is that you should never feel that you are excellent. Excellence is not a destination. Excellent is a journey, and it's never ending. So nobody is excellent in this world. Everybody should feel humble like that. Thank you very much.
Thank you, sir. Now I request Professor Arun Kumar Srivastava, sir, Organizing Secretary for Skullbasecon 23, to kindly introduce us to the course and tell us all the things that are going to happen today, so that we have a brief summary of all that we are expecting.
Thank you, Ashutosh. Very good morning. After so many wisdom and philosophy of the life, because it's the essence of your growing career. So we are going to have this 2.5 day conference, where first day, that is 27th of October, the Friday, is dedicated to two things. Like obviously our theme is making skull base safer. So keeping that in mind, we have actually divided 27th functioning in two parts. The first part is live surgery. Then we know the skull-based neurosurgery is challenging, demanding, and two main kind of things are in practice. One is microneurosurgical practice with the help of exoscope or microscope, and other part is the endoscopic surgery. And obviously we have to understand which facility or which arms to be given more respect. So that is the other part of the discussion. But to cover that, we are having two simultaneous OT. One is where the exoscopic assisted and microscopic assisted surgery will be done. by Professor Dilip Panikkar, and the case discussion will start soon, and we'll be, anticipating good discussion with that case. And then the other OT, in the endoscopic OT, Professor Ashish Suri will operating upon some suprasellar mass, and we are expecting good discussion in that case as well. So if will time permit, then we'll probably go for the 2 endoscopic cases, but I think the microscopic case is huge, and I'd probably take a whole day in OR. So that is the part which we are conducting in SGPGI, that is live surgery demonstration, and then about 60 participants with 20 mentors are working at KGMU, and they are learning the art of applicable part of the neurosurgical anatomy. There also we are having 2 stations. One is for the microscopic, exoscopic surgical exposure in cadaver, and the other part where we are having endoscopic. So that has been arranged at KGMU, and in evening somewhere around 5 o'clock they will be joining us for a Zoom meeting, where a lot of international faculty will sharing their experience in the field of skull-based neurosurgery. So this is regarding 27th. 28th, we are going to have a very brainstorming academic session full of many beautiful talks. I must congratulate Dr. Kuntal Kanti Das. He has put a lot of effort to make those sessions very interactive, interesting, and last time dropped somewhere around 30% drop. He adjusted, managing. So I request a huge round of applause for Kuntal Kanti Das, who has done a lot of effort to making this academic, feast in a very, the ingredient are, I think you will not going to miss any ingredient in that feast. And then 29th till 3 p.m. we are having, we will be running 3 halls simultaneous, and along with the society-based oration and all is there. So that is how we have packed the things for you, and we hope you will enjoy that, and we'll have a beautiful 2.5-day academic feast along with the known Nawabi and the hospitality what we could offer, we are going to offer you, and please forgive us if we miss anything. And with that, from the OR, I would like to acknowledge the effort and sincerity and a lot of help, as Ashish sir and Professor Rajkumar was talking about the teamwork. So we should not forget about our neuroanesthesia team. And a lot of differences has been made by our specialization in anesthesia part, that is the neuroanesthesia. So I would like to acknowledge untiring a lot of effort put by Professor Devendra Gupta and his team. So from OR, Professor Devendra Gupta, Dr. Ruchi, Dr. Prateek, Dr. Ashish Kannozia, they all are, along with their very efficient residents, they are working hard to induce the cases, and they will maintain the cases throughout the surgery, and obviously their role. So I will request Dr. Anant Mehrotra to just, if they could say hello from the OR to us, and we can acknowledge them.
As Arun sir said and Rajkumar sir also said earlier that neurosurgery is a teamwork, and perhaps the most important component of the neurosurgery element is the neuroanesthesia. We are lucky to have the consultants with us. So he is Professor Devendra Gupta sir. He is the head of the neuroanesthesia team. Dr. Ashish Kannozia, Dr. Prateek, he is assistant professor. Dr. Ashish is adjunct professor, and Dr. Aarti, for this case, she is the senior resident in neuroanesthesia. The macroscopic surgery shall be moderated by me, and the endoscopic surgery shall be moderated by Dr. Ravi. Back to you, sir.
Anand, we hope that during the discussion,
Yes,
if
sir.
delegates and faculties are having any issues related to the anesthesia part, that will be addressed that very point of time.
Yes, sir. So when I think when Dilip Panikkar sir comes back, then we will have a short discussion regarding the position and the role of anesthesia, because we are keeping intra monitoring also for this case. So how do they manage that? Those things shall be discussed when Dilip Panikkar sir comes back.
Okay, thank you, Dr. Anand.
Okay, sir. Okay, sir.
And With this, I'll take your permission, Ashutosh. I think I have covered briefly about the program what we are going.
देवेंद्र सर, जब दिलीप पानकर सर आएंगे तो आपको ब्रीफ बताना होगा कि जो इंट्रा मॉनिटरिंग कर रहे हैं उसके लिए क्या करते हैं आप लोग।
Thank you, sir, for sharing with us the brief of the events that are going to happen during today and the next 3 days. I think we can proceed with our case presentations. And, the first case will be presented by Dr. Shreyas Rai.
ये अभी
He is our
इसको बंद कर दिया ना,
third
नहीं आ
year.
रहा।
So let us begin with our the presentation of our first case. It will be presented by Dr. Shreyas Rai. He is our third year resident, soon going to pass, and he'll be presenting a case of fifth nerve schwannoma that will be posted as first case. AV team, we're just loading the presentation. We'll be having two cases. One will be operated endoscopically, and another case will be using an exoscope that will give us 3D images. And this screen has been specially made for that, and we'll be providing you the specs for that. And hope you will all enjoy, because of course viewing the 3D, it's always like it gives a direct perspective, the depth perception that actually helps when we are actually operating on these cases.
Dear Ashutosh, this is Kuntal from here.
Sir.
The presentation is going to come soon. In the meantime, maybe Suresh can go ahead and present the case. Hopefully he has the information with him. The slide is coming up soon.
So, starting with the first case, that will be for the live surgery demonstration, exoscopic. Our patient is an 11-year-old female who presented with complaints of right frontal headache for 1 year, numbness over the right forehead for 5 months, and numbness over the, okay, the presentation has come up. Yeah. So our patient is an 11-year-old girl who presented with chief complaints of right frontal headache for 1 year, numbness over the right forehead for 5 months, and diminution of vision in right eye for 3 months, along with proptosis of right eye for 2 months. There are no known comorbidities. Briefly, the examination, patient is conscious, oriented to time, place, and person. Higher mental functions were intact. Right eye abaxial proptosis was present. Visual acuity on the right side was 6/6. On the left side, it was finger counting at 2 meters. There were no field cuts. Fundus on the right side was suggestive of primary optic atrophy. On the left side was normal. Pupil examination on the right side revealed 3.5 mm pupil reacting to light, and on the left side revealed 2.5 mm reacting to light. On external ocular movements examination, third nerve paresis was noted. Right direct and consensual corneal reflex were impaired. Sensory loss of 20 to 30% to all modalities in ophthalmic distribution was noted, and motor weakness of the right temporalis, masseter, and pterygoids was noted. Rest of the examination was within normal limits. Proceeding with the radiology, the patient underwent a non-contrast CT head, and it shows a well-defined extradural lesion, which is predominantly hyperdense with areas of hypodensity posteriorly, of size 5 into 4 centimeter, which is based in the right middle cranial fossa. And we can see that the lesion is extending posteriorly to erode the petrous apex. Medially, it is abutting the cavernous sinus. Anteriorly, it is going into the right orbit. And laterally, it is displacing the temporal lobe. The contrast CT shows that there is heterogeneous contrast enhancement with non-enhancing areas posteriorly. The patient underwent a MRI brain, and the T1 weighted MRI axial images show that the lesion is predominantly iso-intense with areas of hypointensity within. We can see the right-sided proptosis here, and the T2 axial images reveal that the posterior hypointense areas on T1 images are hyperintense here with the solid component anteriorly. The muscle cone in the right orbit can be seen to be displaced medially, and we can also see that the cavernous ICA on the right side has decreased lumen as compared to the left side. So the contrast MRI brain axial images show that the lesion has heterogeneous contrast enhancement with non-enhancing areas within. Superiorly, the lesion is reaching up till the midbrain and occupying the right crural system. Inferiorly, it is reaching up till the temporal base and can also be seen to indent the roof of the maxillary sinus. The cavernous sinus here shows that the right ICA is not visualized here. Since the supraclinoid ICA was not visualized on the MR films, we got a DSA done. The lateral DSA film on the non-tumor side shows the filling of the ICA well, along with the anterior cerebral artery, the pericallosal, the callosomarginal, and the distal ACAs, along with the M2, M3, and M4 distal cortical branches. While on the right side, that is the tumor side, this is the common carotid artery run, and we can see that the external carotid artery is well visualized. This is the internal maxillary artery, and the superficial temporal arteries are well visualized, but the supraclinoid ICA and the anterior cerebral artery and the middle cerebral artery are not visualized. The tumor blush can be seen supplied by the branches of the ECA. We can also see the tumor blush here. On the left ICA run here, we can see that the middle cerebral artery and the anterior cerebral artery on the left side, as well as on the right side, is supplied by this left ICA injection through the anterior communicating artery, suggesting cross flow. So, a diagnosis of right trigeminal schwannoma with right intraorbital extension was confirmed clinically and radiologically. And now, I would like to call upon his stage Dr. Dilip Panikal to discuss the plan for the patient.
Did you say the vision was normal on that? Vision was normal on the right side?
No, vision on the right side was finger counting at 2 meters, so it was decreased significantly.
Okay. Thank you, Shreyash. And thank you to Arun, Kuntal, and Avdesh and the entire team for inviting me over. It's a pleasure to be back here. This is the third time I'm being asked to be. I'm having the privilege of coming and operating at this wonderful institute. And it's good to see so many old friends again. So I think you have heard the case presentation as discussed by Shreyas. Can you leave the radiology on the screen? I can change it from here. Okay. So it's a very interesting case, challenging in many ways. ठीक है. That's fine. It's a young girl with a large, what is evidently a trigeminal schwannoma that is occupying the whole Meckel's cave and extending anteriorly into the orbit through the superior orbital fissure. There is no other extension into the posterior fossa. The tumor is not extending otherwise outside the calvarium, outside the cranial cavity through the through any of the other foramina. So looks like largely the ophthalmic division is involved. The Gasserian ganglion, the Meckel's cave, Gasserian ganglion, and extending anteriorly through the superior orbital fissure. It's a fairly large tumor with a lot of bone remodeling and pressure changes around the tumor. From the point of view of the schwannoma, nothing very unusual. What is unusual here is the fact that it has compromised the internal carotid artery, which is a little unusual for a tumor like this. The IC is fairly resistant to compression, and the schwannoma, being a fairly soft tumor, generally does not obliterate the internal carotid artery. However, being a small child, being a young child, the caliber of the artery is probably not enough. I mean, that's my guess on this. The caliber is not, the wall is not strong enough to withstand the compression of the tumor growing within the confines of within the dural confines of the Meckel's cave. And that's why the artery is possibly compressed. The visual involvement is of the optic nerve, and the third nerve paresis could be explained by the tumor extending into the orbit through the superior orbital fissure. So the plan for this surgery, the approach would be a classic middle fossa approach, where we would do a frontotemporal craniotomy, drill off the sphenoid wings, the greater and the lesser sphenoid wing, to expose the entire skull base. The lesser wing, we will drill and chase it into and take out the anterior clinoid extradurally and unroof the optic nerve. So the entire optic canal should be unroofed. This will allow us to expose the entire superior orbital fissure, and the next step will be to open the superior orbital fissure and peel the dura back, separate the dural layers, the classic interdural approach to the Meckel's cave and the trigeminal ganglion. So this should expose the lesion for us. And we expect to find the splayed branches, the splayed fascicles of the trigeminal nerve, through which we can enter the tumor and decompress it. This, if all goes as expected, should be an entirely extradural surgery. There should be no need to electively open the dura, though there may be some inadvertent dural openings here and there. But otherwise, it should be predominantly an extradural surgery. Removing the greater wing of sphenoid will also access the lateral orbit, and through the superior orbital fissure, we should be able to access the tumor that is extending into the orbit. So this is the plan. The internal carotid artery, I expect, will be compressed and towards the medial side of the tumor. And we will try to use ICG to visualize flow within the ICA as we decompress the tumor and approach the ICA there. A good tool to have here would be the microvascular Doppler, that would allow us to insonate the ICA as we are approaching it. These tumors are generally not very vascular, so I don't anticipate heavy blood loss. However, there are one or two small arteries that will feed the tumor, which come directly from the cavernous segment of the internal carotid artery, which may give us some arterial bleeding. The cavernous sinus itself would be, I expect, will be compressed, and getting into this tumor, we may encounter a little bit of venous bleeding from the collaterals around the sinus as they drain into the parapharynx, into the venous plexus at the skull base, the infratemporal fossa plexus. And, but apart from that, it should not be a very vascular lesion. The reconstruction, once a tumor is removed, we will end up with a sizable cavity. It is usual to plug fat into the cavity. However, she's a young girl and doesn't have much of subcutaneous fat that we can harvest. So what we intend to do is to turn the posterior part of the temporalis with a galeal flap attached down into the cavity to reinforce the repair. So this is our plan, and hopefully we should be able to execute this. Open to questions.
Thank you. Would you just also explain whether you need to have any sort of, modification of the flap, like frontozygomatic approach or things like that?
Yeah.
And secondly, the position of the patient also to some extent, which will be very important.
So I was going to talk about the position when I get into theater, but but in this, the patient is supine. I generally turn the head at a 30-degree angle. Head is elevated above the heart level and fixed on pins. I give a bit of lateral flexion so that to drop the head and to make the surface of the head parallel to the ground. So that is my position for this. I always use a strip shaving, so a limited incision. And my use of the orbitozygomatic approach has drastically come down over time. I used to use it a lot, but I find myself not requiring to use the orbitozygomatic. The more you drill the skull base, the more bone you remove from the sphenoid wings and the middle fossa base, it allows you this beautiful access into the entire skull base. What adds on the value of the orbitozygomatic osteotomy comes when you have a very high riding tumor, where the trajectory of vision has to be upwards. And that is when the OZ has got a definite advantage. Otherwise, sometimes in an adult male, the temporalis itself can be quite bulky, and when you pull the temporalis down, it forms a big heap over the zygoma, and that can compromise your vision into the middle fossa. So in those cases, a limited zygomatic osteotomy alone will help to drop the temporalis further and improve the trajectory of vision into the middle cranial fossa. So I think for this, just a standard craniotomy with extensive drilling of the skull base.
The second thing is that whether the carotid arteries are occluded, involved, or they're just compressed. How can we make out preoperatively? Is that possible?
Since we are not visualizing the carotid artery, it is difficult to make out. But then in a trigeminal schwannoma, I don't expect the carotid artery to be involved or invaded in any way. Unlike a meningioma, which can sort of grow circumferentially around the artery and squeeze it, the trigeminal schwannoma per se in the Meckel's cave displaces the artery medially, and that is why I suspect the artery is getting kinked as it enters through the laceral segment into the cavernous sinus, and that is where it is getting blocked. So it's very likely that as we decompress the tumor, we'll start getting retrograde flow down into that segment, both retrograde and antegrade flow into the segment. And that, if we are able to identify where the IC is, we'll try the ICG and see whether we can demonstrate flow through.
I always sit down with the radiologist and breathe through the shoulder to come to the diagnosis, and that's my habit. I mean, and I enjoy that. I learn more from the radiologist. I love them, and they're part of my team, obviously. For any, even a small case, I discuss with them. Have they only put the diagnosis as schwannoma in this? The local radiologists, have they put the diagnosis schwannoma in this, or anything? What, any DD they have put, or they have just pinned on to schwannoma in this particular case? Unlikely, most likely schwannoma. Anything unlikely they have committed? No. Okay.
I mean, the oddball ones are always going to be there. But young child with a schwannoma, my only concern is the age. At 11 years to have
Yes,
a
so
large schwannoma like this.
Any feature of NF? That was my next
That
question.
is the question. Even if she does not have any features of NF now, she needs to be followed up long because she can throw up tumors, other tumors down the line.
So we should consider NF. Right. Right. So they have not. Has this been also worked up in that same fashion? No. I think yes. Yes. Thank you. Yeah. As it was told, that things might come up later on, so manifestation might be different.
Sir, how do you work out, like, because such big tumors, the moment you open, remove the bone flap, there will be a good amount of bulge. So apart from the anesthesia things like hyperventilation and keeping the head a little bit higher side, what other things that can be done to like?
Yeah. See, first of all, I think what you said is true. The anesthetists are you have to keep your anesthetist happy. You cannot have your anesthetist being upset with the operating surgeon because they can make life hell for you. But having said that, this is a kind of tumor, even though it looks large, I don't really expect the brain to swell or the dura to be tense when we open up. Because if you see, one, it is a tumor that's confined to outside the primary dura. It is not in the intradural space. Secondly, if you look at the adjacent brain, there is no edema whatsoever. So your brain itself has not reacted to the presence of the tumor because it's barricaded. It's outside the confines. So you will have the CSF flat. What I sometimes do in this, even though the surgery is primarily extradural, if I find that the dura is full and I find the peel back a little difficult, what makes sense is to do a limited opening of the dura along the sylvian fissure, just open the arachnoid, put a patty inside and keep a suction on it. So that will allow CSF to drain and will relax the brain a little bit and allow you to work.
Anybody has any questions, please?
Dr. Panikkar, any differential diagnosis in this case? There is unusual thing that for a schwannoma, there is blockage of a vessel, major vessel.
That's exactly what I said. See, from the history and the progression, it does not look like it's an ominous tumor. It does not look like an aggressive disease. See, the girl herself is very comfortable. There's no pain. There are no other features except for this bit of proptosis, the V1 distribution, the localized headache. It's all confined to the trigeminal. Now, if we were thinking of a more aggressive lesion like a malignancy at this level, yes, I mean theoretically it is possible, but clinically it does not fit in. She does not have any of the features. Those would be they would be a lot more symptomatic with that, with a tumor in this size. So that is why I would still consider schwannoma as a primary diagnosis. It is very unusual for a schwannoma in this location to transform into an MPNST, but they generally don't. So even though the size is large, they are not aggressive tumors.
A meningioma?
Unlikely to be a meningioma. I mean, you can think of it, but then as a remote differential diagnosis, but the pattern of a meningioma is different. the pattern is different. By now, the meningioma in this size, it would have become intradural. It would have even the extension into the orbit, the enhancement would be more homogeneous there. So I don't think it will be a meningioma.
I think Dr. Panikkar would gives the idea, the feel while he's operating, what he feels the
Yes.
tumor to be. And then, of course, we have to wait for the pathologist to give you the final answer. I would request, please give us the feedback about the pathological report in this case. That will be very interesting. As I say, a neurosurgeon is like Draupadi. You have no existence. Your first husband is the anesthetist. This first is the radiologist. The second is the anesthetist. Third is the pathologist. Fourth is the endocrinologist. And the fifth is the radiotherapist. So we survive on their shoulders.
Sir, one question regarding like initial workup of these patients. How the findings of digital subtraction angiography may change your approach towards these cases?
Actually, it won't. It won't. In fact, rather than doing a DSA, very often if you do an MR angiography in this, you will see that occluded segment of the thing, and you will demonstrate distal flow in the vessels. The fact that your approach and strategy is essentially going to remain the same, even if you demonstrate an occlusion of the ICA. And like I said, if you hypothesize, the only reason, generally a schwannoma like this does not block the ICA. In fact, even in a meningioma, for the ICA to get completely occluded is extremely unusual. It can be narrowed, it can be, the caliber will be low, but it generally does not get occluded. So the reason why I think we are seeing an occlusion, and I don't think it's a true occlusion. It's probably such a low flow that it's not picking up. The second thing is, I think because it's getting kinked by the tumor. Being a young child, I think the artery, the caliber of the artery is not enough, the wall thickness of the artery is not enough to withstand a compression. So that's why she's more vulnerable to a compression. I mean, that's my gut feeling. Just my hypothesis. Ashish, you have any thoughts on that?
The only thing in that case, in these situations, I always ask my vascular surgeon to be ready for any eventuality. Even it's involved or not involved, because it's impinging on the artery or it's partially going to the wall of the artery. If it's invaded, of course, preoperatively, I would ask my vascular surgeon to be on the standby to help me out. Let me tell you, I'm not a saint. I have made mistakes in life. I've injured carotid artery twice. One survived, one did not survive. So that happens.
Sir, I think when we are like wandering on these areas, the biggest fear that for us, it's like going and hitting the ICA. So probably that is the thing that we should be ready for it. Do we have any question from our audience?
Yeah. Sir, one question. Such a large tumor and going into the superior orbital fissure, so any plan to save fourth and sixth now, like any surgical plan to?
I don't think the nerves would be really involved. See, the third and the fourth would probably be pushed superiorly over the dome of the tumor. And I don't think, see, in a tumor like this, we'll essentially be working within the confines of the tumor. The nerves will still be outside the dural barrier. So chance that we will encounter the nerves physically are low. So that is why even the role of neuromonitoring in this for the nerves, I'm very doubtful about how effective neuromonitoring is in really picking up the function, especially with the partial paresis like this. So so this is a situation where we have neuromonitoring available, but I will not rely on neuromonitoring to track the nerves. See, this is largely going to be anatomical dissection. So you're going to go from one anatomy to the other. And as you identify the structures, you open the superior orbital fissure, see the lateral wall, you know when you take the clinoid, you know where the third nerve is coming in, fourth nerve is just below that, V1 goes towards that, then you have the V2 and V3 below. So it's your anatomical knowledge in that area that gives you, even though it's distorted, you still have that orientation, and that tells you where you are.
Okay, thank you. Any more questions? Sir, one more thing. As such, in this case, we don't plan to open the dura, but of course, there will be some if there is some minor opening somewhere. So, like how we are dealing with that, or are we considering like what is the role of lumbar drain in these cases to prevent like post-op CSF leaks? And
I don't think lumbar drain has a great role in this. Like I said, if you think the dura is full and difficult to handle, a controlled dural opening is much easier to relax the dura and which you can close, which you can repair later. Inadvertent dural openings may be there, so that is why if you have fat available, you pack the cavity with fat, and that generally will seal many of these small leaks. Larger leaks, larger dural rents, identify and repair them directly. In this case, since I don't think we will get that much of fat from her, subcutaneous fat, so that's why I'm considering the posterior temporalis with a galeal flap attached. So we can just pedicle the whole thing and turn it into the cavity.
one more, I think we can take one more question. Anyone? Sir.
First thing, what Pathak sir has said about the differential diagnosis, and I must like to have our junior faculty and resident to give some input. And I will second for the cavernous hemangioma in this case, anyone who wants to be with me for this very differential diagnosis, the first differential diagnosis in this case, considering the age, considering the enhancement pattern. Anybody else wants to support me? I'm all alone. Yeah, so it's straightforward looking like something which is going in the direction of some nerve course. And it's occupying mainly the Michel's cave as explained by the sir. Sir, I want to know one thing, that we understand this very important portion of this surgery is going to be the displacement of the ICA coming from the lateral segment and then through petrolingual ligament going into the cavernous sinus. In our experience, we have seen the neurofibroma or this kind of nerve sheath tumor, they kind of erode the petrous bone. And then the position of ICA, what we know through the neuroanatomy, is changed. And the second thing is, as you already said, it's most of the time displaced and compressed, not the adventitia encircling involved and causing, morbid problem with these kind of cases. So when you are proceeding, how you are going to ensure to have safety as far as the petrous part of the ICA is concerned?
I think that is where the role of the microvascular Doppler comes in. Because as you're working towards a tumor, now if you have a combination of, a lot of this is anatomically based. As you reach the medial wall, you know you'll be approaching the ICA. There, if you have navigation available, you can also track the ICA as it transits from the petrous segment into the cavernous segment. It's a fixed point, so it's really not going to move. You can see it on the navigation. It is not going to get displaced, so you can identify that. Otherwise, I think the best tool is a Doppler for these, because you can always insonate a little ahead, and you will know approximately. It's like in the endonasal surgery. It gives you a clue as to where it is. The moment you know where it is, in your mind, you're forming a map as to where to find the ICA. Ashish?
Yeah, I think this is a neurofibroma, surely. It's not a cavernous. It may not be infrasurprise because going into the cavernous, it's going into the orbit actually.
Yeah.
I've not seen the T2. I'm sorry, I was roaming around the whole of Lucknow before I reached here. They took me by mistake to. So if you see, this is T2. It's very heterogeneous, maybe a Antony B type of a schwannoma. And can we go back to the contrast again? So it is surely a schwannoma. And this is, ICA should not be a problem in the schwannomas. You very rightly said, this is more of an interdural tumor. It's not a purely cavernous. Had it been a cavernous hemangioma, yes, I would have been very skeptical that why has it been put for an operative workshop, because by the time the symposium would have ended in the evening, by the time we got free. And second, I would like to have a microscope rather than an exoscope for a cavernous hemangioma of the cavernous sinus, because you're actually playing around with the ICA in that. And then you have the sixth nerve and the sympathetic plexus. There, the Doppler is mandatory. Here, the Doppler can be an adjunct, but most of the time you don't need it, as long as you are remaining within the tumor margins and the tumor is very well defined. The only place where the definition goes is where the petrous apex is there. But yes, it is eroding the petrous apex. We have the CT.
We have CT.
There's a CT somewhere.
CT, yes, sir.
Yeah, there.
Yeah, if you see the petrous apex is eroded, if you see on the left side, but yes, the boundaries of the petrous, still the dura is maintained. So it's not, there's no posterior fossa extension. So I think it will be a purely intradural tumor. We'll need some dissection at the anterior aspect. The anterior aspect I find will be slightly much more, which in your hands will be remarkable. So I think, good.
Let's see.
So
Okay.
the conflict of interest with sir's comment with Antonio B was because the better half of Suri sir is pathologist, and that is why he was able to comment upon the pathology as well. So we should not get carried with that. So I think for all the young faculty and the residents here, it's a very good learning with all these mentors of mentor, that how to approach a lesion, keeping neuroanatomy as a base and conceptualizing what I have learned from Suri sir. In your brain, a 3D, 4D, 5D, whatever is possible, you should be seeing the tumor along with the distorted anatomy. And that is what I think Panikkar sir is trying to explain, that how and why he is going to adjunct like Doppler, navigation if required, and that is what makes the skull base safer with our theme, what we are trying to project today. Thank you, sir.
Thank you.
Thank you, sir. We will keep on hitting questions on you. And Suri sir has rightly demonstrated why it is important to read the radiology preoperatively and do the dissection in mind before going into the OT. Now we'll move to our next presentation. It will be presented by Dr. Vipin. Vipin is also our third year. He has just given his theory exams.
Good morning, everyone. Today I am presenting the first endoscopic case of today's live workshop. This is a 36-year-old female without any comorbidities. She presented to us with chief complaints of bilateral frontal progressive headache for last 1 year and diminution of vision from both eyes with bilateral temporal field cut for last 3 months. And there is no history suggestive of any endocrinopathies. On examination, the pupils are bilateral 2.5 mm reacting to light, and visual acuity is bilateral 6/12 without any pinhole correction with spectacles. And the patient is having bilateral temporal field cut, and extraocular movements are bilateral full range with fundus is bilateral temporal pallor is present, and the rest of the cranial nerves are normal. So this is the T1 weighted axial images of the patient. Showing a single well-defined lesion present in the sella and suprasellar region. On T1 weighted images, the lesion is iso-intense on T1, and anterior part of the lesion is showing some hyperintensity. On T2 weighted images, the lesion is again showing some heterogeneous intensities, like with the areas of hyperintensity and iso-intensity. On T2 sagittal images, the lesion is causing expansion of the sellar floor, and superiorly it is extending and obliterating the anterior recess of the third ventricle. And on coronal T2 weighted images, the lesion is closely abutting the bilateral carotids. On contrast imaging, the lesion is showing contrast enhancement with some anterior part that is showing non-uptake of the contrast. And this is the CT-PNS of the same patient. This is the axial CT-PNS. In this, we can see that the nasal septum is in the midline. And on coronal CT-PNS, we can appreciate that the sphenoid septum is in the midline, and there is no pneumatization of the clinoids.
Can I stop you here? Can you give some endocrine history in this patient?
Sir,
you have not mentioned anything. You have not mentioned anything about that.
Sir, no history of any endocrinopathy, sir.
So you should mention that.
Yes, sir.
Carry on.
This is the sagittal CTPNS in this, we can see that there is a sphenoid sinuses of the pre-cellular type and there is thinning of the cellular floor. So a diagnosis of non-functional pituitary microadenoma, Wilson-Hardy grade 2C and bilateral NOSP 1 was made. And I would like to call upon Dr. Ashish Suri to further comment on radiology and discuss the plans.
Yeah, this is a standard pituitary adenoma and bilateral NOS1. There's no cavernous sinus extension, a standard. How do I do it? How do I forward this? Let's see. ठीक आ गया. So it's a cellular supracellular pituitary adenoma. Planning a binostril, a two nostril, forehand approach, endoscopic approach. Well, any questions? The patient already has been positioned. So standard positioning is in, I use the 3-pin. It makes the head more stable. I know HPGI uses a head ring because that was a question which was asked to me, but I use a 3-pin. It's much, I feel it's more comfortable for the surgeon and the patient's head is not moving. And second is that and nothing against the anesthetist, but off and on we see 1 in 100 case, probably probably more than that, maybe 1 in a 20 case, the patient becomes light during surgery, and when you have your endoscope in a critical area, that's the last thing I want it to be light, the patient to be light. So there, I've seen that the 3-pin helps there, and this is what I've learned from my teachers, Fred Gentili, who's no more, and Martin Bittag. And maybe initially just pack the nostrils with some ADR soap cotton, and then it's a first the bigger size nostril first, that is the usual dictum, and then the other side. Take off, you'll see the steps. The steps will include first a very small posterior septostomy. So, and this type of tumor, there's no controversy. You can do it with a microscope, you can do it with an endoscope, you can do with an endoscope uninostril, you can do it with a binostril. But what my aim is in these tumors is that you should do complete excision of the tumor. You should, if you can see the normal pituitary gland, you should preserve the pituitary gland. Where can you leave this tumor would be at the top and especially in the front. But in my experience, because I was trained completely into microscopic TNTS by my teachers, Dr. Banerjee and Dr. Mehta, and I used to do these tumors practically with the microscope, sublabial, endonasal, in 25-minute stats. So I could do all 4 of them today. But yes, I changed completely over the last 12 years to completely endoscopy, because I found that in these tumors, the visualization is better. My extent of removal is better. Then a CSF leak was always a problem in a microscopic TNTS, here you can actually, CSF leak is not a problem. Sometimes you need a CSF leak so that your the frontal portion comes out, the 12 o'clock portion comes out. So, and then you can easily manage it. Regarding the post-operative, it is if you see, it's a large tumor. And I always would like to pack the cella. Had it been smaller, I would not have mounted, just put some gel foam there if there's no CSF leak. If there's CSF leak, always packing with fat. You can take it from the abdomen, from umbilical incision, or the thigh. And we discuss with the patient, so umbilical incision, because there's more fat in the abdomen, we can always use that. And why fat packing is important? To prevent a future chiasmal descent and an empty cella. That is one thing. And had it been smaller, a microadenoma, gel foam would also be. If there's a high flow leak, as a arachnoid breach, I usually put a lumbar drain, maybe 8 hours after surgery, and keep it for 3 days. That's the usual management, the standard management. And a hormone profile after 48 hours, and then 3 months, and at 6 months. Any questions before we go to the next?
Any questions from the floor?
Hello, I'm Dr. Jagat Lal from Cochin. I have 2 questions. One is, do you ever place lumbar drain pre-operatively in any situation? Second is if there's a NOS 3 or 4 kind of tumor, what is your tactics of removing the tumor in 3 or 4?
Yeah. So I have some videos. I'll go to the first question first then. The lumbar drain before surgery, never. I don't advise that. Number one, many times it may not be required to just putting in a lumbar drain. Lumbar drain, the only indication is in microscope TNTS, when I used to do a lumbar drain in big large tumors, especially the vertical extent, and I used to put because you wanted to push in something, and then let it descend. Here, with the more visualization, especially the anterior visualization, sometimes you need to remove. The second case, which you'll see, there has some subfrontal extension, where I'll be removing the tuberculum cell. This is possible in a binostril endonasal approach. So lumbar drain is only after surgery if there is CSF leak. And if there's just a couple of drops, then fat packing is enough. But if I feel that there's an arachnoid breach, I always put a lumbar drain for 3 days and keep it just above the head level. I don't want to over drain. Regarding the NOS 3 and the NOS 4, well, the main aim of surgery is to do a maximum visual cytoreduction. So because if it's a non-functional tumor, you can completely excise 3A and 3B. You can. 4, you cannot completely eradicate these tumors which are NOS4. You can maximal, in my hands, NOS4, I have been barely taken 10 to 20% of the tumors who are completely NOS4, completely. But you actually reduce the bulk so that if it is an acro or rarely a prolactinoma, among my series of Cushing's, only one was invasive. It's very rarely invasive. The medical therapy can become better. Second, even non-functional, you can give a stereotactic radius surgery. So then in that, always for NOS 3, I never take off never a Haddad flap or a nasoseptal flap. This is a standard endonasal, that's what I said. It's only the tool that is the endoscope. In the standard, microscope is equivalent. Uninostril and binostril are equivalent. But in a NOS 3, I always use a angled scope, a 30-degree or sometimes a 45-degree, especially a NOS 3B. But I do not take off the middle turbinate and I do not use a Haddad flap. NOS 4, because then I need to do a durotomy below the lateral to the ICA and connect the bridge. I have some videos I've already given. They'll be played and I can discuss them later. There I would like to do a middle turbinectomy. I've done some maybe 3 or 4 bilateral NOS 4s in which I've done a bilateral middle turbinectomy. Haddad flap is mandatory if you're doing a NOS 4 because the carotid lays bare. You cannot keep the carotid bare for life. You have to cover it with natural tissue.
Yeah, so I think we are closing to the OT time. So just I'll sum up. Lumbar drain not needed in these cases. You can do binostril or uninostril. I do all the cases uninostril because I started myself with uninostril. There was no ENT help in those days. The third thing is that you cannot remove all the tumors. So don't go after that, that enthusiasm that I'll go for every bit of it. Any variety of tumor. The NOVs 4, NOVs 3, you have to be very careful. So with this, and we stop the discussion here because they're ready in the OT.
They'll show the second case, I'll go to the OT. And the second case is similar, except I'll be drilling the tuberculum cell.
Okay, fine.
Okay, Vipin, you can present the second case. Then we'll continue with the discussions from OT.
Hello, Dr. Anand. Hello, OT.
Today's second case is a 39-year-old female, and she's a known case of hypothyroid. Presented with chief complaints of bilateral progressive frontal headache for last 3 years. And
hello, this sir, Anand this side.
So just show the position of the patient of Dr. Panikar case.
Sir. So we're just waiting for Panikar sir to come in. I think he's just changing. So just give us a couple of minutes.
Okay. Meanwhile, we will discuss the second case of for Dr.
Sure, sir. So as soon as Panikar sir comes, then I will just let you show we will show the position and the incision.
Okay. Thank you, Nand.
Okay, sir.
So second endoscopic case is a 39-year-old female, hypothyroid, and she presented with chief complaints of progressive bilateral frontal headache for last 3 years and diminution of vision from both eyes with bitemporal field cut for last 6 months. The pupils are bilateral 2.5 mm reacting to light, and visual acuity is 6/18 bilaterally without any pinhole correction, and there is a presence of bilateral temporal field cut, and extraocular movements are bilateral full range. The fundus is bilateral normal, and rest of the cranial nerves are within the normal range. This is the T2 axial scan of the same patient showing a single well-defined cellular supracellular region, which is showing heterogeneous intensity with some areas being hyperintense and some areas being isointense on T2 weighted images. And this is the coronal section of the same patient showing that the tumor is averting the bilateral carotids. And on sagittal section, we can see that there is a the tumor is extending and causing widening of the cellular floor, and it is causing, superiorly it is causing obliteration of the anterior recess of the third ventricle. The tumor is showing homogeneous contrast enhancement, and this is the CT-PNS of the same patient showing there is no nasal septum is in the midline, and the sphenoid septum is more towards the on the left side, and there is no pneumatization of the clinoids and on the sagittal section the cellular floor is thinned out, and the sphenoid sinus is of the cellular type. So diagnosis of non-functional pituitary macroadenoma, Wilson-Hardy grade 2C, and bilateral NOSP is there. Thank you.
Right, it's straight cut pituitary tumor. Any questions from anybody? Just quick if they want to ask. Okay, if there are none, then obviously we'll wait for the OT people to contact us. In this particular case, what was the hormone profile so far as the prolactin and other things? They were all normal?
Sir, the free T4 was within lower side, so we have started Thyronorm, sir, 75 micrograms, and now it has come to normal, sir, within the normal.
And prolactin?
Prolactin is normal, sir.
Yeah. In this case, you can have something like a stalk effect. So the prolactin might be slightly raised, but not to the level to be called as a prolactinoma. So you have to be careful sometimes. And many times we find people referring to us that patient has got high prolactin levels, but that's probably just a stalk effect. So we must remember that and should not be carried away with that intention.
So one question is, how do you deal with arachnoid bulge during the pituitary surgery? When you know that there is a residual tumor above the diaphragm and there's a big bulge.
Yeah. There is a way of removing these tumors. When you remove the tumor, you straight away don't go to the anterior part and the superior part straight away. So first thing, you go along the floor, you remove the lower part of the tumor, and then you go to the posterior part of the tumor, which has got advantage, because what is going to happen with the pulsation of the brain, the remainder of the tumor, which is the anterior part and the superior part, will fall in your field and help you in removing the tumor. So the arachnoid bulge should happen last, because you have not really gone to the front and the top first, because where the anterior bulge of the arachnoid actually clouds your vision and comes in the way of the tumor removal. So there are segment-wise steps to remove this sort of tumor. So first the floor and the sides, and then to the back part of it, and then when the rest of the tumors, the front and the top part falls, they automatically get removed, and the bulge which comes at the end when you have removed almost all of the tumor or most of the tumor. So that's the way to remove it. And you can also use a little bit of retraction with your... Yeah, so we will talk about that later. Yeah.
Hello.
Yes.
I'm Dr. on this side. So we just, Ashish, the skin incision is being telecasted there. So can you see the skin incision and the position of the patient? So I will just hand over the mic to Professor Dilip Panikar, sir. So he will explain the position and the incision.
Yeah.
Hello? Yes, now you can see.
Okay, can you hear me?
Yes, Dilip.
Excellent, thank you. So, as we described, the patient is supine, head tilted to the left around 30 degrees, extended, laterally tilted, laterally flexed. So this brings this whole surface flat. The malar eminence, as expected, becomes the highest point in the field. Head is elevated above the heart level. So these are standard positioning techniques. The incision that I have marked here is a question mark starting from just pretragal and going up here. You can do this with a smaller incision, but I prefer this because this incision disappears into the hair and does not show later. The more anterior incision you take, it will show up later. So for cosmetic reasons, it's always good to take a slightly larger incision heading backwards. Also, this incision here, extending it here, allows us to take the posterior pedicle of the temporalis and the galeal flap from here, which we can use to turn down into the cavity at the end.
I think that's very important because a coronal incision can also be used where somebody might use it. But as you said, the temporalis muscle might be of help to us in sort of packing the space. So this incision is appropriate. Can you show the picture from the head end of the patient to show the tilt and rotation of the
yes,
head?
sir.
Yes.
ये camera इधर ले लीजिए.
So we are seeing from the side, but to see the amount of tilt just extreme, go to the 12 o'clock position of the head. 12 o'clock.
थोड़ा और इधर हटाओ.
This is not 12 o'clock.
हाथ में ले लो.
अरे इसको इधर ले लो यार.
Yeah. So is that better? You can see this?
Yes, yes.
Yeah, the rotation, lateral tilt and the extension.
Yes. So that the brain tends to fall off.
Yeah.
And get out of the way of it.
Absolutely.
Yeah, that's great.
So what we have here are the monitoring electrodes placed for the 3rd, 4th and 6th nerves.
Yes.
And we have the BIS probe here.
Yes.
From the anesthesia team.
Yeah.
Okay, so essentially this completes the positioning and the exposure. This is your navigation tracker that's mounted, that's attached to the frame.
Great.
And essentially we have a go with this.
Sir, Anand this side. I would just request Professor Devendra Gupta, the head of neuroanesthesia, to just briefly describe about the anesthesia implications of the case.
Good morning, everyone. I'm Dr. Devendra Gupta. I'm professor in anesthesia. So this is since this is a 11-year female with a 31 kg body weight and the large tumor. So we are expecting a good amount of the bleeding as well as the prolonged surgery. So we counsel these patients in the preoperative area about the prolonged the post-op ventilation and as well as intraoperative monitoring because we have planned this patient for the intraop monitoring. So we induce the patient in the routine way like propofol and atracurium muscle relaxant and the fentanyl, which is opiate. Followed by we have planned not to give any muscle relaxant because we are doing the neurophysiological monitoring and we will maintain this patient on total intravenous anesthesia. And we are trying to maintain based upon the BIS values and the neuromuscular monitoring. And so that the neurophysiological monitoring will, our agent will not interfere into the neurophysiological monitoring. So this is all we planned and we have kept a good amount of the blood product ready to manage all the blood losses and as rest of the things is the same as in other cases.
Thank you. What about the osmotic diuretic and the carbon dioxide level that you're planning to maintain in this particular case?
As a routine, we will give the mannitol as soon as the skin incision will start, and the CO2 level, PCO2 will be between 35 to 40.
So normocarbia, basically.
No.
That's great. Thank you very much. Yes, so just about the incision, as you can see, it's a general trend for us to shave all the head. That's a bygone thing actually. We don't need to shave the head. In fact, there are papers which show that if you shave the head, the chance of infection are more. If you don't shave the head, do limited shaving, the chance of infection less. So you can refer to this paper. And it's not now. It's some 20 years ago they have been published. Because the hair itself acts as a sort of static agent which attracts all the germs and doesn't allow the things to go in. So there is an advantage of not shaving the head also. So you have to be careful about that.
Sir, I would just like to thank the Ascolab and for bringing this 3D exoscope. That is the Ascolab AOS, and also I would like to thank the EasyNav, that is the HRS company, for providing us with the navigation machine that we shall be using in this case.
Okay, great.
Thank you, sir.
Do you have any picture of what's going on in the other operation theatre?
Mark, just give me a wipe, I'll mark the incision.
Spirit or needle incision mark?
So basically the fundamental principle of the positioning is that you should allow the brain to fall. You should make the tumor the most at the highest point, and the rest of the things will automatically fall and give way to you. And then you should have an access where you don't have to virtually retract the brain. So that's very important in this case. Yeah.
I think I'll just mark that.
Any questions at this stage from anybody on the floor?
Hello. Hello.
Yes, yes.
So this is Dr. Ravi from OT4.
Yeah.
Yes.
So that pituitary patient got prepared. Patient was positioned, and
that's
we are waiting for the sir. And
needle.
we want to discuss about the CT or MRI.
I think the CT has already been discussed here, and we are now ready to see the positioning.
Yes. Wait. Hello. Hello.
Yes, yes.
Are you able to see the image of the patient? The positioning of the patient?
This is from OT4? No, it's not on the screen here. Yes, now we can see. Yes.
So the head was fixed. We are using a navigation system from the Medtronic. That's why we have fixed the head, and we can see the head end of the head end was elevated 15 to 30 degree, and head was tilted towards the left, and head turned slightly towards the right side, and it was kept neutral position.
Right.
And we prepared the abdomen for the fat.
Right.
And as well the nose and the adjoining area also prepared. We are going to drape, and we are using the STORE's 4K system and S8 Medtronic navigation system. Medtronic's IPC debrider, and also using the Dopplers.
Right.
So we are primarily we are decongested with using the oxymetazoline 0.1%.
What is the blood pressure being maintained by the anesthetist in this particular case? What is the blood pressure and the PCO2 levels being maintained by the anesthetist here in this case?
So currently they are maintaining at 100/72, sir.
Right. What is the baseline blood pressure of this patient?
Baseline? 110/70, sir.
Right. So at the moment it's 100. So what's the plan during the surgery? Any control of the blood pressure is needed or planned, anything like that?
Sir, we are trying to maintain the blood pressure same level, 170.
Right. Okay.
We are distributing 3D specs. Kindly keep it with you. And while while going, you can return it at the registration counter. We'll be switching in between from 2D to 3D. There will be like 30 seconds change in the screen. Then you can put on the glasses whenever it is 3D.
one.
What is the pack given in the nose now in OT4? Any communication from OT4?
Hello.
What's the pack given in the nose now?
Sir, xylometazoline 0.1%, sir.
Xylometazoline 0.1%. If xylometazoline is not available, what's the substitute?
Sir, we can use then diluted adrenaline.
Yes.
Yes.
So 1 ampule in 100 ml?
Yes, sir. Yes, sir. 1 in 1 lakh usually.
Yes.
Sir, sometimes we prefer 1 in 2 lakh also.
Yes.
While we are prepping the patient there, if anyone wants to ask any question, we have Professor Ashish Pathak sir and Jaiswal sir. They can answer your questions.
Yeah. Can I ask a simple question for the trigeminal case? Dr. Pathak sir? Yeah. Seeing the actual position of that tumor, is that possible that we can enter via nasal route to remove that one?
Nasoendoscopy. A good question. We can definitely enter by the nasal route and you can reach this tumor. The question here is, as we have discussed, the carotid artery might be compressed, the nerves might be displaced, and by entering by the nasal route, you won't get enough space to really play around the lesion to identify the structures and get a good dissection and separate them from the adhesion to these important structures here. So that's the main challenge which is going to be. But reaching the tumor and debulking it by the nasal route, yes, it's possible. Secondly, the extension into the orbit, have you seen it's more laterally, so you won't be able to reach that by the nasal route. So there are a lot of compromise in the access and the space for getting the tumor excision, because this is supposed to be and thought to be a benign tumor, as it should turn out to be. In that case, the main aim would be to go for a near total, if not a total resection, unless it is badly stuck to some important structures.
So nasal route might be a compromise in this case, access-wise.
Dr. Vinod, this is basically a surgeon preference. Yes, this tumor can very well removed by nasal route. Not only the middle fossa component as well as orbital tumor also, but it does require some amount of experience, and definitely there is some limitation. The maneuverability of instruments, the hemostasis, the control over the tumor, that's the issue. But yes, it can be done. Of course, the control over the tumor will be much better and transcranial route. And but operating this tumor by nasal route requires a learning curve.
Any more questions? One thing about endoscopy, I must tell you, those who want to start endoscopy, please have good experience of doing it by open procedures first. Because if you land into problems, then it needs immediate conversion to open access. And in that situation, if you're not trained in open access and you start endoscopy as the first thing in your life, that will definitely compromise or jeopardize any problems or handling of any problems. So even if you're doing, these difficult accesses through endoscope, you need to also have good experience of doing it by open procedure with microscope. So that's very important. Otherwise, you won't have anybody to coming to your rescue, specifically if you're in a center where you're alone. So that's very important.
If somebody really want to learn endoscopic surgery, they should know, they should master first the surgical anatomy of the area at the very first, and then after spend some time in cadaver dissection, as well as some time to the center that is high volume center for endoscopic surgery. And then start from small cases. As you get experience, then to try to some more complex cases. So learning curve, it does exist is a steep learning curve for endoscopic surgery. Without learning, if you jump up, start doing endoscopic surgery, you will not able to do it, and the procedure will be blamed as well as your name also. The result will also not be good. So you have to spend some time to learn the surgical anatomy. Then after some cadaver dissection, see some workshop, attend some workshop, and live surgery, and spend some time at a place where there is a high volume center. A lot of things are being done. Okay.
Sir, for young fellows like us, can you suggest few high volume centers where we can actually go and do some fellowships that will help us?
There are many centers in India which are doing very good endoscopic work. You can go. You can come to our institute also. We are having also large amount of cases. Otherwise, AIMS, New Delhi, and many, all government of Nimhans, AIMS, and Sri Chitra. All these places are need not to go outside. And if somebody want to do, spend some time, they can go to Pittsburgh or Will Cornell in US. There are these centers, Germany.
Do we have any more questions? You can direct questions to the operative surgeons also.
Endoscopic surgery has a great advantage over conventional neurosurgery. In fact, it has really revolutionized the conventional neurosurgery. The brain detection is minimal. The surgical approach-related morbidity is minimal. And sometimes you can see that nobody can say whether the patient has been operated or not. So it's an emerging field, and I I request that everybody should learn it. It's very much gratifying, and the results are amazing.
Sir, Surish sir had given us what are the advantages of using a 3-pin for pituitary surgery. We will also like to know what are the advantages of using a head ring.
Actually, personally, I don't use 3-pin in most of our cases. The most important thing that if you can manage the case without 3-pin, then what is the fun of using 3-pin? Will somebody like to, if you ask somebody whether you want to get operated by using 3-pin or without 3-pin, naturally everybody will say that I don't want to get operated by using 3-pin. 3-pin give, I think if you don't use 3-pin, you can change the position if you want interruptively, slightly bit tilt the patient or whatsoever. The maneuverability is less. In personally speaking, I also don't fix the head also. No strapping is also done. It gives a lot of freedom in surgery. I think you should keep it simple. The basic message is this.
Dr. Anand sir?
Any comment, Dr. Pathak sir?
Yeah, I think this 3-pin question is a bit, irrelevant in this situation. If you have got a 30-degree scope, if you've got 45-degree scope, you've got all the different angle scopes. So 3-pin or no 3-pin is irrelevant. You just change your scope, and if you whichever angle you want to see, you can do it. So whether you use a 3-pin or you want a head ring or you just don't strap the head, these are irrelevant now. It's the comfort and your system to which you are used to. That's the way you do it. Basically, because looking at different angles is no problem. You've got different angle scopes, so you don't have to tilt the head to do anything nowadays. So that's there. The advantage of 3-pin might be if you have got a large tumor with extension and you want to use navigation, as you are doing in this particular case, then you definitely have to fix the head. So that's there. But you also have navigation system without fixing the head. In my private hospital at Fortis, we have got both the systems. So you want to fix, you don't want to fix, we still can navigate the patient. So it's not mandatory. And simple straight cut tumors where, and as I said, most of the pituitary tumors which are between NOFs 2 up to NOFs 2, I would straight away use uninostril approach. I don't have the luxury of having the ENT surgeon by my side. Yes, invasive tumors, which are difficult ones, then I would call the ENT surgeon to help me out. And we have got nobody less than Professor Ashok Gupta, who was the head of the department of ENT and PGI, to help us out. So it's a luxury when he's there. But I have been groomed in such a way, at that time there was no ENT help. So I started doing all alone myself. And once you get used to something, then you learn. It's like, having a negotiation marriage, and then start with recognizing your wife and learn more about. So that's the way I've been groomed into that.
Sir, we have Dr. S.S. Dandapani sir with us. He would like to give few comments.
I think already Dr. Avdesh sir and Dr. Ashish Pathak sir had explained, but I will give my experience. It doesn't matter if you are not using navigation, whether you need to have a rigid fixation, but at least some fixation is needed. That even for endoscopic third ventriculostomy, when you are having endoscopic scissor close to the basilar artery, you just think about patient suddenly waking up. That will be a disaster. So even for ETV, we always put the patient on a ring and we tape the head, so that even if the patient wakes up, nothing disastrous can happen. So 4-pin is not important, but some degree of immobilization is a must. And for endonasal cases, if you are planning to drill close to the carotid artery, see, we assume that the control is in our hand, and you keep few millimeters away from carotid artery and you drill. At that time, if suddenly wakes up and patient suddenly, so that will be a disaster. So it is always better to be safe than sorry. These things can happen 1 in 100, but that one patient will be disastrous for you. So it's always better to have some degree of immobilization. Don't trust anesthesiologists fully. Surgeons should not trust anyone fully. And second thing is that, of course, when you are having navigation, we have optical navigation as well as electromagnetic. For electromagnetic, you don't need a 4-pin. So for children and for cases where we don't want, we can use electromagnetic navigation. But the problem with electromagnetic navigation is it will have interference from any of the bipolar and electrical gadgets in the OT. And in optical navigation, it will get interference if some instrument is hiding the the refractive balls from the camera. So you use as per your convenience, but that if I would recommend, I would recommend some degree of immobilization. Even on ring, you can always use a kind of tape to fix the head. Thank you.
Thank you, sir. I think it highlights the importance of teamwork in neurosurgery, how much we are dependent upon our anesthesia team, ENT colleagues, as well as electrophysiology. So do we have like any questions from the participants? Sir, you can use that mic.
In Sonoma case, transcranial exoscopy case, what are the type of neuromonitoring is being used to monitor the cranial nerves, and how it is being used?
Okay, I'll direct to Panikar, sir. The question is what kind of electrophysiology that we use in the case like that.
Right. You have the cranial, there is electrophysiology is for this monitoring of the long pathways, tracts from the scalp to the foot. This is specifically used for brainstem and spine. In this particular case, you have to just monitor the cranial nerves. So the same electrophysical system, it has also inbuilt facility to monitor the cranial nerves, the third nerve, the ocular movement muscles, basically the third, fourth, and sixth, and also the optic nerve. So in this particular case, and for the schwannomas, we use the seventh cranial nerve monitoring, which is more important. So in this particular case, we'll monitor the third, fourth, and sixth cranial nerve. And if I don't know whether they have also the facility here to do the optic nerve monitoring. So that is what would be used in this particular case. You will be putting the electrodes on the muscles and then of the eyeball and specifically the third nerve. And then there will be continuous, whenever you need to stimulate and see what's happening, you can find out. For the optic nerve stimulation, you give a constant photic stimulation, which is picked up. Now, the problem becomes, if the nerve is already involved, you might not get a good sort of response. And that's our experience in the past. So depending on the extent of the paralysis of these ocular muscles and the functioning of these nerves, the response might be picked up or not picked up initially. But many times we have seen once you have removed the tumor, which is a simple compression, the function and the waveforms keep on coming back. Interestingly, we have sometimes seen that if you give steroids during surgery also, some sort of better response in the waves also come up. The second thing is, of course, the depth of anesthesia, which is very important. So there's a certain depth of anesthesia which has to be maintained so that you get a stimulus and this response which is seen on the monitor. You cannot paralyze this patient, that's contraindicated. And also sedation has also to be of a certain level where you get good stimulus. So that's most probably, and that's the standard thing which is used in all cranial nerve monitoring. You can monitor to any nerve. You can monitor the vagus nerve. You can monitor the hypoglossal nerve by putting electrodes in the tongue. There are even endotracheal tubes available which have got inbuilt facilities to monitor the vagus nerve. The tube costs only 20,000 rupees. But then, if you have that, that's a luxury and a help, of course. So especially if you're operating on the brainstem and other areas, these facilities definitely make a big difference. And we have in the past, while removing long brainstem lesions, these monitoring did help. And one particular case I still remember, which was a juvenile astrocytoma who had come on a wheelchair. This girl, while I was operating, in midst of the surgery, will decompress the tumor in the brainstem. The electrophysiologist told me to stop because the waveform had dropped by 50%. We waited for some time, improved the blood pressure, improved the temperature, checked everything, nothing came back. And we had to stop. And halfway through, I could remove almost 70% of the tumor, but the rest was still left behind with a cystic component. So we closed, and to my utter surprise, the child who was on a wheelchair did start walking with the residual tumor still there, and is still there for, it's now 5 years down the line. It's a grade 1 juvenile astrocytoma, and the tumor has not grown. The cystic component which I aimed to remove could not reach, is still there, and she is now in a class 12 exam, one of the toppers in her batch. So you can have this sort of result also sometimes, even when you removed half of the tumor. But electrophysiological monitoring was not there. I wouldn't have stopped and damaged something and made her totally crippled, which didn't happen. Okay. Single-use ET tubes, but in India everything is, even the electrodes that you use here, they are single-use, but we recycle them.
I think Suri sir is already ready, and he will be telling us in brief all the instruments that he is going to use.
वाइट बैलेंस किस इससे
ट्रांसमिट कर लीजिए. Hello, Astosh.
Sir, you are audible, sir.
Yes, sir.
Yeah, this is Dr. Suri. I'm speaking from the Neuro OR. Thanks to SGPGI for organizing this wonderful workshop. It's a very well-equipped OR and one of the finest. And I'm at the moment standing and doing endoscopic surgery, where Dr. Avdesh probably does it every day. And I'll just tell you about, well, one of the Supreme Court lawyers said that when I think Virat Kohli is batting, he cannot do commentary. So my commentary after, when I start surgery, will be done by Dr. Ravi, who are a faculty neurologist here. Make a focus, take it. So patient is under general anesthesia. The patient has been positioned supine with a bit of head end elevation. We did do a bit of head end flexion. I usually change the angle of the flexion. I don't use the, can I have suction please? I don't use the head ring, I use the 3-pin as I discussed in the morning. But I want the suction.
Right. Ashish, Dr. Pathak here.
Yes, sir.
Can you just, initially as you always do, can you orient them with the anatomy? Because
yes, sir. I'm just doing the nasal packing and then I'll be with you in 2 minutes.
Excellent.
Ready?
Just for everybody here, the first time surgery through the nose is always a joy. The main challenge becomes when it is a reoperative case or a patient who has been operated and giving radiation. In those cases, of course, doing a repeat surgery is an extra challenge, and there are certain things to note.
I need irrigation.
You should have a good inspection of the nasal cavity before you embark upon doing a repeat surgery, because if you are really planning to have a Haddad flap, it might not be possible, because already the nasal mucosa had been badly destroyed by the previous surgery. So there are certain steps to remember when you are doing repeat surgery. But this is a first surgery and a simple straight cut tumor, which should not be a big problem.
Okay. धागा ठीक करो.
So this is Ravi Shankar. So sir is decongesting the right side nasal cavity.
So would you tell the audience what is he using?
Sir is using 0.1% dolometazole.
This is ADR, no? How much? How many ampoules? Okay. We put 5 ampoules of adrenaline in 30 ml of saline, and that is for a regular packing that I always do. This is
So 5 ampoules of adrenaline in 30 ml of
saline.
saline. Okay, that's a little bit more than what I use, but yes, okay, great.
I don't inject it into the mucosa.
No.
Because
Not needed.
This is as per what I learned from my teachers, Dr. Fred Gentili and Dr. Bittag, is that even if the patient is hypertensive, both the patients today are don't have any comorbidities, but even then you can use this because it causes vasoconstriction of the mucosa and does not cause any systemic absorption.
You can control the blood pressure always.
Yes, and this patient was started on Otrivin nasal drops, xylometazoline.
Yes, sir.
Yesterday night, evening, and Ciplox. Okay, and I'll irrigation दिखा what suction? वो attach करने के लिए दूसरा suction एक irrigation और चाहिए एक irrigation और दे दो ना.
Sir, do you use uninostril approach in any of your cases?
I'm very comfortable doing a binostril. Uninostril I have, and yes, how do we put this on? Achha, directly, okay, like this. Arterial line ले लेंगे, arterial line. एक arterial line ले लो. So now I'll give space to Dr. Ashish, who is our senior resident, and the team here. They'll take the infraumbilical incision and take some fat. Up start. I'll just explain the position. Well, I'll come out of the field. We have just decongested the nostrils. We put overnight the patient was on xylometazoline yesterday evening and today morning, and nasal drops, and now we put 5 ampoules of adrenaline and 30 ml of saline, and we gently pack the nostrils. At the moment, I've not done anything to the turbinates. We've not even inspected the nostrils properly. We just decongested, and this is the time I'll take to do to take the fat and all that. The patient is positioned supine and with the head on 3-pin Mayfield fixation, and there's a gentle flexion of the head and a head end elevation, and a slight tilt to the of the head to the surgeon's side, so that I can be comfortable having with access to both the nostrils. And we've used the navigation here. We'll be using that, and that has been also registered. Normally in endonasal endoscopic approach, we never use the C-arm or the fluoroscope, as was the problem in the microscopic approach. We don't need it. But the navigation is not mandatory for such a tumor because ostium helps. But navigation is mandatory if you are doing redo surgeries. Navigation is mandatory if you are doing any extended approach. Navigation is mandatory if you are doing a microadenoma, especially when the cella is small.
So what is the extra precaution while doing the supracellular lesions or clival lesions in the position, sir?
Yeah, so it depends. If it's a mild flexion, and if I want to actually access more of the plenum,
right,
I just slightly increase it like that. And if I want to go right till the C2, I do the extension part so that my angle of access is because you have to understand, you are gifted here because you have a complete neurotology. Ours is a complete ENT department, and now ENT at Ames is not only taking care of ENT at Ames but also ENT oncology at the NCI Jajjar, which is 40 kilometers away. So my friends Dr. Alok Thakkar and Kapil Sika and others who you'll be seeing, Kapil I think is part of our faculty, and it's very difficult for them to be part unless we are doing, and we still do a lot of surgeries together,
We do the temporal, infratemporal approach. We do the angiofibromas. But this department is gifted that you have the ENT along with that, and practically you can devise more new things. So I have learned to respect the nose with my, not because of my ENT collaboration, but actually because of my Indo-German collaboration and my learning from them. And actually I learned more from the ENT surgeons associated with Dr. Martin Bittag. He was Peter Schaefer, and I learned a lot from him. And we have to, as neurosurgeons, we actually do not respect the mouth and the nasal cavity. I'll be very frank with you. Our respect only starts after the dura is opened. That concept must change for every neurosurgeon. And we have to understand that nose mucosa is very delicate and you have to respect the nerve. Only then your approach will be minimally invasive. Unless, because of that, it is better to do a binostril, because then you can, the only problem is uninostril is also good, but we have to understand that one nostril can only accommodate 2 instruments. So we'll be having 12 o'clock on the right nostril, always the scope, the suction in the 6 o'clock position, and you need sometimes the drill and the irrigation. You cannot put 4 of them together in one nostril. So that is why I am not now in favor of uninostril, unless it's a very big acromegaly or a giant person and is a big nostril which can accommodate 3 or 4 instruments. But I think if you are, and because then you will be damaging the mucosa. Any damage to the mucosa inadvertently is a maximally invasive approach. Planned damage, that means a middle turbinectomy or a Haddad approach, also is maximally invasive. It will lead to crusting. So I never do a middle turbinectomy or a Haddad approach if the tumor is anything less than 3A or 3B. Anything 4 or from subfrontal extension, I would, major subfrontal, not the one which we are seeing. If there's subfrontal extension, at maximum you can build the tuberculum sellae, may not coagulate and divide the anterior intercavernous sinus. But that is important. That is what the question was. Why don't you use the uninostril? Only because I feel that the drilling has to be done and we need more instruments there. So it is better that we have all the space. Then 2 instruments can nicely go in both the nostrils each, and that can nicely accommodate.
Sir, in your perspective, how you deal with a onodi cell or pneumatized plenum and pneumatized rostrum, and then non-pneumatized or pre-cellular type of spinal sinus?
Yeah, so if you are having an onodi cell, you must identify the onodi cell. If it is coming in your approach and you have to drill the tuberculum sellae, it is important to open it up, to take off the mucosa there, and just diverting from your question, when to take the mucosa and when not to take the mucosa. If the mucosa is diseased, if the mucosa is thickened, there are secretions, then always remove the mucosa. As ENT surgeons, I think you will second me on that. That has been my learning from you all. And if the mucosa is very thin and it is less vascular, then don't touch it. You just coagulate it and just scrape it from the area of exposure. The only thing is, if it's a healthy mucosa, will wall off your fat and everything and make its own space. But the unhealthy mucosa will make a mucocele. That is the problem in a noddy cell, that if you don't identify it and you are plugging it off, you will be creating much more damage later. So it's very important to identify a noddy cell so that you can open it up, take care of the mucosa, healthy or unhealthy, and you are making space for your opening.
So when you will go for a posterior ethmoidectomy, or when you will limit your dissection till midline, sir?
Yeah, it's always midline in a pituitary adenoma. NOS4, I'll always do a middle turbinectomy. While doing a middle turbinectomy, yeah, I'll be very careful also, and especially in these cases, if I cannot lateralize the middle turbinate, it's better that I medialize it, look at the uncinate process. If there is uncinate hypertrophy, do some uncinectomy, and then again try to lateralize it. Most of the time, it is always a midline approach. I'm relatively good at transcranial, transcavernous approaches. Right. I do them every day, practically every week, 1 or 2, Kavases and cavernous. I feel that if the tumor, one should not, fat is done, okay.
So you can see.
Yeah, if the tumor should not be crossing the nerves or vessels. If it is crossing the vessels, NOS4, it is simpler to approach a tumor because if it is less fibrous, medial to the carotid, is very fibrous, and be very careful when you're going lateral to the carotid, because the perforators of the meningohypophyseal trunk and the infralateral trunk will be coming in your field. Do not use a curette blindly. You have to be under vision, do a middle turbinectomy, take a Haddad flap, open the dura widely, bare the carotid, look at the perforators, use your suction gently. Do not aim for a radical 100% gross total excision. Aim for a conservative radical excision, so that you can use your adjuvant therapy. But if it is crossing the nerves and the arteries, especially if it is crossing the interdural plane, and it's becoming like what Dr. Panikar's tumor has become. So if it, last week I did a giant pituitary adenoma. It was a prolactinoma. I think Ashish was there with me, and it was a cellular, supracellular, huge paracellular, and going to the orbit. First time seeing a pituitary adenoma, exactly what something like Dr. Panikar is. I did a transcranial, transcavernous approach, and then I opened the cavernous sinus and entered that tumor. So then we have to tailor. It is no point playing with the carotid from the nose. That's what I have learned.
Sure.
Heroism can be for the surgeon, but patient cannot suffer.
Right. True.
I mean, we've taken the fat. I'll just see the field once. Forceps. Field is dry. Field is dry. So I'll just, I think we can see from the scope. Yeah. So this is the infraumbilical incision. Yeah. This is the infraumbilical incision. It's just a 2 cm. This is the umbilicus infraumbilical incision. I started doing this after my German and Canadian collaborations. No patient in the West allows a thigh incision. So please don't underestimate Indian ladies. Please take care of their cosmetics also. Wet gauze, please.
You mean the Indian ladies would like a thigh incision? That's what you mean to say?
Sir, yes, this patient was actually preferring a thigh incision. I explained to the patient. Another problem in the thigh incision, sir, is that the thigh fat is actually less. The abdominal fat is much more. From a small incision, you can take out more fat. But the problem in the thigh, to take that much of fat, just show, Gina, can you show me the fat? Yeah. So this is the fat small lobule that we have taken. To take that much of fat from the thigh, your incision has to be pretty longer. And if you undermine those incisions, if you are taking a fascia lata is better in the thigh. Rectus fascia is not so good here unless you are taking a very small one. Can I have another sponge, wet sponge? Give me 2 of them so that we pack it for an hour and then later on we can close. Now I think Dr. Ravi will take care of the commentary as per the verdicts. Dr. Ravi, yes, sir. Thank you. I'll be intermittently I'll be speaking, but most of the commentary will be there by Dr. Ravi. He's our faculty neurotologist in SGPGI. SGPGI is very lucky to have both type of teams. We go back to the nose.
So optical zoom, sir. We are having the optical zoom.
Where?
Yes.
This one?
Central press. Big button, sir. Big button. Big
This
button.
one?
Yes, sir. And come down, sir. Come down, sir. R नीचे से. R नीचे से. Just zoom, sir. Right. Sir, नीचे. Yes, sir. Right. Sir, right click. Just infrared one, yes, sir. Left one.
I'll press this upper one.
No, sir. Side one. Lower one. No, sir. Yes, sir. We come down. Yes, sir.
No, it's coming.
Yes, sir.
I increase it.
Yes, sir. Bus.
That's enough?
Yes, sir.
Okay. Go back.
Yeah. That's enough. That's perfect.
Okay.
2 point is perfect, sir.
Huh?
2 point is perfect.
2 point is perfect. Just a second.
So you like standard or chroma?
No, standard is good. This display.
This
Zoom.
one, yes.
Okay. Zoom. Then I bring it down.
Yes.
This one.
Yes. Bus.
Is okay?
Perfect, sir.
Okay.
Exit.
Exit.
Inferior. No. Yes. Sir. Central button.
Coming.
Yes, sir. Yes.
Okay.
Ravi sir?
Can we
Yes,
have one
yes,
more
sir.
assistant?
Ravi sir?
Yes, Ashutosh.
Sir, can you please just give a brief about what are other settings that we can use while using this endoscope?
So we are using a standard mode. So can we start?
Yeah. Now you can start. You can speak.
So Ashutosh.
Sir.
So we are using a standard mode here, and bilateral nasal cavity was decongested using adrenaline, as sir told. Sir using 5 ampule of adrenaline with a dilation of 30 ml of saline. This is the right side nasal cavity.
That is the
inferior, the inferior turbinate, and the anterior end of the middle turbinate we are seeing. There is a small posterior septal purse, and we are going towards the nasopharynx, and we are visualizing the interstitial tube at the 9 o'clock, and there is a residual adenoids at the posterior part of the nasopharynx.
ADR cortex. One more.
So as everybody sees here, the initial inspection of the cavity and trying to orient yourself with the anatomy is very important. Reaching the posterior nair is very important because from there you climb up to try to look for the sphenoid ostia, which is the landmark.
So this is a left side nasal cavity. This patient is having a small spur on the left side, inferior spur, septal spur.
You have a fine suction, please. I'm going between the middle and the inferior turbinate.
Yes.
And that's the posterior nair. And
the left side, left side choana.
Can I have a spatula? Thank you. Okay.
Sir is out fracturing the inferior turbinate to improve the cavity and to get the most space for the instrumentation. So the ideal position is junction of anterior 1/3 and posterior 2/3 of the inferior turbinate, where the inferior turbinate bone is slightly
I think there's a bony spur here which needs to be slightly.
Yes, sir. Yes. It was out fractured, and we are seeing the third portion of the middle turbinate just above the periosteum elevator. So we are out fracturing the middle turbinate to get into the sphenoethmoidal recess. This is the junction of first and second portion of the middle turbinate. So we are into the sphenoethmoidal recess.
ADR cortex.
Sir, at what place on middle turbinate should you keep your spatula while doing the fracture?
So ideally the junction of first and second. So most of the time we will see the anterior end of the superior turbinate. That is the easiest guide to identify the junction where you have to give the pressure. If you give too much of pressure more anteriorly, it can transmit the pressure toward the skull base because the first portion of middle turbinate is attached to the skull base. So the pressure is always at the junction of first and second portion. The easiest guide is anterior end of the superior turbinate, where the sir is exactly out fracture the middle turbinate.
Gotcha.
One more thing, we need to look at the olfactory fossa depth. Yes. If the olfactory fossa is quite deep, there is a high risk of mobilizing the middle turbinate. It can cause fracture to extend into the cribriform plate. So that also needs to be taken. Sometimes it is better to remove the middle turbinate rather than to cause a remote CSF leak from cribriform plate.
Very right, sir. Especially when you deal with type 3 cheiros or asymmetrical cheiros. So here we can see that sir exactly fracturing at the junction of first and second portion of the middle turbinate.
Sir, morning. I am at your temple, sir.
अरे सूरी साहब क्या दिखा रहे हैं? अच्छा यहाँ बोलेंगे तो वहाँ आवाज जाएगी। कोई बात नहीं, बुजुर्ग लोगों की आवाज जा रही है।
I am in company of the head of department, Dr. Rajkumar. He is also our senior alumnus at AIMS and my guru and always my mentor and my friend.
Friend more than guru.
At this point, the blood pressure needs to be on the lower side. So that's what I routinely do. I don't know what's the blood pressure in this patient at this point of time.
It's normal, but mean arterial. 90. So if we have 100, there is not too much of oozing. We can keep the same or maybe reduce it to 90.
Yeah, I mean, we keep it between 90 and 100 depending on the baseline blood pressure of the patient.
Yes, we'll keep it here. Now is the time that I'll be packing the middle. I'll already lateralized a bit of it. I've not really fractured it because by fracturing you can actually see the superior turbinate immediately. So I've not really, I've just lateralized it. There was no. So now I'll be packing it for 5 minutes. That is a very important part and step. The endoscopic biopsy. And ये तो बोन कट रहा है, ये तो बोन कट रहा है। हाँ मेरे बॉक्स में भी है, देखो छोटा सा, थोड़ा सा लेंथ कम है।
I request the audience if they want, they should ask more questions. We have very good surgeons and moderators here, Dr. Pathak with us. So utilize this time and make the session more interactive.
बिना मेरा बॉक्स में है एक बायोप्सी.
So basically what you're doing, you'll get this average space, it has been worked out if you read the articles. You get something between 1.5 to 1.9 centimeter square space through which you have to operate and handle your instruments. So that's why the creation of a corridor with minor tweaking of the anatomy is very important. And every step no matter, as you can see, even with so much of adrenaline pack, there was a little bit of ooze coming out when we were just handling the mucosa. So every stage, if you just have patience and do a little bit of packing for every small maneuver, you will create almost a bloodless sort of corridor through which you enter into the nasal cavity and then into the sphenoid sinus. The first aim is to enter into the sphenoid sinus. So that's what we are trying to achieve here. So we have lateralized the middle terminate a little bit. As Professor Suri said, he has not fractured, but he has lateralized it, which is...
I've out-fractured the inferior turbinate.
Yeah, it's not needed. And now he is just trying to lateralize again, pack it so that there's minimum ooze or no ooze at all, so that it's a clean field through which you can enter into the sphenoid sinus. And that's our target destination at this point of time.
You need more patience in the endoscopic approach. Microscopic, you don't need that much of patience. Curved. ये भी चलेगा. 5 minutes by the watch.
Sir, Dr. Ashish Suri, sir, there's one request for you. Sir, can you please give us like some guidance how we can like change over from a microscopic to an endoscopic procedures?
No, I have last 12 years. I was trained in microscope, and I spent 30 years at AIMS. The first 5 years, 5 to 6 years, I was only training under the microscope by my teachers who were the giants, Dr. Banerjee and Dr. Mehta. And I could do, and till 2008, I was only doing microscopic TNTS, and I could remove the tumor in 15-20 minutes. And then I got trained in endoscopy, and it completely changed because in I felt that the visualization and the extent of removal and the
safety concerns are much more in an endoscope. Like last 14 years, I've completely changed to endoscope. The first few cases, I changed because my hand-eye coordination, my learning curve for the first 25-30 cases, I actually changed to microscope in at least 5 of them. I think I'm out of the first 25 because in large tumors there was oozing and we didn't have that type of patience with the nose. But then I actually learned from the ENT surgeons, and then the last probably 12 years I've never changed to a microscope. If microscope is there, then it is a transcranial transcavernous, not an endonasal.
So I think, sir, the learning curve is for about 25 to 30 cases. And sir, what do you recommend during this learning curve? What kind of cases to choose? What are the things that you would like to see on radiology before choosing such cases in the initial part of your experience?
I will not say which cases to choose. I will say which cases not to do. Do not attempt a conchal cella. Do not attempt a microadenoma because the cella will be very small. Do not attempt a giant adenoma. Do not attempt a NOS4 or a NOS lateral extensions. The rest, a small macroadenoma sized anything between 1 to 2 or 3 would be doable. And please always see the MR intensities on T2. If the T2 is hypo-intense, is much more black on T2. That means the tumor will become much more fibrous, especially in adenomas, in prolactinomas which are resistant to bromocriptine, have been given bromocriptine, they become very fibrous and they become very T2 hypo. Many acros do that. Do not do recurrent tumors and do not do post-gamma knife or post-radiosurgery or post-radiotherapy tumors. If you can avoid that in the first 25 cases, your learning curve will be very nice, smooth and confident. Problem in endoscopy is many people who have left endoscopy, gone back to the microscope or left endonasal completely are the ones who have attempted very big cases and not excluded these cases in the first 25 that something like I can do it and I can do it very well. So that is the problem. 1 or 2 cases have a problem, you stop doing it, actually start becoming afraid of it. Once the 25 is, the main idea for a neurosurgeon is you have to master the hand-eye coordination on the microscope and the instrument tissue manipulation. It is different from the ventricular endoscopy where your one thing set is fixed. Here, your movement and your fogging and there are a lot of issues that you have to master. The mastery is much more beyond your surgical skills. It is the instrument handling, the fogging which happens and the mucosal congestion and the bleeding. 5 minutes are over? Okay.
So basically in one word, start with the soft balls, play safe, take things easy, start with simple balls and then go for 6ers and 4s. So that's what was told. And be ready with the microscope in the initial phase, any difficulty. Don't hesitate, don't feel that your ego is hurt because you have to change from the endoscope to microscope. That thing should not be there in the mind.
Sir, I think be it cranial endoscopy or endoscopy involving spine, both these, all the principles that both of you have enumerated, I think they are applicable for both of it.
Yes. Endoscope can be used anywhere. I remove brain tumors with endoscope, gliomas with endoscope nowadays. So you don't need a, and if you have an exoscope, that's another substitute.
Sharper, mid-needle. Suction, fine suction. Spatula again. Your scope always has to be at the 12 o'clock, this skin, and you have to lift it up so that you are, like Dr. Pathak nicely mentioned, you are actually elongating the nostril. And now you see there's more space. 10 minutes ago, I could hardly go there. Suction बढ़ा देंगे ये वाला.
Now, can you show them what you mean by 12 o'clock? Because most of them they rotate the camera and then they miss the view.
Yes, sir.
So look at the way he's holding the camera. The buttons of the camera should be at 12
This
o'clock.
is 12 and the buttons of the camera have to be 12, so that there is
So that's where the camera, if the camera rotates, you can get totally lost. So you must hold in such a way the camera is held with your fingers as well, so the camera does not rotate. The buttons of the camera should be exactly at 12 o'clock, then the whole view is at 12 o'clock. So whatever you're seeing is 12 o'clock in front. So that's 12 o'clock straight. So these are simple tips which go wrong in the initial phase. Now, Ashish, can you tell us how do you manage nasal spurs?
Sir, I'm started operating. Ravi, can you just help them?
Yes, sir.
Nasal spurs.
Sir, if it's a pointed spur, then you can make an incision just in front of the spurs, and you can excise the spurrectomy. If it's involving the both quadrangular cartilage and the perpendicular plate, then we have to go for a proper SMR. Means through the mucocutaneous junction, elevate the mucopericardial flap and then mucoperiosteal flap
and remove
resect the part of the quadrangular cartilage, and then we can go for a spur resection.
So that is the choana. I go 1 centimeter above the choana, and that's the sphenoid ostium. You can see the sphenoid ostium.
Beautifully seen. Beautifully seen.
Cotton.
So in 70% of the cases, the ostium is seen. In 30% of the cases, the ostium is not seen. And in that situation, the ostium is not seen. You will see a small thickening of the mucosa there, or some bulge of the mucosa there, or some redness there. Or you can use the navigation in that situation to create a little bit of space by dipping through the mucosa, and you'll enter into it. So this is from the choana 1.5 centimeters on an average above. So that's the choana.
Needle ready.
And you follow the mucosa above, and 1.5 centimeters average above that is the ostium. And as I said, 70% of the cases ostium would be seen, 30% ostium would not be visualized. And you have to use other techniques to sort of either create an ostium or find the ostium, which might be hidden by a mucosal fold.
In case if ostium not seen, then a simple maneuver that take a ball probe, just take it there and move it over the expected site of the ostium in the spinocerebellar recess.
Yeah.
It gets dipped inside the ostium itself.
So
this is a simple maneuver which can be done. And location identification of the ostium is extremely important because it forms the upper incision if you are planning to make a dart flap.
True. It's a blind man trying to hit with a stick, and it gets the roll.
Yes. Very good example given by Dr. Pathak. Thank you,
Use
sir.
similes to make it interesting. So now he is coagulating the mucosa here.
This is like a Colorado needle.
Yeah.
And I just make a small semilunar incision on the posterior end of the septum.
So you're again raising a septal flap, basically what we used to do in microscopy, but much posterior to what you used to do normally. Not at the osteochondral junction, but far behind.
That is it.
So that's the bony septum now coming to view, and the mucosa getting elevated.
There is a spur also here.
Yes.
So normally I would have taken the semilunar incision a bit more towards the sphenoid ostium, but because the spur, I thought that it's better I include this incision.
Sir, can you also demonstrate the landmarks for making the Hadad flap?
Yeah, I'll do that. Ravi, can you make
Yes, sir. So there are two very important landmarks for the Hadad. One is the sphenoid ostium. The sphenoid ostium is your limit for the upper incision of the Hadad flap. We have to start at the level of ostium, and for the anterior continuation, you have to follow the midpoint of the middle terminate. So it will it will help in the preservation of olfactory mucosa, that is approximately 1.5 to 2 centimeter below the skull base. So for the superior incision, there are two landmarks. One is the sphenoidosteum, another is the midpoint of the vertical.
This is the sphenoidosteum.
Yes, sir. Sir, showing the sphenoidosteum and exact site for the upper incision of the adult flap. For the inferior incision, you have to follow the choana. The roof of the choana, that is the landmark for the upper incision. So by preserving the space between the ostium and the upper choana, we can preserve the nasoseptal branch of the sphenopalatine artery, that is the main blood supply for the adult flap. So the inferior incision you can extend by using the floor or inferior terminate, but the superior incision always 1.5 to 2 centimeter below the skull base. But when once you cross the anterior end of the inferior middle terminate, you can extend the superior incision towards the roof of the nasal cavity. So based on the size of the defect, and the anterior most incision is ideally a mucocutaneous junction, or it depends on the size of the flap you needed.
So now you see the posterior part of the bony ostium
Yes, sir.
is denuded of the mucosa, so it's denuded now, and you can see the ragged bony septum, which is at the level of the sphenoid ostium.
This patient is having the thick rostrum, sir, and we expose the right side of the
flat dissect.
Right.
So reduce कर दो irrigation कम नहीं कम कर कम.
Ravi sir, can we increase the illumination of the endoscope, please?
So it's 100% actually. So sir is using endo sheath irrigated along with the endoscope.
कम कर reduce बंद कर.
See, when there is blood in the cavity, the blood RBCs,
It'll be a bit
red color absorbs
you'll have
light.
some fogging and all because the nasal stage is there. Once we cross that, it'll be more comfortable. Don't worry.
The red color absorbs light, so that's the illumination gets slightly decreased.
बंद कर दो irrigation. इसको यहाँ रखो अपने पास. इसको यहाँ इनको दे दो. अभी बंद कर. Monopole.
So you remove the mucosa and go down so that you definitely have a good exposure right up to the base of the sphenoid sinus. So this mucosal flap later on, when you close, is going to come back.
Yes, sir.
And
I'll use
seal
this,
the gap. So
I'll use this flap later.
Yes.
You know, you have to clean the needle.
And now you can drill the bone, and if it's a thin bony septum, you can just fracture it and go to the other side as well, and denude it of the mucosa on the other side.
Clean the scope. Yeah, clean the scope. Yeah, thank you. Close, shut off the irrigation. Clean. Flat dissector. एक स्पंज वेट स्पंज और दे दो. वो तो क्लीन के लिए, बाकी इनको खाली डैब करने के लिए चाहिए. वेट स्पंज दे दो. बस एक क्लीन एक यहीं रख दो. I'll just dab it and this is where I'm fracturing the bony plate of the vomer from the keel of the vomer. And this is actually undeviating. 90% of the nasal septa are deviated. Am I right, Dr. Ravi?
Yes, sir. Right.
So our main aim is here to undeviate the deviated nasal septum. And then you will have space on both sides.
Sir, if somebody is not having Colorado needle, so would you like to suggest any other alternative? Sir, Dr. Suri, sir.
Yes, sir.
Sir, if somebody is
Biopsy.
not having Colorado needle, so would you like to suggest some alternative?
Any monopolar needle is good enough, or you can put a hypodermic needle in front as an attachment to I've also done that also. LP needle connected with the
monopolar.
Suction.
So Colorado needle is very important instrument which should be used in endonasal surgeries, particularly when you are making a Haddad flap or raising any nasoseptal flap.
My approach is slightly different. Many people do actually a lot of mucosal ablation. They took a mucosal, what do you call that?
Cobalator.
Cobalator. I never use the cobalator. Bone punch.
Cobalator is also a very good instrument which has 4 functions. It cobalates, it ablates, it has suction mechanism as well as irrigation also. It is very good tool to use for tumors present in the nose, used by our ENT colleagues in juvenile nasopharyngeal angiofibroma. It's a good instrument and particularly useful in CSF rhinorrhea.
Yeah, I agree with Dr. Avdesh that the cobalator is sometimes very helpful. Sometimes in large meningiomas, when nothing works, we use cobalator for internal decompression. And but again, the suction can get blocked very frequently. So that is the only disadvantage.
The other disadvantage is that it is a very expensive tool.
Yes, 15,000 per wand actually.
Bone punch. Bone punch. Bone punch. Cutting punch.
But somehow when we did a comparative study, we noted that the sinonasal outcome was better with coblation compared to the debrider and other instruments. Because it doesn't cause much trauma to the nasal mucosa compared to the debrider and the normal bipolars which we use. Because it's very...
Yes, definitely. Because the cobalator does not cut charring of the tissues.
Yes, it doesn't do charring.
Yes.
Similar to how the RF is quite useful in spinal endoscopy.
Yes.
Punch. Cutting drill है? Cutting drill. Drill. Biopsy.
Dr. Dandapani, can you tell something about microdebrider to our audience?
Before cobalator, we have been using microdebrider kind of regularly. When we are doing dissection of nasal mucosa, we have to remember we should never pull any structure with disc forceps or Blakesy. It is better to cut rather than to pull. So the cutting instruments are far better. But the routine scissors which we use are useless here in nose. So that's why I think the micro debrider, it really cuts at that particular area with a rotating cutter. And it has some advantages, you can angulate it. But you did not have coagulation in that. I think that is the added advantage of cobalator over a micro debrider. In micro debrider, you have irrigation and you have debrider. And but in coblation, you can coagulate also.
Punch.
Micro debrider also can be used in large meningiomas if you are in the middle, that if you are in the internal decompression stage. But again, these things are not kind of recommended things. But when you are so desperate, if the tumor is very fibrous, then nothing works. In fibrous tumors, sometimes even the blade breaks, surgical knife.
Irrigation off kar do.
So I request all the delegates to ask, don't hesitate, don't ask and share your experiences with us. You have good masters with us. They will be feel happy to clear your doubts, or maybe in exchange we will learn something from you. So please participate actively. We'll try to give you the mics. Otherwise, the mics are in the middle of the
You have a long
this hall. You can come and you can share your experiences.
Upcut.
On which
Down.
point actually we should have the binostrial approach?
Grasping. So that is sphenoid sinus. There's a middle septum, midline septum. Punch. So at the moment I'm only uninostril. I'll be going to the other side. Once I dislocate this vomer completely. Downcut.
My question was on which point we have to have a binostrial approach from, we'll switch from uninostril to binostril, on which point of our nasal phase?
That is surgeon's preference. Some people may remain purely unilateral, but Dr. Suri sir has clearly told you have a better hand-eye coordination as well as a greater exposure and a better ergonomics, and you are likely to remove the tumor fully in binostril approach. But you can start with one side and then see there are different ways of getting into sphenoid sinus.
Downcut.
One is you start directly in the sphenoid ostium and then go to the other sphenoid ostium and connect both and then come backwards for removing the posterior septum. Or you may go first do a posterior septectomy. Once you have removed the posterior septum, then you enter the midline of the sphenoid sinus and then go till both ends of the sphenoid ostium. So both are acceptable on a case-to-case basis or as per your preference. Each has its own advantage. If the sphenoid sinus is very large, you may remove the tumor without doing posterior septectomy. That is only possible if you directly do sphenoidotomy on one side and then on the other side and then join both. Then you will know that there is good space and no need to do posterior septectomy. But the disadvantage is you need to have kind of that specialized instruments. But in a simple setup, it will be easier to do posterior septectomy first and then mobilize and then get into the sphenoid sinus in the midline.
Hello, this is Dr. Diptiman. I'm an ENT from Odisha. We are doing collaboration with pituitary surgeries with my neurosurgeon. And from the beginning, we have used coblation and we do septectomy from the beginning because we see from the scans what we actually need, how much exposure we need, whether we need a middle turbinectomy or whether we need to reduce the middle turbinate. Sometimes the turbinate hypertrophy causes lot of injury and later on it gives rise to lot of synechia formation. And the patient will keep on coming to you for the botheration of the sinus nose nasal issue. That is actually problem the patient will face after 3 to 6 months. So we need to respect the nose. We need to use much better tools, that is the coblation. The field will be much better, it will be less bloody and you'll have comfortable to do this surgery. You'll have much better exposure. You need to use good drills like the clear view tools which will have self-irrigation. You need suction tips with blunt ends so that it won't cause mucosal injury and it won't damage the turbinates, and this will give rise to a better outcome in future. Thank you.
Well said. That's quite understandable. Neurosurgeons do the surgery and the post-op care for the nose, of course, is a difficult issue sometimes, and it keeps on lingering. And I have to admit that we then become, helpless, and we have to definitely take care of the ENT surgeons to help us out. So respecting the mucosa, nasal synecdoche, even I had a recent patient who had a nasal septal abscess after surgery. So all these things do happen, and if you go through the literature, even for simple pituitary surgery, 22.7% complication rate is reported in the literature. So though it seems to be a straight cut surgery, it's not so straight cut. So from the patient point of view, because you have to understand, this is the era where the patient satisfaction is more important. So well pointed out, and this point must be really kept in mind. Now we have exposed the sphenoid sinus area, and we would expect, once the things are clear, then Professor Suri would tell us the landmarks here, once again to orient the whole audience.
Professor Pathak sir, could you like to tell us what should be the post-operative nasal care in a simple endonasal endoscopic surgery?
If I've done something around 1,500 cases now, which includes microscopic procedures as well, I have seen saddle nose formation. I have seen synechia happening in good number of patients who kept on bothering me. I have seen mucocele formation. As I said, I have seen septal abscess formation. And these patients are never happy. They're not worried that tumor has been removed or not, because their nose is bothering them day and night. I have seen problems with breathing, good aeration of the nose. So that's what I'm sometimes, when we extensively or irrationally use Haddad flap, I'm not happy about it, because you're denuding the nasal mucosa, which nature has given you for good aeration, good humidification, good ventilation. It also prevents the mucosa also acts as a barrier against particles which are not wanted in the respiratory airway down in the lungs. So obviously nature has made all these convolutions of trabeculae and septations and all these things covered with mucosa to protect the lower airway, and these are the gateway to the entry of the lungs. So preserving the mucosa, respecting mucosa, and having smooth ventilation through the mucosa. There is something, the mucosal pattern, the vascularity of the mucosa changes in a daily basis, and the vascular supply of the mucosa also changes from day and night and in a diurnal basis. So all this nature has made its own provision of proper air conditioning of your airway, and if you don't respect that, you're going against nature. And just imagine somebody who is a patient of allergic rhinitis or something like that. So if you have denuded the mucosa further, you are really destroying the immune system. So it has something to do with the immunity also of the respiratory passage. So this is very important to maintain that. So yes, I have seen a lot of complications, and I really feel for those patients that I could not give them a comfort even after successful removal of the tumor. So that's something to be kept in mind. So don't ignore the patient if he is telling, I'm not having comfort. So either you take help of the ENT surgeons or you try to solve it yourself if you can.
Hello, sir, Anand this side.
Anand, please.
Sir, can we switch to the exoscopic OT?
Sure.
Okay, sir. Please go live. So I would request all the delegates to please wear their 3D glasses, because now we are switching on to the 3D surgery. Hello?
Anand, please go ahead.
So I would request all the delegates to please wear the 3D glasses, because we are now switching on to the 3D OT. Hello?
Yes, sir. You can proceed, sir.
Okay,
Yeah, are you all
the
with
3D output is visible out there? Ashutosh, the 3D output is
Yes,
available?
sir. It has been. Yeah, it's just changing. Those who have not received 3D classes, they can get it from the just from the door, nearby
Yeah,
door.
because the delegates will be needing the 3D classes, so
You-
just let me know when the 3D projection is on.
Sir, 3D projection is on.
Okay, sir, Dilip sir, the 3D
Yeah.
projection is on, so you can just explain it to the people now.
Great. So you can see the image, what I'm seeing right now. This is the frontal dura, the temporal dura. This is the sphenoid wing. I have nibbled off big part of the sphenoid wing here. This is the middle meningeal artery, right? Can you appreciate this?
Hello? Hello? Ashutosh?
We are not getting 3D effect here in the auditorium.
Dr. Anand, this is Dr. Kuntal from the auditorium.
Yeah.
We can't see the 3D quite well, I think. There's some problem, even with the specs.
What do you do for adult? How you do it? Sir, how do you do it?
Kuntal, just hold on, we are just trying to...
Yeah, AV team, kindly look into this.
Huh.
We are neither seeing 3D nor 2D.
Okay.
Okay.
I quite understand. I'm seeing this in glorious 3D and I'm stripping the anterior fossa dura from the orbital roof under 3D vision.
Dilip sir, if you could kindly focus on the area you're working. Recenter, please.
Dilip, Ashish here. Can you just orient us once again, please, if you don't mind?
Just do that. I'll just do that.
Yeah, yeah.
3D projection is still not good.
Okay. Okay, so this is the frontal dura, the temporal dura.
Which is the temporal? It's not coming to view in the screen. It's not focused. You're not focused actually on that area.
Okay, I'm focused probably down here. Let me get back.
So it's not coming in the center of the screen. So probably you have to.
Yeah, can you focus
Your exoscope has to move slightly out of the way to that area.
Basically, what I've gone to the opposite side, and same. I've done.
So that's the temporal area. Okay.
This is the frontal, what you're looking at.
Okay, that's the frontal. Okay.
That's the orbital roof.
Why not make a flap
That's
here?
a lesser
Because then
wing
it
of
comes in the
sphenoid.
No, nothing is on the screen.
You can also
So
make a flap here because then
it's out of.
with a drill bit.
It's not coming in the screen. It's focused but not coming in the screen. So
Okay.
no, we are zooming it. We don't want to zoom. We want to. We want it's out of the screen. No, you're zooming it. We don't want to zoom. We want the thing to come in the center of the field.
Cranial always.
Okay, is that better? Can you see?
No, we can't see. Yeah, getting better. Yes. That's it now. Yeah. Not. Yeah.
Let me move the system out a little bit.
No, you bring the left side to the left, further left. Bring your left side further left, further left, little bit more. Yeah, you were there almost.
Is that better?
No, bring the left side further left. You're getting better. More, move. Move to the right. Move to the. You move to the right.
I move to the right.
Right. That's it. That's fantastic now.
Okay.
Yeah, that's fine.
Okay, so you can see this.
No, again it's moved.
Yeah,
It's
I
not-
know. I'm moving it. I'm angling it
Okay.
frontally.
You're manhandling it. So.
Plan to check.
Okay. Can you see this view?
No, the previous one was better. You moved it. Yeah, that's temporal.
No, that is frontal.
This is an SSFL branch. Yeah.
This is frontal, this is temporal.
So temporal is not coming to view. Frontal is coming to view.
Yeah, that's it. Monopoly. This side can be burnt, no?
Is it better?
Anand sir?
Yeah,
Sir,
yes.
can you see that picture there in 3D?
If you keep it in this position, that's
Yes,
fine.
we are seeing it in 3D only here.
Okay.
Okay. If you don't allow it to move further, yeah.
Okay, Ravi?
We are seeing it in 3D here in the OT.
Actually, we have a transmission of 3D, but
So that's frontal.
This is frontal.
Yeah.
Dissector, please.
Yeah.
Okay, so that is the frontal craniotomy. That is a supraorbital bar somewhere there.
Right.
The orbital roof.
Yeah.
I'm stripping the dura off the frontal, the orbital roof.
Right.
This is the lesser wing of the sphenoid. You can see
Everything is gone off now.
In fact, you can see the meningo-orbital band right there.
We can see the whole OT, but minus your this thing.
Cutting drill चाहिए होगा.
Okay, I think they're changing the display. That's why we are.
ये पूरी OT जा रही है तुम्हारी, ये जा रहा है क्या?
Can you switch to the other theater by that in the meantime?
No, biopsy. Biopsy.
तेरे पूरी OT दिख रही है कौन सी? पूरी OT कैसे दिखा देगा परेश?
Hello.
Yeah, this is perfect.
अब देखो, अब आया, this is perfect.
चलाएं डाल.
So that's the temporal.
Yeah, that is temporal side.
Again, the display is gone off.
देखो display is gone out now.
Suction. ये सेप्टस लाइन है.
अरे बिल्कुल.
सबसे बड़ा सिलेंडर.
Yeah. So I think the drilling of the sphenoid is more important here, as you mentioned initially, and we can see how beautifully you have drilled the sphenoid.
Yeah, so I will have to take off all this bone here. This entire bone, the lesser wing, the greater wing.
Yes.
Open the superior orbital fissure, dissector.
That's right.
Yeah, open the superior orbital fissure. That's a meningo-orbital band which I will disconnect.
Yes.
And that will get me access down. You can see the you can see the lesser wing.
Anterior clinoid is almost.
Yeah,
there.
so we are reaching there. This will take us to the anterior clinoid process.
Yeah, yeah, great.
Right. Tube by nostril. No, it's big syringe.
So you'll cut the meningo-orbital band, am I right?
Yeah, I'll start drilling here. I'll reduce the sphenoid wing.
Yes.
And then as I reach the meningo-orbital band, I'll cut that.
Absolutely.
And then mobilize this whole dura backwards.
Yes,
That will give me exposure to the greater wing and allow me to take all this bone out.
Yes.
This is what will get me into the orbit and give me access to the intraorbital tumor.
Great.
Suction
Great, great.
Pani on. हाँ वो देखो सिर्फ इस पे कुछ वो लगा दो ना सक्शन टिप कर दो नीडल इज नॉट गुड one more saline.
So what sort of drill bit you are going to use in this case?
I am going to start with a cutting burr.
Cutting burr.
I am going to start with a 30 cutting.
Right.
And then we'll move on to the diamond.
Diamond burr.
As we get closer to the periorbita.
Excellent. Excellent.
So I'll just start with the cutting burr and start reducing this. This is just volume reduction of.
How do I change? Yeah, that's what I was asking.
So this is frontal.
Yes.
Temporal.
Yes.
Sphenoid wing.
Yes.
Meningo-orbital band.
Excellent.
The middle stump of the middle meningeal.
Yes.
Lesser wing of sphenoid.
Yes.
The greater wing.
Yes.
The middle fossa base down there. I'll put some patties there.
Yeah. So excellent. We are all oriented now. Great.
Great.
Better. No, the red will go, na? Red will go. Yes. Red will go. This 4K, eh? Beautiful. Saline?
Saline.
इस पे ना नीडल ठीक नहीं please.
Potty cutting है अभी?
देना switch. Better? Thank you.
पाइप दीजिएगा.
Cutting drill. Cutting drill. Irrigation.
I think there is tumor here. तो यहाँ पर थोड़ा सा strip करेंगे तो I think we'll see the tumor.
Hello. Yeah, we can see something which is tough there within the dura.
Sir, can you give some tips on using the drill?
Some tips on using the drill? Yeah.
Well,
Yeah.
use
So I think very important, never undersize your drill. Because use a larger drill bit than what you think is necessary. मिल गया? हाँ जी, दीजिए. Always use a larger drill bit than what you think is necessary, because you're safer with a larger drill. The smaller one is likely to plunge. So you should always be very careful when you use a small bit. Well, use a large bit, lots of irrigation, and always when you want to do a volume bone removal, use a cutting burr. So the two types are cutting and the diamond. The fluted burr, the cutting burr. It's still the 3. Okay. ठीक है. So this is a diamond. Cutting available नहीं है. ठीक है. ठीक है. The problem with the diamond is we'll take more time. Okay, keep irrigating. Lots of irrigation. So one tip is when you're drilling, never allow the bone to become white like this. If your bone becomes white, it means your irrigation is inadequate. So what I'm doing is I'm using my suction as a counter traction tool to keep the dura away while I drill.
As you rightly mentioned, the anesthetists have given a perfect relaxation of the brain for you, which is definitely helping you to retract the brain with minimum sort of retraction just with the suction. So that's very important. You need to have this sort of relaxed brain to have enough access to the base.
So again, this is a question of getting used to the system. The drilling here is probably a little slower than what most people would expect. The drilling is a little slower than what most people would expect. That's because I'm doing it under the exoscope. So it's practice. So you have to keep on doing it to get used to it and become familiar. So I've switched to a slightly larger burr. It looks horrendous, but this will allow a lot of volume bone removal. And it's very important whenever you're doing any heavy skull-based drilling, try to use a new burr so that something that is not blunted and something that will allow you to yeah, you've gone off the screen.
Yes, that's fine.
Yeah, okay. Forceps. Okay, drill. Can you protect the muscle? Yeah, come there. Excellent. So as you drill, you keep protecting the soft tissues from any kind of an injury. So as we all know, the drill is a wonderful instrument, but if not used in the right way, you can have a tremendous amount of collateral injury. Now, if you can see here, give me the dissector. Ashish, can you see this?
Yes.
Can you see the tip of my instrument?
Absolutely.
Yeah? Now, that is a tumor.
Yeah, yeah.
There, that's a tumor.
The texture is different, yes.
Yeah. So, in fact, I can feel a thin shell of bone over that, but
Yeah.
it's like cardboard. So
Yeah.
that is a bone that has been thinned out, and this is the tumor.
Absolutely.
So you can see we already have this. We are peeling the dura back,
Absolutely.
and you can see the tumor.
You have to show
There
us
is a
the-
thin shell of bone there, which
Yes,
we'll all
yes.
take off. But this is, we are beginning to see the tumor.
Yeah.
And as we go on, I'm sure we'll see a lot more of
Yeah,
this.
yeah. If you remove some more bone,
Yeah.
it will be more obvious
So
to
this
us.
is, again, I'm peeling the dura off the skull base.
Yes.
As you can see, we are almost down to the middle fossa base.
Yes.
So when I did the craniotomy, I drilled the lower part from the keyhole to the hole I made on the sphenoid wing.
Great.
I mean, I made on the temporal squamma.
Yes.
And you curve that down so that you minimize the amount of bone removal that you need to do.
True.
So all I've done is we had a shelf of bone here, so I just took a ronger and nibbled off a little bit of bone.
Yes.
So that has got me flush to the middle fossa base.
Yes.
So it saves a lot of drill work for me.
Absolutely.
Drill. Yes. Good.
Dr. Anand, can we switch to other OT?
Yes, sir. Yes.
OT.
Hello, sir.
Hello?
Hello, Dr. Anand, yes.
Yes, sir, we shifted to the
this is Ravi,
endoscopic
sir.
OT.
Okay, thank you.
Sir completed the posterior septectomy. And
We are getting another OT screen. So please switch to endoscopic screen. Dr. Ravi.
Sir, are you getting the image, sir?
No. We are getting microscopic image. We want to get endoscopic vision.
Bone wax ready? Drill.
Dr. Ravi, we are getting exoscopic vision image.
Take me.
Please switch on to other OT.
Drill.
We are getting your endoscopic picture in PIP.
PIP.
AV team, can we switch to the endoscopic view?
Astosh?
Sir.
Sir, they need to change there in the auditorium actually.
Yes, sir, we are changing.
Biopsy. Upcut 3 mm.
Ravi, sir, your feed is visible now.
Yes, sir. So
Right.
we have completed the posterior septectomy and we removed the rostrum.
Yes.
As well as the part of the rostrum was drilled out from the floor of the sphenoid.
Yeah.
And sir has removed the mucosa from the cellar region, both from right side and left side.
Right.
And we can see the cella and the midline septa, impression of midline septa, and the drilled out portion of the rostrum.
Right.
The suction is on the drilled out portion of the rostrum.
I'll just show you the nostrils. This is the right side.
Yeah.
And that is the middle turbinate, that's the inferior turbinate.
Right.
No injury to any nasal structures.
Right.
This is the mobilized small septal flap I had taken for
Absolutely.
septostomy.
Excellent.
I'll be putting it back.
Yeah.
And that is the opposite side. Let me clean this. Stabulon वाला मत रखो, बार-बार तो तंग करता हूँ, एक इसको रख लो, दो ही रख लो, यहाँ रख लो.
Dr. Suri sir, have you removed the superior turbinate or not?
नहीं sir.
Okay.
No, there's no need to remove superior turbinate.
I have gently
Okay, sir.
retracted it.
In which condition you removed the superior turbinate?
नहीं. Till now, not yet. I may have to remove it later if I am thinking that I'll have to go till the tuberculum or beyond it. In the next, you can see this is the superior turbinate here on the opposite side, and
So
this is the opposite
this
nostril.
is all through the left nostril
This
at the
is the
moment.
left nostril. So now we have a bi-nostril approach. So the irrigation and the drill can come from this one. This is the middle turbinate and inferior turbinate. That is the superior turbinate there. Dr. Sandesh is absolutely right. We may have to remove the superior turbinate if I need to go above the tuberculum cell leg. Then I need a much more angled approach, and that is the superior turbinate of this side. Till now my posterior septostomy is small. I may have to increase the size later. Then we use an antrum punch or something like that. So some bit draw karo. No, irrigation नहीं चाहिए. Bone irrigation मत दो. Dry.
So for the benefit of the audience, can you show the position of your endoscope through the nose? The scope is in the left nostril.
Clean. Bone wax? Bone wax on number 4 or anything. And I need a a cotton, half an hour of cotton. Section for picture.
So this patient had a pre-cellular pneumatization of sphenoid.
So you have to drill and create more space
Yes, sir.
at the lower part. That's
Yes, sir. The lesion
yeah.
was extending into the clivus, part of the clival bone.
It's just ballooned out the clivus slightly, that's
Yes,
it.
sir.
Yeah.
Cotton, half an hour of cotton. Biopsy. Cotton. Just a धागा काट देंगे, छोटा 1 centimeter धागा. I don't need that much of धागा. That's the technique of applying bone wax. You take a number 4, put it there and take a cotton and just rub it over that. So these are small endoscopic techniques which we don't have in, which we don't need to use in the microscope. इसको बंद करो ना, irrigation, scope irrigation. इनको देख लिया करो बेटा, बार-बार मैं बताऊंगा. Biopsy. Biopsy. Suction. Bleeding has stopped from the clivus. There is a bit more bleeding there. That will be taken. Biopsy.
The same technique of hemostasis using a cottonoid is very much effective in if you're doing a cervical corpectomy, just to tell you.
Yes, sir. Yes, sir. Especially OPLL cases. Saline wash.
So for the audience, as you can see, you have to create enough room so that you don't struggle when you are actually on the tumor. Because as I was telling you, it has been worked out. You are getting a corridor of 1.5 to 1.9 centimeters square to use two instruments and the endoscope. And if there is ooze, or if you're struggling, and you have to navigate into the corners, it becomes difficult. So more you expose, the better you are. So here, because this was the orientation of the cella is slightly different here. It's not a pure cellar sort of sphenoid sinus which is going all around this cella. You have to drill the lower part up to the level of the clivus to gain more space. And I think we discussed that question. The initial part of your removal of the tumor was going to be at the bottom and then the posterior part. So you need that lower part to be exposed with maximum sort of effort.
Can you see the navigation image?
Navigation image, we need to see the navigation screen. We can see your, yes, pointer, yes.
Yeah, so that is the lower end of cella.
Absolutely.
I'm putting exactly where I drilled. That's the lower end of the cella.
Yeah.
And that is the tuberculum cella. Here I don't need to remove it. That is the tuberculum cella.
Yeah, yeah.
That is the right side. That is the right side. Give me some suction view, Ashish. That is the right side.
Yeah.
And that is the left side there. I have to increase my septostomy a bit.
So we have not inserted the MRI images on the navigation. We have used a CT.
Sir, and the bony anatomy is better here.
Right.
And that is the center. I need to go a bit on that side. Yeah, that is the left side, yes. So I think we have the whole view.
Great.
And drill. Sponge order. Wash. Clean.
one comment on navigation. We had noted that even a little bit, like 1 mm extra bony removal, which we do with navigation because of the extra confidence, it translates into better extent of resection. We did a comparative study with or without navigation. So the surgeon's
अच्छा चला, thank
experience
you.
is important, but navigation always helps. It increases your confidence of doing a better exposure, especially in cases where there is a high
Diamond.
likelihood of leaving behind a residue.
Navigation. This is my lower end. That is my
This is just a comment of Dr. Dandapani.
This is my right
If
side.
somebody is not having
Okay.
navigation in
And that is my left side.
in their hospital or their institute
That is
where
my
they are
left
working,
side. ठीक है, good.
this
Now
should
drill.
not
Diamond drill.
prevent them
Thank
from
you,
doing
ma'am.
this operation because you have lot of natural navigation in this individual surgery. You have turbinate, you have stenotastia, you have coina, you have so many things. So, truly speaking, you can perform these operations
Drill
without
irrigation
navigation
on.
also. But yes, if you have navigation, this is luxury.
Yes, I totally agree with Dr. Avdesh. Actually, my point was for people who have navigation, but who think that their experience is better and they don't use navigation for those situations. It's always better that any extra gadget technology, it always can make you little better, not so much.
Definitely, I agree. In certain situations, it is definitely required, particularly if you are it's a redo case, and if you have a conchal type of pneumatization of sphenoid sinus.
So here you see the base is being drilled off so that the angle to operate is going to be from below up. And more you drill the base, more wider you conform the cella, it will be easier for you to reach and the tumor to the top. Otherwise you have to use angled scope. So this is very important, specifically in this particular case where this cella is not complete.
You know, बहुत hot हो रहा है. हाँ, नहीं handle change कर देंगे, बहुत hot हो रहा है. Can you change this handle?
They are shifting to OT3, sir.
This is it.
Hello, Avdesh sir.
Yes, Anand, please go ahead.
Sir, we are switching to the exoscopic OT.
Okay.
Okay, sir. Okay.
Okay.
Switch to the
So I've
exoscope
taken
OT.
off part of the greater wing here. So you can see the tumor going all the way down.
Sir, can you see the exoscope output?
Not yet.
Okay, sir. Dilip sir,
not
just hold
yet.
on for a minute. They are changing it. Is it visible now?
Dr. Anand.
Yes, sir.
Just let me tell you a coincidence.
Yes, sir.
Dr. Ashish is operating, Dr. Ashish is assisting, and
yes, sir.
Dr. Ashish is moderating.
Wow, sir. Yes, sir. It's a good coincidence. And so that is why you are the senior one.
So Ashish.
Sir, it is connected now, sir.
Yes, now we can see.
Okay, sir. Dilip sir, you are live now.
Okay, great. So you can see the tumor. This is what I had shown you earlier. So this part of the tumor, I've taken off part of the greater wing, exposed all this bone here, exposed all this tumor here. This is, I think, the part that's going down into the ptericopalpine fossa. So this is an island of bone. This is the part that's going into the orbit. This is the sphenoid wing. You can see the whole sphenoid wing is sort of mobile there. And you can see the posterior part of the orbital roof is like cardboard. It's
soft.
thinned out. It's very soft. So that shows that the whole thing is expanded by tumor.
True.
So now I will take this, I will continue this cut here and then gradually increase the exposure to this area. The clinoid I should find somewhere there. Down here.
You can use the upcut punch now actually to take that bit out.
Then I'll take the meningoorbital
Yeah.
And then I'll come all the way down. This whole dura will come back.
Yes, it's just, the bone is just coming off.
Yeah. So this whole thing will come off. This is all tumor.
Yep. I think the anterior clinoid is also mobile, am I right?
It should be. It should be.
Yeah.
It should be.
Yeah, that's mobile there.
That's all mobile there.
Yeah.
So we'll take that off slowly, bit by bit. Give me a drill.
Excellent exposure. I mean, it's really fantastic.
Dissector. So this part is very thin.
Yeah, it's mobile also.
Yeah.
So do you recommend using the drill only, or you can do it with rongers also?
Right. This part you can do it with rongers. Hey, I have to show you guys something. Okay, give me a nibbler, small nibbler. छोटा वाला.
Dilip sir, this is Kuntal from the hall.
Yeah, bolo.
Sir, I have also operated a couple of cases on exoscope. Do you also believe in sync? Are you also in sync with me when I say that it does affect your fine movements? What do you think?
I think it's getting used to it. See, we are used to looking, we are used to conventional microscopy using the operating microscope, where we are looking down towards where we work. And that's how we take the tumor, and that's how we perform our surgery. In this, it's a question of realigning the way we think, or how we control our hand movements. So it's a learning curve. It's definitely a learning curve. It's not something that is going to come very easily, but yeah.
Sir, one more thing, means I had read somewhere that like continuously seeing 3D screen becomes very tiring to the eyes, and it causes greater fatigue, especially when you are reaching.
Oh yes, it is. I completely agree with you. Nibla.
So, but if you are doing a very, very complex and long surgery, so microscope, when you do, you are not tired at the end of the surgery. But if you continuously see the 3D screen, we have noted that at the end, your eyes are very kind of exhausted.
See, again, I think it's a question of getting aligned to it. See, exoscopes have come in recent times, and it is a generational change for us. So like when we started adopting microsurgery, so in the same way, I think as we keep working with the exoscopes, we will get increasingly comfortable with the technology and how to use it. And I believe that as in the years to come, the technology itself will improve so that the quality of what we are seeing gets better. And this issue will also be addressed.
So one more thing, like one more problem with Stor's exoscope was that whenever we operate on cases of epidermoid, when things are white, then the focus becomes very bad, and you means because it has an auto auto white balance or auto focus, it makes the image very, very bad. Did you have ever any experience like that while
I have
operating
not
on
used the
epidermoids?
Stor's exoscope. I have not used the Stor's exoscope, but most of these come with settings that can be widely modified. So I think the important thing is you modify the settings as you feel necessary, like the autofocus bipolar. The autofocus can be taken off. The auto white balance, I'm sure, can be taken off. So, on. So I think depending on the requirement.
But the greatest advantage of exoscope is for the assistance. Actually, when we used to do with microscope, sometimes the surgeon is so obsessive about looking that we don't give enough time for the assistants and others to have a good view. The third assistant, the second and third assistants. But with exoscope, because what you see is what they see, so invariably they get the best view.
Now, I think that is a very, very important thing. Because one, your visualization. See, I think we can all accept one thing, that digital technology is going to, I think, replace conventional optics in due course of time. On.
Sir, one general question from the house. We can see that the frontal and the temporal frontal dura in particular in this patient is projecting into your surgical field. So do you coagulate the dura to cause some shrinkage?
You can, but then I don't think it is an issue, because look at this. When I want to work this side, all I need to do is to put my suction there and it moves away. So this is dynamic retraction very typically. So we don't need to, so when I'm working here, I have all the exposure I need.
Yes.
I mean, I don't need this to be retracted. So what I sometimes do is I coagulate the temporal dura to keep this out of the way when I'm working in this axis.
Yes.
But then here again, the tumor has done a lot of the dissection for me. On. So the tumor has done a lot of the dissection for me. So there is a difference, give me a dissector. There's a difference when you're working with a tumor and when you're working with a non-tumorous condition or a small tumor, because then you will have to make more space. But with a tumor, your tumor itself gives you a lot of space to work in. Scissor.
So one more point I'm asking for the house, that one of the requirements to do an extradural clinoidectomy is to completely unlock the dural duplication here and expose it right till the apex. What is your take on that?
Yeah,
do you routinely do it?
See, it depends upon the configuration. Very often you can do a clinoidectomy without unlocking the superior orbital fissure. It all depends upon the depth and the angle, bipolar. It all depends upon the depth and the angle that you get. Sometimes the sphenoid wing is very steep and the axis is like this. The clinoid is buried that way. In that case, it makes sense to unlock this. Sometimes the sphenoid wing is like this and the clinoid is further up. So then it makes it pretty easy to reach the clinoid. On.
Supposing if there is a middle clinoid process, which is a rarity, would it affect your approach to clinoidectomy?
Doing a complete clinoidectomy is going to be a little bit of a problem when you have a middle clinoid. So it's something that you need to look at on the scan, identify it before, and then do that. If you have a middle clinoid, the ring is usually attached to the tip of the clinoid.
Yes, sir.
So you can take the base of the anterior clinoid but leave the tip as it is. You don't want to touch the tip, you don't want to avulse it. Yeah. You don't want to avulse it because then that will put a lot of strain on the structures there. I mean on the tip. So you don't want to do that.
Right. Any question from the house? I again request the members to kindly participate actively. You can express your experiences. You can ask some queries.
Okay. Give me a dissector. Do you have a freer?
So the meningoorbital band has been now removed. The orbital roof which
नहीं बड़ा वाला,
which
थोड़ा सा
was
broad
covering the
receptor.
tumor has now been reasonably removed. The anterior clinoid process is almost removed. So the dura, which was overlying the tumor and the tumor capsule, is gradually getting peeled off. So that is what you're seeing. And you can see this, how the dura and the tumor interface can
that
be
is
so
the
nicely separated.
greater wing.
Again, that's the thin skull base, which is like a cardboard, as has been described.
So that is the remains of the greater wing of the sphenoid.
Yes.
So you can see that plate of bone that's coming off there. So now the whole thing has been denuded.
Yes.
And I'm just peeling this dura back.
Yes.
So you can see the separation plane
Absolutely.
very nicely. There's again a little bit of bone there, but that bone is really not getting in my way. It's very thin, very malleable.
Yeah. Beautiful.
Sir, what you are seeing is this the tumor or a cavernous sinus filled with blood?
This is
What
a
do you
tumor.
think? Right. Sir, as you are dissecting and exposing more, can we go to the next OT
Yes,
and
please.
see? Yeah.
Kuntal, it will take about, hello?
Yes,
Kuntal?
yes.
I think they just want 4-5 minutes more in the other OT.
Bye,
So we can continue here. Kuntal, you can just take the opinion of the house regarding the need of lumbar drain in such cases.
Yeah.
Do they need lumbar drain if we are planning to remove, retach the temporal lobe? What is the opinion of the house?
Ashish sir, what?
See, we have not yet opened the dura here. First of all, even if you open the dura, as it has been told that it's a small opening, we can close it. So you are needing a lumbar drain only if you suspect that the brain is not slack. I think you can't get a better brain than this, and thanks to the neuroanesthetists there who are giving an excellent sort of support. And so the question of needing a lumbar drain is for two reasons. To make the brain lax, or if you're suspecting a massive CSF leak, which I don't think anyway is going to be required in this particular case. The brain is very slack. You are operating parallel to the surface of the skull base. So here the retraction is hardly going to be needed. So why do you need a lumbar drain?
But what to do if the brain turns out to be very tense?
Already, as it was told, you make a small opening in the dura, open the Sylvian fissure and drain out the CSF as you do when you are entering for aneurysm clipping. So you drain the CSF out, the brain becomes slack, then you can again come back out of the dura and do your surgery. So, and you are just at the skull base here, you need to make a small opening in the dura or whatever size opening you want to make. Open the arachnoid plane, drain some CSF, and the brain will automatically become slack. You don't need a lumbar drain.
And sir, there are several other avenues from where CSF can be released. In our institution here, we sometimes release CSF from around the optic nerve as we are going towards the extradural part of the optic nerve. Then as you keep on peeling posteriorly, you can release CSF from the Meckel's cave. And the third option, as sir has just pointed out, you can make a small incision right over the dura, over the Sylvian fissure, and you can release CSF. But the problem is sometimes the vein will pop out through that small opening, making it difficult to release CSF.
Kuntal.
Yes, sir.
So what you do is,
nasal stage
you open the dura here.
Cellar floor drill हो गया.
So this is where you will find the Sylvian fissure. When you open the dura here, you won't have anything.
5 मिनट पैक कर रहा हूँ.
You won't have any issues. So in fact, you'll see the veins, you'll see the arachnoid. Just open the arachnoid, put a patty down there, and you can keep sucking on the patty.
Yes.
So that will give you enough of a CSF release to relax this.
Agreed, sir.
In fact, यहाँ से already I think थोड़ा सा खुला हुआ है dura. There's a
CSF is coming out. We can see.
Yeah.
So it
I
is
mean, that's
very,
all is needed.
Yes, yes.
That's all is needed.
Yes. So the
And
point,
you can see how lax that this thing has become.
Yes, sir.
Yes, sir. Yes, sir. So the point is, it is very, very important to make the brain lax if you're working in the skull base, because sometimes you don't realize that the retraction that you're doing has caused actually contusion of the temporal lobe, particularly if we are also compressing the vein of labia on the left side. So it is always preferable to release some CSF from one of these three avenues that was just discussed. And with these options, the indication of lumbar drain is probably not that much in selected cases.
I think the lumbar drain is an option that has to be considered has to be kept in mind, but it's not something that is very important for something like this, where you have access to a cistern which you can release. The problem comes when you don't have access to a cistern. Then you need to put in a lumbar drain.
Yes.
Okay. Come to a smaller size one.
Dr. Anand, are we ready to switch to the other OT?
Kuntal, just let me check it for a minute.
Hello.
Give me a minute, please.
Yes.
Hello, Kuntal boss, this is Dr. Ravi.
Yes, Ravi.
Yes. Actually, we finished the cellar phase.
Okay.
Sir, cellar exposed. Sir did the adrenaline patching, and we are waiting for 2 more minutes. Then we'll go to our OT.
We have finished the nasal stage. The nasal stage involved a bit of lateralization of the middle turbinates and the outfracture of the inferior turbinates and a very small posterior septostomy. And we took a small flap at the posterior septal on the right side. Left side didn't take it because it comes in the drill otherwise. And then that was the nasal stage. The sphenoidal stage is also done. We identified a middle nasal septum like you saw. We took that off. The lower 1/3 of the sella was embedded in the upper clivus, so it's a pre-cellar type. We drilled that. And like Dr. Ashish Mathak nicely mentioned, that we have to do a very good sizable posterior exposure. That is the inferior one on the vision. That is 6 o'clock, so that we can put our instruments which are guided up. So because we want to see up with all the instruments. So we did that exposure. The cellar floor was then identified, and the mucosa was thick. That was completely removed, whatever we can see. And we have drilled the cellar floor. Initially, I drilled a circle and take a circle out, but just in very few cases, we want to keep that bone back because there's no need actually. And then drill the rest of the cellar floor and confirm it on the navigation. We don't actually need the navigation, but still, since it was there, it was going towards both the sides cavernous sinuses and the upper towards the tuberculum cellae. We just pack the nostrils for another 5 minutes so that it is nice and less oozy when we do the tumor removal. So we just 1 minute more and then we can see.
What's the blood pressure now?
What is the map? 80. Always use for the Vomer and all that drilling, cutting drill is good, but for the cellar floor it's always diamond, coarse diamond. Never cutting, because the more you are closer to the cavernous sinus and the anterior portion, the medial OCR, there is a risk that the internal carotid artery may be just covered by a very thin layer of bone. So cutting drill can actually has been reported to be the cause of damage. So now our team says that the 5 minutes are over. And take out the nasal packs. So saline dal do, just irrigate some saline there.
Can we now have the endoscopic picture on the screen? Excellent. Now we can see how beautifully this area is looking almost bloodless and clean. So both the
Hello.
nasal cavities have been.
Kuntal sir? Kuntal boss? Hello.
Kuntal is not here.
Sir, are you getting the endoscopic image, sir?
Yes, we are getting now. So that's what I was trying to give a running commentary along with the surgeon. Otherwise, the High Court will come, condemn Ashish Suri. That how
So
can
Dr.
he give
Ravi
a
is helping me in that.
Yes. So you've got a runner. You've got a runner. Acha. Okay. Incidentally, I was told that the chief guest tomorrow is a judge, so he might condemn you, Ashish. So be careful. So that's the dural lining of the cella, which has been exposed, and you're seeing it through the right nostril, and you can see how beautifully the whole area has been denuded of the bony covering, and the flap is hanging there. Uh, who is holding the scope for you, Ashish?
Myself, sir.
Acha, yourself.
I'll give it later if I need it.
Right. So all throughout you have been holding the scope yourself?
Yes, sir. Ashish Thakur was helping me with the.
Right.
He's our resident final year.
Right.
And he from AIMS. He was helping me with the suction because we need to hold the suction.
Yes.
I'm holding one instrument.
Right.
I'm slightly. I would have loved if Ravi was there with me because you need a very
You'll
trained
need
person.
little bit of bone removal to make it wider if possible.
Yes, sir. I'm doing that.
Yeah.
I need the navigation
Bottom.
once more and
Bottom
the drill
part.
also. Yeah. Drill also.
It's quite a thick bone actually.
Yes,
I
yes,
thought I was expecting the bone to be thin here.
So if you see the navigation image, I'm at the lower part of the cella.
Yes, yes.
And this is the lower part of the cella. And here, this is the tuberculum. So the up and down angles are okay. I
Yeah.
need to go a bit lateral.
Yes.
Maybe a bit, couple of millimeters on the right, and maybe another more than a couple of millimeters on the left, and maybe
Yeah.
more on the inferior aspect.
Absolutely. More on the inferior is more important, I think.
Irrigation for the drill, please. A small tip here for the youngsters. When you're holding the drill, never push the drill. Hold it like a pen or a paint brush. Let it work itself. You should be just holding it.
And at this phase, I would suggest a diamond bird rather than a cutting bird because you might injure the dura.
Just a comment about drill also. Again, the moving part of drill should always be under endoscopic vision. This avoids injury to endoscope by the drill. And,
Diamond knife.
And while removing the drill, only remove when it is stopped. Do not remove the drill outside the nose while it's moving. Dr. Dandapani, any other thing?
Yeah, that's a very beautiful tip. Actually, most of the endoscopes are breaking in the departments because people don't follow what Dr. Avdesh Jaiswal sir had just told. Because when we switch off the drill, it keeps moving for some time. If we are very meticulous while inserting, but we are casual while taking it out, that
Bone wax?
invariably touches the tip of the scope
Pass me a small
and
piece
it
of
breaks.
bone wax.
So I think this is a very practical.
Cotton. No, don't touch that bone wax. Cotton. Maxi. Monopolar. ड्राई ड्रिल दे दो, ड्रिल दे दो.
Ashish, there's a question from Dr. Jaswal. Do you always use navigation?
No irrigation. Just stop the irrigation for a while. No irrigation. Saline. Scope wash.
See, that was a beautiful tip which you
निकल
saw.
गया, निकल गया.
The bone was oozing, and a little bit of drilling stops the ooze also. So the impaction of the bone dust itself can make a change in the bleeding.
Diamond. Now the dura is nicely visible, and I'll be opening the dura 5 o'clock to 7 o'clock. Diamond knife. They have a very nice instrument. This is a diamond knife.
The ideal one.
It's a very beautiful thing. You can see what you're cutting actually. So I cut it 5 o'clock to 7 o'clock like a semi-lunar. Because posteriorly there's always a posterior intercavernous sinus, and then a small cut parallel to the cavernous sinus.
Sir, where is this knife available? It's not with stores?
No. Pass me a flat dissector in that spiral one.
The tumor is purging out. So
then some extracapsular mobilization of the dura.
oh God, it's vomiting now. Okay, great. So the necrotic areas.
Now flat dissector.
Yeah. So with the.
पता नहीं सर क्या देखते हैं. Flat dissector लग रहा है.
So yes.
Flat dissector.
So it's got gastroenteritis like features.
सर डॉक्टर महापात्रा ने 2-3 पेपर लिखे टीबी, हम ट्यूबरकुलोसिस मिला.
हाँ पता है. Not one. I have at least seen 20. So.
नहीं पास नहीं है सर. नेक्रोटिक सा लग रहा है.
ये necrotic है वैसे.
So this is the best time once some liquid comes out, do a right extracapsular dissection.
So कि brain ही सारा काम कर दिया, तुमने क्या समझ नहीं आ रहा मुझे.
इससे बड़ा है flat dissector.
So you can imagine the pressure which was there in the tumor, and that was one of the reasons you are having the headaches. So moment the pressure is released, the CSF pulsation is good enough to drive out the tumor.
EM, I'll keep the EM here. EM.
So the dictum is first you empty the lower part, and then you go to the posterior part, and then gradually the rest of the tumor falls into the field, and you can easily remove the superior and the anterior part.
इससे पतला section. इससे पतला section. Pituitary लग रहा है सर.
It seems to be pituitary basically with some necrosis. There was a cystic area which was seen on the imaging.
हाँ जी.
So that's basically. Yep, this is.
Pituitary लग रहा है.
Classical
Back
pituitary.
please. This visualization is a pleasure in an endoscope,
Yes,
sir.
yes.
I had done, I think, similar case in yours. So many cases microscopic. I could never get this type of a vision. Back it.
So as you see, the lower part is first being cleared. He is not touching the upper part. And the upper part would automatically fall in the field. As you clear the lower part, you see the pulsation, the brain is driving the rest of the tumor down.
Okay.
And you can see a little bit of arachnoid in the posterior part now, which is bulging. So, so you scrape the lower part so that nothing is left in the lower part.
Back suction. Back suction है ना? नहीं है. मेरा बॉक्स में भी नहीं है. इनका एक कुछ होगा बैक सेक्शन देखो. कार्लस्टोर से पूछो ना. टिप्स बैक Back suction है, back suction, front suction.
So you say arachnoid is now coming to the field and the tumor in the upper and the anterior part is still there. In this situation, whatever you scrape with the tip of the instrument looking down, because otherwise you will puncture this arachnoid. Now, as you can see, he is putting a cottonoid to push that bulging arachnoid out of this field, which will give you access to the front and the upper part.
Correct. Correct.
And you can see the huge amount of space created. All that cottonoid just went in.
Right side, correct. Right, left, correct. Can you take suction and button? Biopsy.
So the upper and the anterior part of the tumor is still stuck to the dura, which in this particular case should come off easily. It's unlike the other tumors, which is quite tough, and you have to really literally, pull them out.
Just push this cotton up. Good. Push this up. Push this up. Good. Just keep it there. Keep your suction there. No need to move. Push this up. Good. Very good. You can remove the finger from that hole, suction hole. Now, cure it. The left side. Right, this side. My right, patient left.
So now he's using an angled curate to scrape out the tumor in the upper part and the front. And that cotton patty is acting as a barrier against the bulging arachnoid so that you don't create a hole in the arachnoid.
In endoscopy, even if sometimes if it's too disturbing, I actually make a hole, sir.
Yeah, that also helps. But normally I use a couple of patty and then push everything up, and then I use a ring curate to hold the left side, to hold the bulge back, and then use another curate. Yes. I think this would do the trick. So this would be a pseudo tumor which has been now created to push that bulging arachnoid back.
Be careful, she's oozing. Get it? Chota wala left, right side. Just keep your suction here.
I think there is some CSF coming out. Am I right?
नहीं sir, अभी नहीं आया. पीछे से
थोड़ा सा आ रहा है. थोड़ा सा.
I'll see. I've kept the glue ready. I've already taken the fat. Gently suck on the tumor.
You have to probably lift this to go to the posterior clinoid region to see if there's anything left behind there.
Right side, chota.
I have a feeling there's a micro leak.
Clean. बड़ा वाला ले लो, बड़ा वाला.
Yes. Now you can see the corner, you can see the bits of the tumor which are stuck there.
Curve section है sister जी.
There's angled suction which is helpful in this
No,
situation.
they don't have it in this set.
Okay,
actually.
okay. The NT guys should be having that. They can borrow it from the NT OT.
Curve suction hai, but it's too big actually.
NT guys use the angled suction.
NT saman.
There's some CSF leak, Ashish. The whole bulge is, is retracting now.
Hold it like that. Get it back, get it. बड़ा छोटा नहीं होगा.
So this view of the base of the cella was or is never possible with the microscope. And that's the advantage with now you see the small bits of tumor which we missed out, now you can see and scrape out. So this is never possible with a microscope because you have got only a parallel vision.
है curve section में. Biopsy. पकड़ो section. हाँ जी. Cotton. दो डाले थे ना. एक बार कंफर्म कर लीजिए कौन सा चाहिए. ये सारा लें. और लेके आ जाओ. Cotton. पकड़ो. Curate front. Fine front. Go wash. Fine front. Fine वाला front. Okay. Fine front. Fine front. Front है fine वाला. Front fine front section. इससे हो जाएगा. सर को दिखा दीजिए जो. हाँ ठीक ये लेते हैं. और एक वो दे दो. फाइन क्यूरेट फ्रंट वाला है. Cotton. Again. Back. Straight section. Straight. पकड़ो section. Biopsy. धागा काट देना. अच्छे अंदर लेके ऊपर लिफ्ट कर. ऐसे. Curate back. You can see the cavernous sinus on the left side here. This.
Yes.
अंदर section डाल. ट्यूमर निकाल. ट्यूमर निकाल. Good. Very good. That's a diaphragma and the left side tumor.
Yeah.
All clear there. छोड़ो. हाँ tumor है अभी. Curate.
I think there's a little bit of tumor beneath that, on top of that cottonoid. Is that right? If you cut this dura slightly in the midline, you might have a little bit of better view.
Yes. Curate. Left side. छोटा. This side. Thank you. Don't move your suction. I'm a very critical place. Suction. बैक सक्शन, सबसे जेंटल वाला बैक सक्शन दोगे। This is very short length. You have a longer length? Wala short. This is the angled suction.
Yes, it's a great help.
Scope wash, please.
Yeah, there's little bit in the distal aspect, as we
Bus
can
off.
see. Yes.
You have a Doppler?
So we can see the tuberculum cella there.
That's the right cavernous sinus.
Yes.
Straight suction. You have flow seal. There's some oozing from the cavernous sinus. Normally I don't use flow seal, just for demonstration I'll use.
Yeah.
Pakdo. Biopsy.
You can coagulate that dura a little bit, which is in the base, 6 o'clock.
There is a bit of CSF leak, a couple of drops coming.
Yeah, I had a rough guess that something is leaking. Yeah, CSF is coming out now, you can see. So that has made that bulge slack, you know.
Yes, sir.
Yes.
इसको ना इसको खाली डोम को पकड़ना है, पीछे नहीं, पीछे ट्यूमर पड़ा हो सकता है, वो भी देखना है मुझे।
तुमको मैं पहले ही बोल रहा था, तुम बुजुर्ग की बात सुनते नहीं है तो क्या करें?
गलत जा रहे नहीं, तुम खाली रखना जो सब करो, मत करो। आप इसको पकड़ोगे? इसको पकड़ो। Good. Can you see? Can I have a curate front angle? Front angle. Thank you. बड़ा वाला है? ये बहुत बड़ा है। इसे थोड़ा सा कम बड़ा।
So now you can see
just
if you
looking as if
yes, you can
just want to confirm if there is any tumor.
Yeah,
at the junction of the diaphragm and the posterior
clinoids.
arachnoid. There doesn't seem to be any here.
Yes, so you can see how beautifully Professor Suri has now lifted the arachnoid, and you can see right the floor and right up to the posterior tubercles. Everything is clear. So that's what you need to achieve. We have seen the cavernous sinus wall on both the sides. So that's what is the aim of this surgery. A little bit of CSF like this can be very easily controlled with using some fat graft and flow seal. Part of the ooze happens when this dura gets lifted up from the bone, the surrounding dura, so that oozes a little bit.
Now you can see the junction of the diaphragma is clear.
Yes.
There is no tumor there. Upper portion is all clear.
Yes.
No tumor there. Saline. Now just hold, and but we have to show everyone the cavernous sinus. Hold the scope. And tilt, a bit tilt. Even the 0 degree, if you tilt a bit, you can actually see something like 10 degree.
Yes.
Now that's the cavernous sinus.
Yeah, it's pulsating. It's pulsating wall. But if you put a 30-degree, you might see it better.
Yes, sir, I am putting.
Yeah.
This is the cavernous sinus wall
Yes.
of the left side. 30 degree scope ready कर लो. छोड़ो, अब अंदर जाना. नहीं, don't leave the scope. Give me a back angle suction. Endoscope, at least we can demonstrate that we have completely removed the tumor.
True. The difficulty comes if the tumor is fibrous.
At least in when I was doing, sir, with my microscope, I don't know, in my hands I never used to be confident I've removed the whole tumor.
What we used to do is that
Okay, 30 degree scope. Biopsy.
Pull this bulging arachnoid down, and that is to peel off most of the tumors along with the arachnoid bulge.
Saline. Just pack this so that hemostasis is secure. Suction. आप suction कर लो. Scope रख लेता हूँ. Straight suction. हाँ, छोड़ दो.
So we are almost at the end of this surgery now.
30 degree scope, please.
So once with the 30-degree we view and see that there is nothing left, so that will be time for closure. And in this case, as Professor Suri said, he is going to use some flow seal.
Biopsy. Okay.
And
Suction. Biopsy. Now count the number of cartons because we'll be changing the scope. पुराने वाला निकाल दिया ना. This is the second one. This is the third one.
Right.
Always count the number of cartons which you are putting in the cellar, supracellar. Even with threads, you can get lost. 30 degree scope, please. इसको फिर मैं वॉश कर लेंगे. 0 डिग्री हमें चाहिए होगा. इसको वॉश कर देते हैं. इसको पकड़ो. गॉस प्लीज. ड्राई गॉस, बिल्कुल ड्राई. थैंक यू. वाइट बैलेंस. पॉइंट ये रहा. पकड़. सूचर ऐसा रखना. 30 डिग्री. सर. Now we have the 30 degree scope with us.
Yep. It's fogged.
Fog. So suction बढ़ा सकते हैं. Biopsy. Saline ready. पकड़ो. Suction. Saline डालो बेटा. एक nostril में ना ऊपर की तरफ ऐसे एंगल कर. हाँ. डाल. 1. 2.
Who is holding the scope now for you?
3. सर अभी नहीं कॉटन देखने Here one small tip, when you're putting the deepest cotton, never put on the side, always put in the center. Even if there's some bleeding from the cavernous sinus, never put on the side. Put some gel foam and then put on the side. Because when you're removing it, it is always, there is some clotted blood and you may have to pull it out, but sometimes you cannot see because of the arachnoid and the blood, and the last thing you want to yank out is the carotid or a branch of it. Suction. Now we can see the cavernous sinus nicely.
So this is 30-degree scope now for everybody's information.
That is the
So you
cavernous
see
sinus
beautifully
of the left side.
yes, the cavernous sinus wall on the left side, and
Scope wash.
the scope needs to be cleaned. Yeah.
I think it's not working in this scope. Something is wrong. Scope wash. On करो scope wash. हाँ नहीं रहा. वो दो. Pass me that syringe. Syringe. Scope wash on. Yes, now it's working. Scope wash. Thank you. Biopsy. पकड़ो suction पकड़ो. This is clear, right?
Yes,
The upper
everything is clear.
diaphragma is clear.
Absolutely. So that's the left side. We are seeing left lower corner, which is clear. We can even see the floor, which is clean. And if you can just push the arachnoid bulge a bit and show the upper part.
दो कॉटन डाले है ना. Check करो कॉटन.
Yes, now if you can angle the scope, yep. So that's the left lower corner and the back, which is
That's
absolutely clean.
That's the cavernous sinus.
Absolutely,
left side.
absolutely smart on.
Suction. Flow seal ready. Suction थोड़ा कम कम. Suction कम. Some suspicious tissue there, but I don't think it's tumor. No, there's no tumor. There's just some blood clot.
Yeah. I think the back part you can see the pituitary also flattened out.
Yes, sir. Yes, sir.
That's the pituitary flattened
Yes,
out.
sir.
Yeah,
Yes, sir.
yeah.
Flattened and orangish in color.
Yes, yes, yes.
That's a normal
That's it.
pituitary.
That's beautiful, beautiful, superb,
Okay. Biopsy.
superb.
Biopsy. Only one cotton inside. No? We can change the suction. This side. There is a very micro CSF leak, saline. Cotton and then flow seal. I always do this last irrigation. Some cotton bit of remnants can be left.
Okay, 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 okay.
तो धागा वागा कभी छूट जाता है सर. Suction, flow seal. There's hardly any bleeding. I may not use this, but I've been told to use. I'm using, and plus, they're giving it ex gratis.
Ashish, can you remove that cotton at first, then
Yes, sir.
put the flow
The
seal?
cotton will help me to keep this flow seal in position, sir.
Okay.
नहीं तो सारा बाहर आ जाएगा.
नहीं वो थोड़ा सक्शन ऊपर करके फ्लोर में दे दोगे तो चारों तरफ ऐसे फैल जाएगा।
वो कर रहा हूँ सर।
हाँ, फ्लोर में दे दो। हाँ। Now you can squirt a little bit on the surface also, so that that acts as a some sort of a tamponade and barrier. Yeah, put a cottonade there and keep it for a few seconds. It will stick there, and then you wash out the extra ones.
Okay. Wait for 2 minutes. Suction. Change of scope back to 0 degree.
Right. So, anybody has any questions? I mean, this was an excellent exposition.
Now I'll be packing it because the arachnoid is down. Not
Yes.
packing it, only putting gel foam. And plus, there was a very micro CSF leak.
Yeah. So anyway, you're going to put a little bit of fat, I suppose.
Sir, the fat also, I'd like to push the arachnoid up.
Yes, that's for
till the tuberculum.
Opticopexy.
Hanji, sir.
Yes, so that's important.
Chiasmopexy.
Yeah.
0 degree laga lo.
Chiasmopexy, whatever you want to use it. So any questions from anybody in the audience? So you saw all this. If there's anybody interested to ask any questions. So basically, this arachnoid bulge can be a problem in the later period. You can have this optic chiasma and the optic nerve prolapsing. Then you have to go in again and sort of push this up. So ideally, even if there's no CSF leak, I would still put some fat there to push all that arachnoid up and avoid any prolapse. So that is to prevent any future case. Yes.
Hello, sir. Yeah, can I interrupt? Yeah, sir, there's a question, please.
So there is a small comment on this one.
Yeah.
Well, if we put fat post-operative just for packing, then it will act as a mechanical, and fat is having ADSCs, that is adipose-derived stem cells. That will again pack it up more later on. Fat is having ADSC, adipose-derived stem cells. That will again pack it up later on after 3 weeks.
Sir, I'm Dr. Vikas Gupta from Delhi. There's one question, sir.
Yes.
Earlier we used to see a cellular floor reconstruction by placing a bone. Is that required, you feel? We don't do it right now, but some seniors still do it.
I already have a cellular disc of bone which I've taken.
Yeah.
But it's not, I realize it's not used. It's not, since you're putting in fat, I like the fat prolapsing out a bit into the sphenoid side. And actually that bone becomes useless. Maybe others can give their comments.
And sir, another question, sir. While using the flow seal, and especially in cellular, so we have had some sort of weird experience way back. Sometimes if it is not washed off early and the amount is more, it sometimes gets calcified and very hard also. So
Calcified?
Yeah, it gets very hard and difficult to remove sometimes. I mean, if you irrigate it immediately after some time, that's fine. Otherwise, it can.
I always irrigate it. I'll just show you.
So that's one weird thing which I faced way back while using flow
So
seal.
it's a recommendation to irrigate the extra flow seal. So that's always recommended. So that's the flow seal company always suggests that.
Yeah.
So this is something interesting. You should have reported that in the literature if there was a calcification of the flow seal. Actually, it is something.
Bleeding has stopped. If you now see the arachnoid is right into the cella.
Yeah. I can see some molecules of H2O. So you better put some fat also.
Yes, sir. More than molecules, sir. Fat. Fat. Got it.
You would like to put a blob of fat, or you want to cut them into pieces?
Small pieces, sir.
Small pieces, yes.
That takes more space.
Yeah.
Blob of fat, actually the problem with blob of fat is if there's bleeding, it'll push the bleeding up and form a hematoma.
Yes. So that I wanted to bring up that question, so I asked in a different way. The other thing is that what I do, I don't know whether you accept or not, I squeeze the fat to maximum so that the water content is out and make it dry fat so that it sticks better. That's my feeling. But I don't think that's a necessity. Yeah, some people do that. I think the adhesive property of the fat is gone then. That's my feeling. But you can argue, you can produce some fibrosis or addition, so it can go both ways. Somebody has to work on that to really prove or disprove what. But is bad. Yeah, true.
Clean. Biopsy.
So I think now, Ashish, we have finished most
Yes,
of the
sir.
things.
Just one question. You want me to do the second case or it's okay?
I'll ask Kuntal, the main person.
Sir, the thing is, we have to close at 4 o'clock. The reason
Okay.
being, we have an international symposium at 4:45.
Whatever you say.
So I'll leave it up to you. We have to finish at 4.
So you are hungry, you are tired, so you need to have food, so you better stop it.
Whatever you say, sir. I can continue till 4 in the morning, you know that, sir. But the organizers have their commitments, I have to respect.
Yeah, so,
And thank you for nice moderation, sir. We have upheld the legal verdict.
Yeah.
I was not giving commentary, thanks to
See, I love
Dr. Ravi.
I love leg pulling, which I've been pulled throughout my
I
life.
thank Ravi for a nice moderation here, and thank you for the moderation there.
Thank you.
Thanks to Vipin.
It was
Thanks
a-
to Vipin, Ashish, Sister Jeena, Sister Sunita, Bito, our teams from SGPJ and
Yeah,
four of us from
everybody
AIMS.
needs a good applause. Thank you.
Thank
and
you, sir. Thank
it's
you
a
for-
well demonstrated case. Very beautifully demonstrated, Ashish. Thank you. Thank you.
And the anesthesia team.
Thank you, Ashish sir. I think he deserves a wide round of applause here.
And we'll not do the second case, sir. I'll gift it to you.
Sir, we are trying to get the second case for you. We'll inform you shortly.
Okay, sir.
So before we break for lunch, which is around 10 minutes from now, I would request Dr. Dandapani, who is a co-moderator here, to show a surgical video to all of you. Dr. Dandapani, please. Audiovisual team, if you could kindly play the video.
ठीक है, we don't need more packing than that. थोड़ा सा बस fat और adjust है.
Can we have the display on the screen? Yeah, hi. I think you're all hungry, so waiting for lunch. So I'll try to finish as early as possible. So I just show some videos on transcranial keyhole surgery for giant skull-based tumors. We have been doing keyhole surgeries for ruptured aneurysms for quite some time. And then because that is the kind of high volume center where I work, PGH Chandigarh, then gradually we started moving for skull-based tumors, started with small tumors, and I will show some of the recent cases. So for most of the, like this is a case of large planum tuberculum meningioma. As you see, that there is a lateral encasement of the carotid artery, or that's what it seemed in MRI. So otherwise we would have done endonasal endoscopic. This is the incision we give. And so only for select tumors we do this transcranial keyhole surgery. Most other cases we do endonasal endoscopy. So for keyhole, the principle is that it is not that we want to do minimally invasive for cosmetic reasons, but we believe that because we are doing a skull base approach, it is not needed to open the calvarium. So we have our own technique which is published in Neurology India. We incorporate the orbital roof in a single piece without removing the orbital rim. So the orbital rim is preserved so that it is cosmetically good, and we can replace the bone flap very comfortably. And the anterior cranial fossa, all the ridges are drilled out and made absolutely flat in extradural plane. Then we open the dura, and as you see, the right optic nerve is the first thing to see, visualize. The tumor is behind that and it is stretched out. And we don't compromise on any microsurgical principles in keyhole. We can open the sylvian fissure, but not on the convexity, but on the base. And then we strip out the arachnoid over the tumor. Meningiomas are extra-arachnoidal tumors. So we'll have to strip out the arachnoid to remain in the extra-arachnoidal plane. And though you can see a retractor is most often used to protect the brain rather than to pull the brain, because we are going through base, and invariably some amount of handling unconsciously is there on the ipsilateral optic nerve. So we'll have to make a conscious effort to remain as far away from the ipsilateral optic nerve. Because of this approach, you see the left optic nerve undersurface and left ICA better than the ipsilateral undersurface of optic nerve. As you see, that is the optic canal where we are removing the tumor on the contralateral side. So the contralateral opticocarotid angle is better visualized. Now we are coming to the ipsilateral side. We identify A1 and we make sure that it is under visualization so that it is preserved. Then we go lateral to the ipsilateral optic nerve. This part cannot be done with endonasal endoscopy. The part where you dissect the tumor plane lateral to the optic nerve and medial to the carotid artery. As you see, this is the carotid artery, right ICA, and this dissection and all the oozing from cavernous sinus, this is better done with a transcranial approach. And the ICA bifurcation is dissected and the tumor capsule is gently rolled under the optic nerve into the midline. Because this was a fibrous tumor, internal decompression, though we tried with QSA, it did not work so much. So at some point, then there was nothing you can do other than QSA and sharp dissection and like internal cutting. So we have to start dissecting the tumor capsule, taking care that the blood supply to the optic nerve is not compromised, and A1 is all the perforators are preserved. So as long as we remain in the extra-arachnoidal plane, most of these objectives can be met. And as this tumor gradually was rolled more and more, then at some time the whole tumor will come out. You can see the pituitary stalk. The pituitary stalk is seen at the end, but in endonasal endoscopy, we see the pituitary stalk in the beginning. You see the left third nerve, left PCOM and all the perforators. And this kind of visualization, the contralateral, so this is a very asymmetric view you get. So we have to be kind of anatomically oriented. In endonasal endoscopy, it's a symmetrical midline approach. We see bilateral equal. But here we see the superior surface of optic nerve ipsilateral better, under surface of optic nerve and third nerve contralateral better. But the problem is to look at the retrocellular portion or the cellular portion which is deeper. For that we use angled endoscope, 30-degree angled endoscope. Then only because we are coming parallel to the skull base. So we need angled endoscope and angled instruments to curate out the tumor which is behind the tuberculum sellae, and also to remove the tumor from the optic canals, mainly from ipsilateral side, because contralateral optic canal we have already decompressed, but ipsilateral optic canal decompression is better using angled endoscope. So this at the end again we are coming back to exoscope. So basically this was a 3D exoscope and angled endoscope hybrid method, in which the advantages of each can be utilized to the best of the patient. And this is at the end we fix with craniofix. So this is the post-operative scan. Sorry, I think. So this is the post-operative scan showing complete excision. But there are certain advantages of microscope. This is a keyhole microscopic and endoscopic. As you see in the depths, the focus is slightly better. The resolution is also better when you are doing full magnification. So, but the problem with using microscope and angled endoscope is you'll have to change the whole assembly. But when you are using exoscope and angled endoscope, you see in one screen in a very smooth manner. See, this is the third nerve. We are seeing lateral to the ipsilateral optic nerve better. This was a case which is going lateral. So this no way we could have done endonasal endoscopic. And this we did anterior clinoidectomy also. But everything was done using a keyhole approach. So you can see the lateral exposure better in this. And as I have already highlighted, the exoscope and angled endoscope, you get a kind of two pictures in the same way. One is 0 degree visualization, and the right side what we are seeing is an angled visualization. As you see, the stalk and the undersurface of the ipsilateral optic nerve is better visualized with, see, this is the stalk. At the same time, you can see the 0 degree view, what you are seeing. This is the ophthalmic artery. You are not seeing with 0 degree visualization at all. This is simultaneous. And this is what we are trying to curate out the tumor in the undersurface of the optic nerve in the canal. So definitely each has its own role. And when we compared, actually endonasal endoscopy is a direct short corridor, but supraorbital keyhole is an oblique corridor. So tumors lateral to optic nerve, ICA and lamina papyracea, then the transcranial approach is better, and tumors reaching frontal sinus also, this is better. Vascular encasement can be tackled easily in transcranial approach. Medial optic canal involvement is tackled better contralaterally in transcranial approach, but in endonasal endoscopy, bilaterally it can be tackled. You achieve early optic decompression in endonasal endoscopy, but it is delayed. Same way, the brain retraction is not at all there in endonasal endoscopy. In supraorbital keyhole, sometimes you may need, but we have to be careful. Arachnoid layer, it is easier to preserve in endonasal endoscopy, but in supraorbital keyhole, we have to take a conscious effort. Sometimes we do a combined approach. For this was a case of chondrosarcoma. This part of the tumor cannot be excised in a subtemporal keyhole approach, but in endonasal endoscopy, you cannot remove this portion. So this we did a combined approach, doing almost a kind of near total excision, in which optic decompression bilaterally was done. See, this side optic canal decompression cannot be done by either supraorbital or subtemporal, but most of the tumor is here in the temporal area, so we did subtemporal keyhole approach. So these are the cases we prefer supraorbital keyhole. Tumors which are going lateral to the lamina papyracea and going little bit lateral with encasement of carotid artery. So the dome can be rolled easily even if it is beyond, but the base cannot be rolled. So any tumor base, meningioma base going lateral has to undergo a transcranial for a complete resection. But in terms of keyhole approach, you come along the base. So this part of the tumor, if you want to visualize, you have to see angled endoscope. So most of the principles I have already highlighted. What are the advantages of contralateral approach? And this is the orbital rim preserving single piece fronto-orbital keyhole is there in Neurology India. So the advantages of microscopic and exoscopic over endoscope, you have kind of hemostasis is better. But in endoscope, if it is a very vascular tumor, it becomes very cumbersome. But these are possible with a full brain, but in endoscope, you need a good space. Especially when you are using a transcranial endoscope, you need good space. But if the brain is tense, you can't do an endoscopic keyhole visualization. So these are the cosmetic results of our cases, keyhole cases. And so there is no limit. Even you can do extradural clinoidectomy and most of the things with keyhole. So this for a case of middle clinoid meningioma, olfactory groove meningioma, this is the case which I showed the video. The review of literature, it shows that vision is significantly better after endonasal endoscopy, but most of the other parameters are equivalent. Gross total resection rates are better with transcranial, slightly better than endonasal endoscopic. So with this, I would like to thank and conclude. Thank you.
Excellent exposition, Dr. Dandapani. Very good. The only thing I would like to add is that there is no competition between endonasal and a transcranial approach. The CSF leak is still a greater problem in endoscopy for large tumors, but the visual preservation is slightly better. But for large tumors, it doesn't matter. We are talking of a different scenario here. But we need to have complementary plan. And anything beyond the optico-clinidal line lateral to that is to be thought of as a transcranial procedure rather than trying to, be adventurous to the transcranial procedure. But experienced hands can still do things in different way. So it is the expert person who is used to tune to doing these things has to decide which is the best way to do. Thank you again very much.
Yes, thank you, sir. Sir, the main objective was I wanted to highlight that in keyhole, you can achieve most of the things what you do with a full craniotomy approach, except if you are planning for a kind of, elective bypass. If you are already planning for that, then that is the only way. Otherwise, you can do clinoidectomy and the similar exposure you will get as a transcranial because you are focusing more on the base. So there is no contraindication for a keyhole transcranial approach compared to an open transcranial approach. So that was the main message. But the indication of endonasal versus transcranial are clear. But again, whether to do keyhole transcranial or open transcranial, that's what I wanted to highlight. So thanks.
You have to wait till you get couple of keloids in the wound, and then you see the patient running after you. So that's, you have to have some more numbers to face that situation. Then you will think, well, what to do about it. Then you have to send it to a plastic surgeon and he's never happy with their cosmesis.
So with this, we'll stop now for the while. And we request you all to go for lunch, which is being served outside. So I'll request all of you to kindly come back to this hall, say after 30 minutes, so that we can continue with the exoscopic case as well as the possible second case of endonasal endoscopic. And I also would like to remind you that at 4:45 today, we'll have a virtual symposium where prominent international speakers would be online making their presentations. So please stay on. And in the meantime, let's go for lunch. Thank you. राहुल वो तब तो कोई लूप चला
साहू is there.
कोई नाराजगी है क्या? चलिए आइए बस चलिए चलिए
this is like if there is a central disc. First I will dissect the tumor.
I hope everyone would have enjoyed the lunch. Now we'll again proceed with the live operative workshop. The first endoscopy case. Are you connecting? Hello? We are connecting with the OT. Endoscopy OT. The first endoscopy case is over. Now we'll be inducing the second case. And meanwhile, there will be few video presentations. Hello? So I first invite Dr. Ravi Shankar sir to kindly present his video. Our second endoscopy case is being induced.
Good afternoon, everyone. I think this presentation wakes from a nice lunch that we had. Again, this is kind of a video presentation. We are having this day for a video presentation, the operative exposure. So my talk will be also for kind of what is our practice and philosophy of dealing a brainstem cavernoma, particularly a pontine cavernoma. So if we really talk about brainstem cavernomas, how has been our practice and philosophy, we will be talking about that. So if we take our index case, this is the 45, 50-year-old gentleman. He had this first episode of headache in year 2013, got and scan done. This is the first thing that we really do for all patients. We get a scan done. The patient had a small left pontine cavernoma, no focal neurological deficits. So this is again for the I'm a mid-level player. We have senior players over here, juniors also over here. So this is mainly for juniors. What will you advise for such patients? That's the first thing that really comes up to the mind. When you see such a scan, the patient presenting with headache, what do you really advise for such patients? Yeah, I just wanted to ask to wake them up from sleep. So what do you really advise for such small lesions, patient not having any focal neurological deficits, just for a headache? So you really advise, so this is the philosophy that we really practice for our patients. You really advise a follow-up, a routine radiological follow-up of the patient. So what we really did in our case was, this was a scan, this was a patient that I was following from my times at Safdarjung Hospital. So again, the patient was advised for a routine, regular follow-up, scan done again in year 2016, no deficit, but the lesion has expanded over the period of time. But as again the patient is having no deficits, so again the patient was told to follow up regularly. And come year 2013, he comes with now a deficit. The patient has a seventh nerve paralysis, imbalance while walking, patient has vestibular symptoms. The patient is now having fixed focal neurological deficits. You can really see in the scan a hyperdense lesion in the left pontine region compressing upon the ventricles. So this is the scan that we got at our hospital. Again, a lesion which is edematous, having no real boundaries or definition, has a pile kind of invasion also compressing upon the fourth ventricle. So this is the time that we really advise a surgery for such kind of patients. So there are many ways of doing a same surgery. What we really tell is you can skin a cat from many types. But what is the regular work of hours of such kind of surgeries is a retrosigmoid approach. So this is the regular surgery that we do for pontine cavernomas. So you go, you drain the CSF, retract the cerebellum, open up the brainstem, and these are the various corridors that you take out the cavernoma from. But again, here the philosophy changes. You don't want to retract the cerebellum. You want to have a very open corridors, a wide operative corridor, so that you don't produce any kind of problems to the patient. And this is how you really do our surgery, a retrosigmoid approach. You see, and once you go inside, for any extra-axial lesions, acoustic, meningiomas, epidermoids, you want to see at the end of the CP angle. But if you are really doing a brainstem surgery, you have to come back again and you have to really see the brainstem. So for any extra-axial surgeries, this approach works. The retrosigmoid approach works for that. But if you are really wanting to come back to the brainstem, you don't want this approach. You want an approach which will take you down back to the brainstem. So this is the regular approach that you really see with a retrosigmoid approach. And this doesn't work well with a brainstem lesion, because if you really have this exposure, you will slide across the surface of the brainstem. You will not come back to the brainstem. You will slide across, go to the front. You will not be able to come back. And if you really want to come back, you will have to retract the cerebellum. You will have problems with your exposure. And the moment we add this procedure to this thing, what we call as petrosal fissure split, the moment we open up the petrosal fissure, the whole thing opens up in front of you. This is akin to opening a sylvian fissure in the supratentorial space, where you open up the frontal and temporal lobe and everything kind of opens up in front of you. Same thing, we take it back to posterior fossa. We open up the petrosal fissure, the superior interlobular lobe and the inferior interlobular lobe opens up, and you can really go direct way to the brainstem. So this exposure changes somewhere from this to this. Now the whole thing has opened up in front of you, and you can really, without placing, if you really remember this picture, the operative video that will come, you will really see the same kind of exposure that we have. So the approach changes from looking forward to going backwards. And this is in conjunction of what we call as two-point theory of doing any brainstem lesions, that you really want to have a line of sight that is across the length of the lesion. So this is the operative video. So the first thing is you have an extended retrosigmoid approach. So we are drilling out the mastoid vein, and we just denude the sigmoid sinus, retract the dura over the sigmoid sinus, so that you really can see the whole length of that sigmoid sinus. Cut open the arachnoid from the neurovascular structures, and now here we are opening up the petrosal fissure. So this is the top is the superior interlobular lobe of the cerebellum, down below is the inferior infralobular lobe of the cerebellum, and we are opening up the petrosal fissure. The moment you open up the petrosal fissure, without placing any retractors, without having any kind of fixed retractors over the cerebellum, you can really open up the cerebellum, and you're not anymore seeing the front of the CP angle. What you are really seeing is the back of the CP angle, the brainstem, and this is now the lesion. This is the flocculus, the ICA vessels draped over the cavernoma. So you dissect out this ICA that is draped over the cerebellum, and without using any fixed retractors, we are seeing the whole surface, the pontine surface. We dissect out this ICA which is draped over the cerebellum. This is the flocculus which is at the below, and once you open this up, the whole thing opens up in front of you, and without any kind of more neural retraction or any using any retractors, what we call as dynamic retractors, you have the lesion wholly in front of you. And now you can really, this now becomes a regular microneurosurgical approach, and you can really take out the lesions. I'll not go into the so if you really see, so this is regular microneurosurgery, what we call as traction, counter traction. You are with a suction, you are putting a counter traction over the lesion and you are taking out that lesion from the brainstem. You dissect it out. We use different instruments. This is a round knife kind of thing to dissect out the lesion from the brainstem. You create those spaces all around the brainstem to take out the lesion. So nothing different from a standard microneurosurgery. So this lesion was kind of permeating. You can see the facial nerve which has been discolored. So the whole facial nerve was discolored with the cavernoma. So we had to go back again to the facial nerve, take out some arachnoid, dissect it out from the cavernoma. So this lesion was kind of coming out to the surface also, inside the brainstem also. So we dissected out the facial nerve again from inside out, both from the brainstem and from outside also, and took out the lesion. So this is post-op scan, and this is the patient at the end of 10th day when he came back to the clinics for suture removal. No new focal neurological deficits to the patient. The patient was as before. The patient is now under follow-up. This is 2 months now down the line surgery, and we are waiting for an 3-month scan at the end of the surgery. Things change. Things change. Once you start doing regular cases, simple cases like this, you go on to the next level. And what is that next level? The next level are the recurrent lesions where the boundaries have been lost. The thing is now obscuring the natural boundaries that you have in first cases. So this was a case operated first time for an AVM. So first time these lesions are so vascular on regular scans that you think them to be an AVM. So the first time he was operated for an AVM, clot was removed in year 2020. Again, in the same year, he underwent a second surgery. Now they were wise enough, knowing that the lesion is a cavernoma. Then they went back again, operated, couldn't take out the lesion. And this is the scan that he came to us with. So now the whole boundaries are lost. You are not having that regular kind of natural barriers or natural boundaries that are there in the lesion. The whole lesion is kind of meshed up with the brainstem. And you really, once you kind of submit yourself to these kind of surgeries, you know that you'll be having a hard time going inside. You'll not be having a regular boundaries or the natural boundaries. So this is the surgical video of the patient. So this is kind of like flying in the dark. You are flying in the dark when you go ahead with such kind of surgeries. You don't have that natural planes to dissect off, and you have that your gut feeling to kind of dissect it out from the brainstem. So you try to see spaces, you try to create boundaries, you try to create planes from where you can dissect it. So this is the brainstem. You see these large vessels, these large cavernoma vessels, the venules, what we call as large venules, which are present across the brainstem. You start creating planes, start creating spaces, you dissect it out from the nerves, neurovascular structures. You really don't see till the end of the surgery that what you are really dissecting upon. And once you have done, you feel that you have done a good job, and you take out whole of the lesion. But again, these lesions are not something regular. You really are, with your gut feeling, you are doing such kind of surgeries. But at the end of the 6 months, this is the scan that you really get. The whole lesion has been taken out. Now the lesion is free. You have a patient who was kind of given up. The patient, when he came to our clinics, was given up because we can't do much about it. The patient was told, you'll have this, you'll be bedridden for your life. We can't do much about it after 2 surgeries. But now he is kind of independent. He's having that deficits which he started upon with. The facial nerve paralysis is still there. He is having still some bit of hemiparesis. But yeah, again, he becomes independent. Now he has started recovering. This is at the end of 6 months. This is some challenging case that we really, I really want to put it at the end. So this is a 9-month child of a surgeon, a doctor's son coming to you, 9 months with this lesion. The lesion was told to be an ATRT. The radiologist reported it to be an ATRT kind of a tumor. We were not very sure that this is what we are seeing is an ATRT kind of atypical tumor over here. So again, for youngsters who are starting their practice, you have to ask for help. Whenever you are in doubt, I am in the mid-level. I have made my own set of mistakes. I have gone through my own learning. But once you are starting with your learning phase, don't be afraid to ask for help. And this is the help that I asked from my seniors. What should I really do for these lesions? these lesions which are kind of first in my life, you see it once in a lifetime of a case, what should be really done for such kind of cases? You ask for help. And you get all the help from all the seniors who are experienced in these cases, and then you decide what is best in your hand. How, see, one of my teachers also told me, do a petrosal approach for this child, a 9-month child. Is it really safe in my hand to do a petrosal approach for such patients? No. So you really have to know your boundaries also, that where you start and where you end. So once you know this is my limits, this is best in my hands, you go ahead and do such kind of cases. So again, we did an retromastoid craniotomy for this 9-month child, once in a lifetime kind of case, and this is the end of the lesion, end of the surgical result that we got. The patient is now kind of living on her own, the child has grown. I wish I could have shown the photos of the child, but the parents told that we really want you not to, they are having that thing for their child, they don't want to show the photos of a child who is now kind of active. And this is at the end, you again want to, everyone tells that you should remember your bad cases. I'll tell you, remember your good cases also. You remember what good you have done for your patients. Remember the bad as well as the good that you have done for your set of patients. So my philosophy for such cases are that for every brainstem cavernoma that you are operating on, location is the guide, what approach that you really want to take. The location, and anatomy of the location, how the structures are incorporated all around the lesions dictates the surgery. For pontine cavernomas, extended retromastoid approach where you denude the sigmoid sinus, that you can really roll the dura upon the sigmoid sinus is the first step of getting a good exposure. And trans middle cerebral peduncle approach exposes the pontine brainstem cavernous malformations. Extended retromastoid facilitates proper trajectory, and the petrosal fissure is the Sylvian fissure that you really have to know upon how to separate the petrosal fissure, that you can really get an unobstructed view of the brainstem without any use of retractors, so that you have whole of the anatomy in front of you that you can really take out the lesions safely upon. Thank you so much. Thank you, sir.
Thank you, sir. Trans-petrosal fissure approach to middle cerebral peduncle is an elegant procedure and a must to have an armamentarium for any skull-based surgeon. Sir wants to comment. Sir. So,
hello. Hello.
Thank you for Dr. Ravi for a great presentation. It's really great, and congratulations for this. The only issue is that you said sometimes it's difficult to find out where to approach all your cases. But do you use tractography when you're doing a brainstem lesion? Because that's common practice now. If it's not available with you, you can get it from other centers.
Yeah, we are doing DTIs and tractographies for a patient. But again, once you are inside the brainstem, how much it really helps is a question mark. You really at the start of the surgery, you know that which way you have to really go. But once you have gone deep inside the...
It's a question of finding the point of entry.
Yeah,
so that was the lesion. And specifically for small lesions, must.
Yes.
Your lesions are so big that they are practically welcoming you. So you can do that very easily. But for any brainstem lesion, DTI specifically showing the motor tracts are to be considered as an important preoperative investigation.
But then again, I'll ask that question from you, sir. As in senior guy, do you really operate upon a small lesions anymore? What is your
it depends on
philosophy?
how symptomatic the patient is.
Yeah.
And you know that in our country, many times, if it's a sizable lesion, when you tiny lesions, okay, deep inside the brainstem, you have to wait and watch. There's no doubt about that. But sizable lesion, which has already become symptomatic or bled once, you have to think twice in a country. If you lose the patient will come back, after 1 or 2 years with a catastrophic event.
The problem again is in our practice, again, if we take our Indian setup, the patients will go different places. You give them an option for surgery and someone else says, and that has been the kind of practice that we are following upon.
Absolutely.
Surgery is not an option. You can really, and with the advent of radiosurgery anymore in our practice, we have had our patients where we have told that surgery is a better choice for these set of patients. But then again, someone has said a radiosurgery is a better option. And I really, whenever I am telling
Radiosurgery in cavernoma is still a very debatable option.
that's the problem. But again, someone says that radiosurgery is an option, the patient will take it with both hands, that radiosurgery, no, I don't want any invasive surgery, I'll go for radiosurgery. And then it becomes a problem of giving the...
Most of the cases that you showed are beyond the realm of radiosurgery. The size, of course, is nothing
the small
to do with
ones,
it.
the small ones.
Small ones, it can be an option.
Yeah.
But again, the question is, one has to be very honest and put his hand in the heart and say, yes, this can be cured with radiosurgery. But some centers have shown some result.
Yeah.
Symptomatically, they can be better, but it cannot make the lesion disappear. That's the problem.
That's the problem. But the patients will always take with both hands option of radiosurgery.
I know. And now in most of the major centers, they are using intraoperative neurophysiology also for such situations.
We are doing, I could have shown we use that in every of.
So that is also something to be considered. Otherwise, surgery cannot be safe in all cases.
True.
Thank you.
Thank you so much.
Thank you, sir. Now, I request Professor Arun Kumar Srivastava, sir, to share his video.
Thank you so much, Ashutosh. Actually, the second case, endoscopic probably pituitary adenoma, is actually in the process of induction. So before that, we are just taking you through some videos. So basically from last 5 years, along with my colleague, Dr. Kuntal Kanti Das, actually we are trying to venture in the field of cavernous sinus, which was one time known as no man land. So what happens when we actually think about our traditional approaches, like we want to traverse from anterior intrahemispheric fissure to the CP angle, and if we are having an oblique approach, so our the biggest limitation going to the midline is the cavernous sinus, we believe. So we think it's like a hurdle. The cavernous sinus is like a hurdle when you are going for some midline lesion, a complex lesion, and if someone teaches you the art of making this hurdle disappear, and such a place which is actually considered to be the no man land, then definitely you are going to have good time and your surgical outcome and your area of surgical practice will increase. So that is what we have learned over last 5-6 years. And now we started utilizing this transcavernous approach. This is our first-hand experience with basilar tip aneurysm, paraclinoid aneurysm, some complex PCOM aneurysm, the indication where you need some tailored peeling, means limited transcavernous approach. Some tumor, I will be talking about like craniopharyngioma, hypothalamic area tumor, pontine lesion. Clinoidal meningioma, very routinely we are doing. I'll be sharing one video. And many indications we are actually utilizing this transcavernous approach. Full transcavernous approach are tailored. So vascular, basically what actually this transcavernous approach, how it's going to help us, because the literature says very clearly, when you go through the literature about any complex vascular pathology like aneurysm, you will find two statistical significant variables. One is procedure-related brain injury, and second is the perforated artery injury. And then when you will keep on thinking, like any neurosurgeon, we know literature is one thing, common sense is the second thing. And I think common sense, if you will start utilizing, you will start understanding why literature is going in some direction. So what common sense tells us, actually the deep and narrow corridor and the area, actually you are exposing a lot of brain, actually leading to this brain injuries, and you are actually making this corridor narrow. That is why you are inducing a lot of morbidity to the patient. So if you can cut down that, and the answer is transcavernous approach to that. With this approach, you are able to, have, like in paraclinoid aneurysm, you don't need to have control in cervical area. You can have control in the clinoidal segment of ICA. So your proximal control is actually adjacent to your surgical field, and you can add that clinoidal segment in your part of the aneurysmal anatomy, and that further helps in improved clipology. So I will take you through this video of 60-year-old female presented in poor grade E2V2M5, and then recently operated a case of basilar tip aneurysm. So you can see a V3 coming through the ovale, V2, V1 in the field. We are opening the Michel's cave. And the Michel's cave opening releases a lot of CSF from the Michel's cave and makes the brain lax. So V3 coming from ovale, V2 from rotundum, V1 from SOF, vertical part of SOF. Now we are in the process of doing the extradural clinoidectomy. Now you can see all the nerves starting from third up to GSPN with this elegant approach. Now, as I was talking about, not exposing the brain, which is actually not required during the surgery, and that will definitely decrease the morbidity. So cutting the distal dural ring, now you can see the posterior clinoid. Behind that, you can appreciate the Lilliquist membrane, and we know the aneurysm is hidden behind that membrane. Now you can see the third nerve lengthening has been done. You can see the posterior cerebral artery, PCA, and you can, trace it back to the basilar trunk. So again, the advantage, you can identify the perforator-free zone of the basilar trunk. You can see the opposite SCA, opposite third nerve. And by tilting the microscope, we can very well appreciate the opposite PCA. So, it actually made this very deep structure, the basilar tip and basilar trunk, very superficial. And this is actually the operative view you can see. And still I'm using small handle bayonet and instruments. So opposite SCA, opposite PCA, opposite third nerve, ipsilateral SCA, third nerve, and PCA. So this is what I was able to see like this. Basilar tip to the mid basilar trunk. And you understand, if you are able to have this kind of exposure, definitely the two important components, perforator injury and procedure-related brain injury, is going to be very, very minimal. And that is what is going to add to your good outcome. And having multiple surgical hand, like after this, my colleague Dr. Kamlesh has joined me in clipping the aneurysm. So now you can see no perforator was compromised, aneurysm was well clipped. The only thing is you need to have a very robust repair in transcavernous approach, and we are doing from many years, and we never had major issues with that. So the same art is utilized in various, many paraclinoid aneurysm, and we have clipped, I think, Kuntal, more than 18 cases of paraclinoid aneurysm using tailored transcavernous approach, where we are, peeling up to the V2, rotundum. So now coming to the next very interesting indication is the clinoidal or medial sphenoid wing meningioma. And when I gone through the literature, what I have found that 60 to 65% cases we are able to achieve Simpson grade 1-2. So in majority of cases, like 35 to 40%, we are not able to achieve the good excision. And the limitation being the invasion of the tumor inside the cavernous sinus, morbid encasement of the second and third cranial nerve, and internal carotid artery. Then further, our problem is complicated by the fibrous to firm consistency of the tumor, and that in literature is around 65 to 70%. But nature has its own answer. Nature is saying 80 to 90% of these cases are WHO grade 1. And then the recurrence-free survival is also very, very good. Only, recurrence-free survival is ranging up to the 90%. And whatever the recurrence are there are very elegant answer to those recurrences, including the stereotactic radiosurgery gamma knife. So I don't find any confusion or doubt if I want to ask about the best possible treatment option for these tumor. And I think all of you will agree with this maximal safe resection. But this is easier said than done. And second thing, it is only a very subjective thing. It's not having any objectivity. For me, leaving 60% tumor is maximal safe resection, and for other good surgeon, leaving only 10% of tumor is maximal safe resection. So what literature says about this residual tumor? If you are leaving the tumor where they are having internal feeder, or you are leaving the tumor or the major arteries or vascularized structure, they are going to grow. And second thing is, if you are leaving more tumor, the recurrence rate is going to be high. So again, the answer is the maximal safe resection has to be in objective sense, not in the subjective sense. So what we are opting to address this in last many years, these advantages are offered with tailored transcavernous approach in cases of clinoidal meningioma. First thing, the clinoidal meningioma is, we are making it a convexity meningioma, and we are having early ICA control through this approach. And then we are able to trace the optic nerve, third nerve, and ICA in antegrade manner. I'll show you through my video. And we are able to devascularize the complex dural network, complex ligamental network at the base, which are arising and terminating over the anterior clinoid process. And then you can very well control the cavernous sinus bleeding in early part of your surgery. So I think this tailored transcavernous approach is very good answer for unique subset of clinoidal meningioma. And literature talks about many types, but a lot of Indian neurosurgeons will agree with me that our scenario is most of the time like this. Huge tumor, invasion to the pia, adventitial invasion to the major vascular structure. So we are trapped with these kinds of tumor. So knowing this elegant transcavernous approach will definitely help you to achieve good result. So I will take you through this case, left-sided clinoidal meningioma, no doubt about this, the diagnosis, as the radiological hallmark of hyperostotic anterior clinoid process is well evident, and you will appreciate in upper third cut, the most right one, the lesion is going through the oculomotor triangle inside the cavernous sinus and touching the intracavernous ICA as well. So it is encasing the supraclinoid ICA and going, and maybe 180 degree it is encasing the intracavernous ICA as well. So I'll take you through this case, a left-sided frontotemporal craniotomy with zygoma lowering technique. We usually start with posterior arbutotomy. In 5 to 7% of cases, orbitomeningeal artery traverses through a separate foramina. Now, horizontal SOF is open. You can appreciate the orbitomeningeal band coagulated and cut in the direction of the dural groove. You can see the cavernous dura and junction of the temporal dura, and sharp dissection in that direction will start the peeling. So here we are not going to peel just like last case basilar tip, and we are making this cavernous sinus avascular by instilling glue between V1 and V2. So here we have done the peeling only up to the V2. Now we are in the process of doing the anterior clinoidectomy by taking out the anterior root which form the roof of the optic canal. Then sharp dissection, n number of dural attachment, reflection attached to this clinoid process, you need to sharply dissect. This completes the clinoidectomy. Now you can see the clinoidal ICA, there is a sheath of tumor over that. Now the intradural part, again opening the dura at the base, not exposing the brain much. One retractor just protecting the frontal lobe. Now we know there is a tumor cuff between the ICA and the distal dural ring. We can cut it very without any complication, but just for the sake of teaching, I put a dissector and I shown my colleague that it is very safe to cut the falciform ligament over the ICA, as there used to be the cuff of the tumor between the ICA and falciform ligament. Now I said that I'll be able to do the antegrade dissection of the tumor over the ICA, and you see the ICA, and you can see the optic nerve. The optic nerve sheath is here, and optic nerve is here. So the tumor has actually displaced the optic nerve beyond the optic nerve sheath. Now this transcavernous approach can give you the exposure, as I mentioned in my first slide, anterior interhemispheric fissure to the mid-pons level. Now we are doing the retrograde dissection by identifying the middle cerebral artery, and we are able to do the safe decompression of the tumor. You can see the P-cone. Now we are going to chase the tumor which are going in the cavernous sinus through the oculometer triangle. Now you can see the intracavernous ICA, and you can appreciate the sixth nerve draping over the intracavernous ICA. So this kind of control is possible with tailored transcavernous approach. Otherwise, if we would have gone in a traditional way, it would have bled like anything, and probably saving these nerves would not been possible. Now the classical microneurosurgical technique, we know this is the third nerve. We know this tumor is encircling the ICA. Never pull it out. Never try to pull it out. Just have your strategy, as Dr. Ravi Shankar was talking about. Have your strategy. If required, ask for the help. And do, take time and do sharp dissection as far as possible. And here, once we have dissected, we are not going to pull this tumor. We have left this tumor, and now we are cutting from this side. So these are information is very, very important when you are dealing the tumor like this, the complex tumor, which are actually known for their morbidities. And on other hand, they are actually very, very benign. So now I can very well say to my patient's relative and my patient that I have done maximal safe resection in true sense. Again, as I talked about, the repair is a bit challenging, but with time, you will learn the art of doing the repair. Now, the third case is actually contributed by Dr. Kuntal Kantidas, and I really appreciate that, because we are doing this transcavernous approach in retrochiasmatic craniopharyngioma Why? Because they have some specific challenges. They grows in the third ventricle, often grows to the posterior fossa and covered by the neurovascular structure. And calcification and lateral extension makes it more vulnerable for surgical morbidity. So with keeping all these things, we gradually started utilizing this transcavernous approach, that too obviously tailored one for these kind of retrochiasmatic tumor with lateral extension to the middle fossa and posterior extension to the interpeduncular fossa with severe hypothalamic indentation, and if they are having heavy calcification. It's not sacrosanct. We are just seeing if most of the factors are there warranting transcavernous approach, then only we are opting transcavernous approach. Now the other challenge for, I think, for Kuntal was this 3-year-old female. I mean, you need to have a good dissection without adding to morbidity, because this child could not be sent for the adjuvant therapy like chemo or radiotherapy. So with this in mind, he has gone with this transcavernous approach, and he has beautifully shown how to modify this triennial approach with a mini tailored transcavernous approach. Beautiful peeling of the temporal dura from the cavernous sinus dura, followed by the stepwise anterior clavicectomy. As I said, we are in mini peeling, we are doing peeling up to the V2. But here, we have gone up to the foramen of Ubwell. He has released CSF from the Michel's cave, as this case started with a very tense brain. Completion of the clinarectomy, again the beautiful anatomy, second nerve to V3. Again the opening of the dura at the base to avoid unnecessary exposure of the brain. Now you can see the tumor between interoptic space, keratoco-optic system, lateral to the carotid. You have good exposure. And then obviously then the classical microneurosurgical technique. We know the size of the tumor and the corridor is mismatching, so we have decompressed the tumor, and in piecemeal we have delivered the tumor. You see that we have some liberty while manipulating optic nerve without compromising mechanically as well as the vascular supply of the optic nerve by this elegant approach. And in very single go, we are able to see as high as toward the hypothalamic area, as low as maybe the mid-pons area, if we are going to open the Liliequist membrane. But in this case, we don't want to open the Liliequist membrane because that is the normal physiological barrier for this craniopharyngioma to grow into the posterior cranial fossa. Nice dissection and removal of the tumor. Almost cross total excision of the tumor. You can see the hypothalamus. So this is the beauty which by tilting the microscope, or if you have done the malar up, you can see right up to the hypothalamus with this approach. So it's a very good feeling when you see your patient doing well with such a demanding, challenging surgical approach. And the best thing is there was no residual tumor warranting any adjuvant therapy. So we had the window of having child grow further, and we can follow up the child. So advantages is specific to the retrochiasmatic craniopharyngioma is there is a minimal approach-related brain injury. The conventional corridor, as beautifully shown by Dr. Kuntal, was expanded, and there was a wide access to anterior, central, and middle and posterior midline skull-base structures, and there was a very good control from superior to inferior and medial to the lateral. So to conclude, the transcavernous approach, as per me, complement and completes the art of microneurosurgery. But definitely you need to know the art of case selection. Cadaveric course is very, very important, as we are doing in this conference as well. Gradual translation from cadaveric to the real cases, definitely learning curve is required. And if you are doing these kind of approaches, you should not be spoiling your case because of the poor repair. So give enough time for a robust repair. I would like to thank Dr. Ali Crest, with whom I have grown in the area of this transcavernous approach, and my colleague Dr. Kuntal Kantidas, who keeps on helping me in developing this very elegant surgical branch. Thank you so much for your patient listening. These are my references. Thank you.
Thank you, Professor Arun. As usual, very great presentation. I really liked all your expositions. My only little bit of hesitation is like the last case of craniopharyngioma which you showed. That's a standard skull-base approach for going, optico-carotid or inter-optic approach. So that's, should I call it a transcavernous or not, is my hesitation. Yeah, that's basically a standard skull-base approach to deal with a large multi-segmented calcified craniopharyngiomas, and this is the usual practice that we do. We try this corridor, remove a little bit, we go through other corridor on the lateral side, remove a little bit, then pull it out this way, that way. But a great presentation and beautiful work. Thanks to Kuntal also.
Yeah.
He is now showing his elegance, so that's really great. Thank you.
Actually, sir, the doubt you have raised is very, very valid doubt. That is why Kuntal in his video, in his presentation, I incorporated. He said that the, modification of perirenal approach to a mini, you can say tailored transcavernous. Why we are adding the word transcavernous? Why? Because we have peeled the dura, temporal dura, from the cavernous sinus dura, that is the true cavernous membrane, up to the V2. If you take it up to the V3 or beyond that, it gives you a lot of space. And by cutting the dura at the base and cutting the DDR, actually we are sitting on this structure. So as sir is rightly pointed out, we have modified this approach from a very deep approach. The structure was deep, has become very superficial for us. First thing. Second, we were able to mobilize the optic nerve. We were able to mobilize the ICA because we have released the, anchoring structure. From ICA, we have released the DDR. From ICA, we have released the sheath. So we were able to, manipulate. So we have, though as sir said, we have utilized the natural corridor. But as he already mentioned about the advantage, those corridors were expanded, I think, by 1.5 times, I believe. I mean, we don't have any objective criteria, but those corridors were enlarged, sir.
Absolutely right. But anterior clinoidectomy itself acts as a very big gateway.
Yes, no doubt.
To the skull-based region. And this sort of craniopharyngioma, either you go through anterior clinoidectomy, or if you have got translaminar, then you really have a huge space to remove. And specifically, if you have to shell it out from the hypothalamus, translaminar is a very good approach.
Again, I mean, just basically, sir, we are doing a project with the help of Arkansas University and all, and me and Kuntal into that. Basically, when you are coming oblique, the vascular insult to the optic pathway is very, very less. When you are coming from the midline, the vascular insult to the optic pathway, both the optic nerve and optic chiasm is seen more. They have actually proposed two theory. One is obviously mechanical. That is why in tuberculosis meningioma, you see more incidences of vascular complication when you're doing from the midline and compared to when you're doing from the oblique approach. And second thing is that these peeling, basically gives you, because we are cutting the dura, not only the just lateral to the sylvian fissure, we are going right up to the base of the temporal lobe. So you will see that actually we don't manipulate if temporal lobe at all during the surgery. It is all retraction-less surgery. So that is one advantage maybe I have noticed over the year.
Yeah, excuse me, I have a small, first of all, congratulations for the nice presentation to you and Kuntal. Just want to know whether you are dealing with these transcavernous approaches, and I have seen Dr. Vikas from Nimhans also is doing this. At many places I am hearing this approach from the previous, from Arkansas. The thing is that when you are dissecting the cavernous sinus and mobilizing all the nerves, what is the post-operative ocular movements and the fifth nerve, and how is your optic nerve, as you just answered? What are the deficits you are likely to have, and did you have it at least in the beginning, and your opinion?
I think a very valid question. Basically, if you are in the right plane, if you are peeling in the right plane, believe me, no morbidity will occur. That is for sure.
Including the third nerve?
No, I'm talking about peeling in the right plane. So I think, I don't know, I'm not very, means only 5-6 years I'm doing this, but at least I can add one thing. In the beginning, when you have cut the orbitomeningeal band, you are going toward the dural groove. You have seen with experience or with your senior help, you are in the right plane of the peeling. Nothing will happen. But the moment you think that you have gone towards the temporal side more or towards the true cavernous membrane, stop there. This is going to add to the morbidity. Then you will have third nerve palsy, fourth nerve injury, V1 injury, and this is all very, very morbid. So we do have, still we are having third nerve paresis. And in most of our cases, the paresis improves in 4 to 6 weeks.
Yes.
Literature says, and we have also seen, if there is a fourth nerve palsy and sixth nerve palsy, they usually don't improve after the surgery. But the paresis is also very, very alarming red flag. If you have seen that, be very careful. Probably you are going to produce prolonged deficit or maybe permanent deficit. So I think the answer to your doubt is peeling in right plane. If you're peeling in right plane, nothing will happen.
I think he's also to be supplemented that you have to be more concerned, specifically for craniopharyngiomas, about the endocrine deficits which you can produce or that can be aggravated. So that's something more important, because as he rightly pointed out, if you're in the right plane, if you're respecting the arachnoid and the pyarachnoid, and you're peeling off, taking care that you don't disturb that, nothing is going to happen. But it's the main thing is if it's stuck to the hypothalamus, big lesions, craniopharyngiomas or skull-base lesions, and there if you're trying to be more aggressive and adventurous without really trying to see how carefully you can separate out, that's where you can produce more morbidity, and that even you can even kill the patient also.
Yes.
No doubt.
Thank you.
So no more question?
Yeah,
Yes.
really, Arun sir, congratulations. You have shown that, you have shown the victory over the no man's land. Still, it was lacking. All the skull-based meningioma which were entered into the cavernous sinus till date, people say that the maximum safe recovery is the maximum safe resection would be the best answer because of deficit. But you have shown beautifully that you can enter it and you can excise completely. What is your experience on cavernous meningioma? Till date, it has shown that because you should leave it, or gamma knife or something. So till you say that because of transcavernous approach, now it's maybe easy, can you excise completely, or you should leave it some things, and what is your experience?
I think the limitation to those cases were exposure and bleeding, I believe. So exposure with this is actually excellent. And if I have to answer your query, is actually the true, there's nothing like true cavernous meningioma. It's like adjacent structure, sphenocavernos meningioma, part of it's this complex meningioma, one part is going into the cavernous sinus through some wall of the cavernous sinus. So as a package of a big meningioma, if you are going to deal with the cavernous meningioma, cavernous part of the meningioma, it is not that challenging. But as you talked about, in some isolated cases, the cavernous component is big and extra cavernous segment is small. Again, it's all related to the ICA, intracavernous ICA, cross flow, and then strategically planning your surgery. So what we are saying, we are not having very good experience in cases of true cavernous meningioma, but we are having good experience in petroclival, spheno, caverno, those kind of complex meningioma as a part going into the cavernous sinus. And there we are doing very simple thing. If soft suckable, you know, tumor dictate, take out the tumor and it comes out. But if it's fibrous form, we follow the principle of not manipulating much, because yes, as I mentioned, we have multiple non-surgical options. So there's no heroic surgery, only, you know, stopping at some point.
Thank you, sir. I think on this topic we can keep on talking for a whole evening and whole night. However, our second case is already induced, and now we'll move to the second endoscopic case.
Hello.
AV team, can you get it on the main screen?
Hello, Astush.
Sir, you are audible.
Yeah, actually we have started with the nasal phase. The patient, actually this patient is having the bilateral conchobulosa of middle terminate. So I'll just show the etiology. It is interesting. एक बार इधर फोकस करिए, मुझे कोई इंस्ट्रूमेंट दे दीजिए, कुछ इंस्ट्रूमेंट. Astush? Hello?
Sir, you are audible.
Yeah, so are you able to see the coronal sections?
Sir, can you make it like head on with the camera?
भाई मेरा इंस्ट्रूमेंट इसको दिखा दीजिए. Able to see that?
Sir, can you focus it a little bit? Yes, sir, now it is visible.
Yeah, so this is the coronal sections from anterior to posterior. The anteriormost cut, you can see that the appearance of inferior terminate and the bilateral middle terminate. Both the terminates, the vertical lamella got pneumatized. This is called conchobulosa, right? So this, whenever you encounter the conchobulosa, there is a compromise in the nasal corridor. So how you manage these kind of scenarios? Today morning also we discussed how to deal with the middle terminate, especially in conchobulosa. Instead of sacrificing the middle terminate, what we usually prefer is a lateral laminectomy. So I already done the lateral laminectomy, but I will show how I did the lateral laminectomy to make the corridor. Hopefully you are able to see the bilateral conchobulosa on the next cut also. And this is the inferior terminate, this is the conchobulosa on bilateral middle terminate. Again it extending more posteriorly, again extending more posteriorly, and it is going to the opening into the posterior ethmoids. So this is the conchobulosa. Otherwise the skull base is normal sloping, cellular type of pneumatization, and there is no onodi cell in this case, and there is small onodi cell on the right side. Probably we might encounter the small onodi cell, and then there is a small pneumatization of the rostrum. These are the significant things we can encounter during our procedures. So I'm changing to a endoscopic view. So we already done the right side lateral laminectomy, and we expose the sphenoethmoidal recess. This is a left nasal cavity. I'm sorry. Astush, are you able to see?
Yes, sir, it is visible.
So this is the periosteum. This is the anterior end of the inferior terminate. So you can see that this is the bulla, middle terminate ka conchobulosa. So I removed the lateral part of the middle terminate. We preserved the medial part of the middle terminate. It is called lateral laminectomy. And you see the difference, how much space we got, right? So this is called lateral laminectomy without sacrificing the middle terminate, whenever we encounter the conchobulosa of the middle terminate. So then next step is how to get the middle meatus, the superior meatus. So you have to engage your periosteum along the floor of the middle terminate, never on the anterior aspect. If you give any pressure here, it will transmit the pressure to the skull base. It will danger, especially when you deal with the type 3 or type 4 Kiros classification, there is a risk of CSF leak. So you have to introduce your periosteum along the floor of the middle terminate and mobilize the middle terminate and try to, sorry, suction please. See that because of the lateral laminectomy, I got the better mobility, right? So my instrument is along the floor of the middle terminate, and I'm going to see the tip of the superior terminate. Okay, I'm just fracturing now the junction of vertical lamella and the ground lamella. So this is where you are going to give the pressure, and you can see the beautiful view of the tip of the superior terminate. Right, section please. Irrigation please. You can get the glimpse of osteal opening now, and so this is the out fractured junction of ground lamella and the vertical lamella, and this is the tip of the superior terminate, and we always out fracture the lower half of the superior terminate. So that will give the, that is the one of the landmark for the your spina osteum, right? See that I am just out fracturing the lower half of the superior terminate. Suppose today morning also they discussed, this is not always we can see that this kind of beautiful sphenoid osteum. Most of the time we will encounter the polypoidal osteum, we won't see the clear cut osteum. In that case, how to find the sphenoid osteum? The better, we know that the sphenoid osteum is 12 to 15 millimeter above the choana. So the rough diameter of suction tube, the what I am using is the 4 millimeter, right? So the 12 millimeter distance is from the roof of the choana. So you just place the your suction 1, this is 4 millimeter, second this is 8 millimeter, third this is 12 millimeter. So 12 millimeter, and just above the 12 millimeter you introduce your instrument like ball probe, you are into the sphenoid sinus. So whenever you get the difficult anatomy, not in this case. Pat please. So as Surisad morning demonstrated, we have to decongest the cavity.
Hello, Ravi.
Sir.
Ravi, you are Ravi, na?
Yes, sir. Yes, sir.
Just point out once more.
Sorry, sir. Point out one.
Just show the structures once more.
Yes, sir. Yes, sir. Sir, this is the left side nasal cavity, and this is the anterior end of the inferior terminate. This is septum. There is a small spur, and this is the anterior end of the middle terminate. So this is lateral. I am lateralizing the middle terminate, and we are seeing the superior terminate, and the superior terminate was inferior half of the superior terminate was out fractured, and we are seeing the osteum. This is sphenoid osteum, sir. Sphenoid osteum. And this is the choana, sir. Irrigation, please. Pat. Pat, please.
लीड कर रहा है, बंद कर आगे जो लीड कर रहा है ना,
कहाँ सर?
आगे से सेप्टम के लोअर पार्ट में
हाँ
कोऑर्डिनेट कर
कोऑपरेशन करिए
कोऑर्डिनेशन कर दो अच्छा
So you will sew uncinate after some time.
Sir, we are not going to do the uncinectomy, sir. We are going to use the nasal corridor only, sir.
Okay, so uncinate and bulla, these are the things which
No,
you
sir.
are not going.
No, sir.
What is this case? Sorry, I just entered, so I don't have idea.
So we are going to use the transnasal and transseptal corridor, not the transethmoidal corridor, sir.
No,
So-
pathology क्या? What is pathology?
Sir, pituitary adenoma, sir.
Okay, then that is not needed. Okay.
Yes, sir. Yes.
I thought you people are going to show the anatomy for rest of the anterior skull base. So it's a straightforward thing.
Yes,
Okay. Okay.
So the same step already performed on the left side. So I decongested almost 10 minutes before. This is the right side nasal cavity. This is the inferior turbinate. The middle turbinate got lateralized. Irrigation, please. This is the lower border of the inferior middle terminate. This is the upper border of the inferior terminate. So this is the choana, and this is the eustachian tube. This is the fossa of Rosenmüller, and this patient is having some kind of adenoid hypertrophy. This is the roof of the choana, and we are already decongested, and we can see the beautiful osteoma on the right side. So we are planning to harvest the mini hadad on the right side. Mini hadad means we limit the size of the hadad. We will show that how we do that. On the left side, rescue flap. And bilateral.
Hi, Ravi.
Sir?
Just tell about the importance of fossa of Rosenmüller and the structures associated with that, because that is one of the important landmark, and in ENT you people have the pathologies also in fossa of Rosenmüller.
Yes, sir. So for the skull base point of view, fossa of Rosenmüller is very important, especially when you deal with the squamous cell carcinoma.
Right.
The location of fossa of Rosenmüller is this. You can see the eustachian tube here. This is the torus tubaris. Just behind the torus tubaris and the roof of the choana, you can see the small recess. This recess is called fossa of Rosenmüller. This is one of the most common site for the nasopharyngeal carcinoma. So any lesion involving the fossa of Rosenmüller, and we are planning for their excision. So for that we need a transpterygoid approach. In the transpterygoid approach, not only we remove the body, we need to remove the pterygoid blades along with reposition of the or movement of the middle terminate. Sorry, eustachian tube. So eustachian tube, pterygoid plates, pterygoid body. These three things has to be removed or mobilized to reach the fossa of Rosenmüller.
And if this extends into the infratemporal temporal fossa,
yes, sir,
then you avail the fish type D approach to take out the nasopharyngeal extensive carcinomas.
Right, true, sir. Yes,
Right.
yes. Correlation होगी? So we are going to harvest the mini hadad on the right side. Mini hadad means the length of the hadad will be small, but the other principle is same. Like I said, so the inferior incision starts at the level of choana. This is the roof of the choana. When you make an incision, make sure that your tip of the needle hugging the bone. Go bone deep. Otherwise, the elevation of the flap will be difficult. And so you can see that I can feel the flap. I can feel the bone, and this is the rostrum. I'm hugging the rostrum, and when you come more anteriorly, you take a curvature and towards the floor of the sphenoid. So in mini hadad, the anteriormost part of the incision is the anterior end of the middle terminal. Suction, please. So unlike a hadad, in usual hadad, the anteriormost incision is a mucocutaneous junction here. But in mini hadad, because anyway we are going to do the posterior septectomy, instead of sacrificing the mucosa, we can harvest on the mini hadad on the one side. That is our principle. So this is the inferior incision, and I am just saying the anterior end of the middle terminate and making a vertical incision here and connecting the inferior incision. Then we proceed for the superior incision. As we discussed in the morning, the superior incision landmark is the floor of the ostium. So we just visualize the sphenoid ostium here, sphenoid ostium. Just coagulate here and visualize further clearly. I just coagulated at the level of ostium. This is a marking for our superior incision. Irrigation, please. Superior incision. So when you make a superior incision, make sure that we are preserving the 1.5 to 2 centimeter mucosa, because this mucosa is has the olfactory function. So what are the landmarks we will use? One is the ostium posteriorly, anteriorly the midpoint of the middle terminate, midpoint. So by following these 2 points, we can able to preserve the olfactory mucosa, adequate olfactory mucosa. So the ostium was clearly delineated. Now again the same principle, when you make an incision, hug the bone. Sometimes in thin perpendicular plate of ethmoid, we may enter into the other side of the spine, other side of the nasal cavity. That's okay, because anyway we are going to do the posterior septectomy. So you can see that this line approximately corresponds to the midpoint of the middle terminate. So these two landmarks are very, very important when you follow the superior incision during adult flap harvesting. So once you cross the anterior end of the middle terminate, so here there is no olfactory mucosa. You can go till the roof of the nasal cavity to get the bigger flap. So never compromise the olfactory mucosa. If you need a larger flap, you can go for more anterior. So in that case, in this case, we are not going to do the big adult. So I'm going to stop that incision here and connect to the anterior incision now. Periosteum elevator. So we made a superior incision, inferior incision, as well as the vertical incision on the anterior-most point. Divider Ravi. So the good thing about the posterior part of septum is the perpendicular plate of ethmoid, you can easily get the subperiosteal plane. Unlike your anterior part of septum, where the getting the mucopericontal plane is little difficult. But in the posterior part of the septum, the mucoperiostral plane, getting the mucoperiostral plane is little easy. So you see that how easily we get into this plane. So this is a
adult.
So if you make a proper incision, elevation of this flap is very easy. If you make an incomplete incision, then it's little difficult. We may need a scissors help to cut the mucosa. So you can see that now. Irrigation, please. So we made a good incision, and the flap is moving very nicely. And so this is a flap. I'm going posteriorly, and inferiorly we didn't make a clear incision. You can see that there is a attachment. So just make sure that bone deep incision. That's it. Irrigation. So this is a flap. See that we made a good posterior incision. The flap moves very nicely, and we are going towards the rostrum now. I'm using a suction here because I'm sure that I made a good incision. So we can, without injuring the pedicle, we can reach the posterior part of the rostrum. Periosteum. Again, we use neuropathies to push the flap to avoid the direct trauma towards the pedicle.
Will you not put it in coena?
Yes, sir. Yes, sir. Once I mobilize the flap completely, then we can place it, sir. So this is the ostium, sir.
Yes. So ultimately, you are going to park this hadad into coena.
Coena, yes, sir. Yes.
Right. इसका वीडियो बना अच्छा कम से कम ये एकेडमिक पर्पस के लिए
So this is the ostium.
Meanwhile, ask them to make a good video of it.
Sure.
So that because you are speaking also, so entire demonstration will come into the video.
Right, sir. Coagulation.
मैं कह रहा हूँ 4 बजे का जितने भी तुम्हें खत्म करना है, हमारी टेंशन मत कर रहा है, हम लोग दिखाने का मतलब नहीं ज़्यादा है, तुम्हारा प्रोग्राम ज़्यादा इंपॉर्टेंट है, ठीक है?
Irrigation please. Sir, we are using a coagulation here
ओ देख लो अपने हिसाब से, मतलब हम
to
लोग
get the
हम लोग कोई
hemostasis
ईगो नहीं है, समझ रहे हो ना?
as well as
हाँ, अपने हिसाब से आप प्रोग्राम देख लीजिएगा, बट
to remove the mucosa. Here I'm using the coagulation mode to get the hemostasis here.
Right.
It's a cold technique. There is no thermal damage to the mucosa. The coagulation works in the principle of plasma ablation. So this mucosa I'm just ablating now. Because our adult flap is situated placed inferiorly, we are sacrificing the mucosa over the anterior wall of the sphenoid sinus, just above the ostium. So it's a bloodless removal of the mucosa. So you can see the beautiful view of sphenoid ostium now.
Yes.
Irrigation, please. I'm ablating the lower half of the superior turbinate mucosa. This is a superior turbinate mucosa. We are ablating the mucosa of the superior turbinate.
Hey, Ravi, you are working on septum here. Where is superior turbinate?
Yes, sir. So
this small part of superior turbinate, it's seen only.
So this is the superior turbinate.
Lower part.
Yes, sir. This one.
Right.
This is the ostium, sir. This is the septum, sir.
Right.
I'm working on the right side, sir.
So you are going to raise a rod on another side also?
Sorry.
Is it important?
Yes, sir. Yes, sir. Other side, we are going to harvest a different type of flap.
Right.
That is rescue flap, where we are not going to sacrifice any mucosa.
Right.
Sir, this is the superior incision.
Hmm.
And we are now, I'm going to mobilize this flap and place the entire flap in the nasopharynx, sir. So I'm placing the pedicle inside the nasopharynx. Irrigation. Sir, you are able to see that? So this is the flap.
Very clear, very
So
clear.
inside the nasopharynx, sir. And we can see the right side, the rostrum completely visualized. And this flap is rotated inferiorly.
Perfect.
This is the floor of the right side sphenoid. Coagulation, please. Coagulation.
Does somebody want to ask something?
I'm ablating the lower half of the superior turbinate. So we always try to elevation till the palatovaginal canal. So this is the palatovaginal canal. So it will give the good freedom of movement of your adult flap.
Ravi, is it possible to, if you take 2 minutes?
Yes, sir. Yes, sir.
If not on this side, on contralateral side, if you can demonstrate the uncinate process and
Bulla, sir?
Bulla.
Sure.
Those are very good landmarks, because neurosurgeons don't know all these landmarks.
Sure, sir.
So it would be better their relationship and relationship with ostium and with the inferior turbinate. All those things would be very handy if you just demonstrate once.
Sure, sir. So this is I'm going to demonstrate the normal structures on the left side. Suction, please. Suction. So this is the middle turbinate where lateral laminectomy was done. So I'm just middleizing now, and we are into the middle meatus. Middle meatus is the space between the lateral wall of the nose and the middle turbinate. So this is the middle meatus, and you can see that there is the free border. You can see the free border. This is the uncinate. There is accessory ostium here. This is the accessory ostium. This is normal, not the normal structure. This is the accessory ostium. Irrigation, please. And there is another accessory ostium here. So this is the horizontal portion of the uncinate, and this is the vertical portion of the uncinate. Behind this structure, there is a globular structure that is called bulla. The space between the bulla and the uncinate is the ethmoidal infundibulum, where these ethmoids and the maxillary sinus got drained. And another beautiful structure, you can see that this is the vertical lamella. This is the first portion of the middle terminate.
Ravi, you are very fast, na? Try to start from beginning, how to recognize uncinate.
So, in this case, because of the pneumatized middle terminate, there is slight this is not the normal anatomy, sir. But here, the
Acha, Ravi.
Sir.
Sorry, Asutosh is showing me watch. So you go ahead, go ahead with the pituitary, okay?
Sure, sure.
Sorry. I became little more academician.
Right,
so
sir.
no matter, you go straight away to the
Sure,
cellar floor because it's already 4 o'clock.
Sir, as I discussed, so we are going to harvest the rescue flap. Rescue flap means we are not going to do the proper hadad. We are going to make the superior and inferior incision, not the vertical incision. So the vertical, we are going to make only the superior incision as we discussed in the other side. This is a superior incision at the level of ostium. This is a complete incision. And then this incision again, the same principle, midpoint of the middle terminate. If you make a more anterior incision, it will give a better rotation of these flaps. Why I am mentioning the rotation, you will see during the procedure. If you limit your length of this incision, it can limit your flap mobility, it can interfere your instrumentation. So I made a superior incision and then going to make an inferior incision, the same principle. One is along the roof of the choana. Roof of the choana, this is the roof. Again the bone deep. Again the rostrum. And then come along the floor of the septum. Floor of the septum. It doesn't need a more anterior incision because we are going to mobilize these. Cooperation, please. So we mark the mucosa that has to be preserved. This is the mucosa has to be removed, right? So this is the part of the mucosa we are going to preserve. This is the mucosa above this ostium has to be debrided. So I am going to ablate the mucosa above this incision. I am using the coablation. Irrigation, please. I am not sacrificing the anterior part of the septum. I am sacrificing the mucosa just in front of the anterior wall of the sphenoid. Again, the superior terminate hindering our instrumentation. So I'm just going to, we didn't outfracture the upper part of the superior terminate. So, periosteum, please. Periosteum. Debrider ready. Slightly out fracturing the superior terminate. This is the superior terminate. And we are able to see the coagulation. Sphenoid ostium clearly on the left side. I am ablating the mucosa on the lower half of the superior terminate as well as anterior wall of the sphenoid, not on the septum. Okay, so this is the superior terminate. Now, irrigation थोड़ा कम कर लीजिए. Suction. So the rescue flap is the same like adult flap without anterior incision, and its supply depends on the nasoseptal branch. In case if you need a adult flap, then you can make an anterior incision and then convert into adult. So So this is a mucosa. Periosteum, please. Posterior part of septum. Periosteum, please. Suction. Periosteum. हमारा periosteum अभी. Good. So we made a clear superior incision. I am going to mobilize this flap inferiorly. So see that. So the flap, this is the rescue flap. Yes. Then again the same principle till the rostrum. Neuropathy, please. Neuropathy. Drill ready. Debrider ready. I am just putting the neuropathy to push the flap inferiorly. Suction. So the flap rotated inferiorly, and we can visualize the rostrum completely, and we are going to see the outside appearance. Still, I didn't do the septectomy completely. So this is the rotated flap, and this is the rescue flap, and you can see the bilateral sphenodosteum. So we are not sacrificing the mucosa much. We are properly utilizing the mucosa. At the same time, we are preventing the septal perforation anteriorly. The posterior septal perforation doesn't make a difference, but if you make a anterior perforation, that makes the crusting, whistling, and nasal obstruction. So how come you know that your posterior septectomy is adequate? Again, the rough landmark is the anterior end of the middle terminate. If your septectomy posterior to this, then you don't have the problem usually. If the septectomy crosses this level, then the patient prone to have the crusting, whistling, or nasal obstruction. So the anterior end of the middle terminate plays very vital role in skull base surgery. Scissor, please. So I am going to extend the posterior septectomy. So when you going to sacrifice the septum, remember the amount of septal sacrifice minimal at the anterior end, maximum towards the planum. So this way we can prevent the damage to the olfactory mucosa. So I am not going to sacrifice this septum, but I am going to sacrifice the septum more towards the planum. So when you engage the scissors, engage in an angled way. So it has to go towards the planum, and make sure that you are not injuring the skull base. That is also important, right? So see that amount of septum I sacrifice, it is more posterior, not anterior. Again, this is the rostrum. This patient had a thick rostrum as well as the pneumatized rostrum. Debrider. Straight. So Jashwal sir always prefer the 1.5 cavity principle. So he always likes to do the posterior ethmoidectomy. Because he believes in the anatomical landmarks. Before going to the cella, he always visualizes the tuberculum cella, carotid position, optic canal position, clavicle recess, and complete visualization of the cellar sphenoid sinus. Then he proceed with the pituitary tumor removal. So I resected the posterior part of septum. Now you can see the beautiful view of bilateral sphenoid ostium. We didn't extend any sphenoid anterior wall. This is a bilateral sphenoidal ostium. So how we extend the sphenoid? So the simple principle, most of the time we don't have the gadgets, we have only the cold instrument. In that case, how safely you can expand the sphenoid. So once you identified the sphenoid ostium, take a periosteum elevator. The safest area to expand the sphenoid is inferior, and lateral. Why can't superior? Because if you move more superior, you can hit the skull base. If you go superior lateral, you can hit the optic nerve. So the most safest area to expand is the inferior and then lateral. So why can't inferior medial? Medially, we get the rostrum, that is thickest bone. We can't out fracture the area. So see that simple instrumentation and the direction, it leads to the expansion of the ostium. Why we need expansion? Because we need to engage the rhongen, right? So similarly, this is the ostium on the left side. I am engaging and moving infero-laterally, just out fracture. 90% of the time it is thinner. So we are into the sphenoid ostium. Coagulation, monoclure please, monoclure. So this is an intact mucosa. I am just going to break the intact mucosa and you can beautifully see the sphenoid ostium. I am just going to break the mucosa to get the better visualization of left side sphenoid. So now we can see the left side sphenoid clearly. Now, how we expand the sphenoid and make the posterior ethmoidectomy? So usually we prefer the Kerisons 2 mm. The Kerison is the safest instrument to do this step. Irrigation please. Irrigation. Irrigation. Good. So whenever you are able to engage, means you are into the sphenoid sinus. So if you are not getting any resistance, means you are into the sphenoid sinus. If you are getting resistance on the lateral side, it means orbital apex. If you are getting resistance superiorly, means you are hitting the skull base. So whenever you get the resistance, don't pressurize. So that is the trick and safety dissection of the sphenoidal expansion. So I am able to engage my instrument freely inside the sphenoid. I am not getting any resistance. So I am widening the left sphenoid anterior wall. Debrider, please. So, suction. This is the way most of the time we do. Suppose if you have the powered instruments like a micro debrider, then you can proceed or safely and or clear neat dissections. So I will demonstrate how we use the debrider here. So this is the cold instrument technique, how you expand the sphenoid. Pat, please. So whenever you do the mucosal removal or dissections, you always get a bleeding. So just again decongest, put the pack and wait for a few minutes, you will get a very good clear feel, as Suri sir demonstrated in the morning. So it's one of the patience is very important in anti-skull base to get the very good visualization of structures. Suction band. Right. So this is a cold instruments technique. Now I'm going to use the powered instrument to do the posterior ethmoidectomy on the right side. Periosteum. So I'm going to use the IPC. So this is a superior turbinate. I'm just medializing the superior turbinate. Once you medialized, you are into the posterior ethmoids, right? We are not going to sacrifice the entire length of the superior turbinate because the upper half is functional, means it has the olfactory function. So we are going to sacrifice the lower half of the superior turbinate. Divider. Irrigation. So the dome had the marking. This marking helps where you are removing the soft tissue structures. So divider. It dictates the direction, right? So it's, you can see that I'm removing the lower half of the superior turbinate, and we got the mucosal secretions from the posterior ethmoid. I'm preserving the upper part of the superior turbinate. And if we are into the posterior ethmoids now, this is the posterior ethmoid. Usually posterior ethmoids are large cells, single cells. Only few cells, they are larger. Once you are open, most of the time, it leads to the anterior wall of sphenoid and the laterally lamina papyracea. See here, I opened the only one cell. Hopefully, we are going to see the anterior wall of the sphenoid as well as the lamina papyracea. Irrigation, please. This is the lower half of the inferior turbinate. So this is the lower half, and we are preserving the upper part. This is the anterior part of the posterior ethmoid. This is not needed in this case. So we need a limited posterior ethmoidectomy, and so we didn't move our instrument laterally. We just dissected the middle portion, and we are open into the posterior ethmoid, and we got both the landmarks. That is anterior wall of sphenoid. This is the orbital apex. Of course, this side, as we told, the CT, there is small gonody. That's why we are getting the glimpse of optic nerve. Able to see this? This is the glimpse of optic nerve. This is the optic nerve. This is the optic nerve, orbital apex, and this is the anterior wall of sphenoid. And this is the ostium. Now, we know that how much bone has to be removed. This is the skull base, the superior is the skull base, orbital apex. So this is the anterior wall of sphenoid. This much bone has to be removed to get the complete boundary on the right side. Scissor, please. Scissor. Silent here. So little bit of further dissection of the superior turbinate. And suction, please. Scissor. Irrigation. So we demonstrated the two techniques for the sphenoidectomy. One is the using the ronger, another is the using the microdebriders, how safely we can negotiate and how safely you can define your boundary. Now, I didn't complete the septectomy, so scissor, please. calcium region. Again, I am going to expand the anterior wall, remove the anterior wall. See that I am not getting any resistance, means we are into the sphenoid. If you are getting resistance, I am not able to move the instrument further, means we are hitting the skull base. Don't pressurize. So stop here and then move laterally. Laterally, again inferiorly. When you harvesting the hadad, make sure that the inferior dissection you have to do carefully. Here, I told already why we dissected the flap till the palato-vaginal canal. So safely, we are moving the nasoseptal branch, and we can safely remove this bone to get the inferior cellular exposure.
Just let me clear one thing more, that Dr. Ravi is using 3 number upcutting plunger. At the anterior face of sphenoid, we use 3 mm. At the Phillips roll, you use 1 mm. This is very important, because there is no important structure present in the anterior wall of the sphenoid. So we are using here 3 mm upcut. And just at the Phillips roll, you get a lot of important ICA, optical, everything. So you use only 1 mm upcut there.
At least.
Dr. Ravi, Dr. Pathak here.
Sir.
In your opinion, do you think in all the cases you need to really enter into the posterior ethmoid? Because
No,
I
sir,
think,
no.
in my opinion, most of the cases I can do without that. So it becomes a little bit of more.
Sir, not routinely, sir. But we will definitely go for this step when the lesion extending to the cavernous sinus, when there is a significant suprastellar extension. These are our usual indications. In cella, the lesions confining to the cella, we never do that. We go only the transnasal, transseptal, and limit our dissection in the midline itself.
For knobs too, I mean, I would still just remain within the confines of the cellar.
Yes, sir. Yes.
So
Yes, sir.
it's good demonstration. I mean, I'm enjoying it. That's no doubt about it, and very beautifully depicted.
Sir,
So-
in this case, Dr. Pathak sir,
Hmm.
in this case, the tumor is reaching to bilateral cavernous sinus.
Right.
So unless we open the posterior ethmoidal cell, the exposure will be incomplete. In
I
fact,
know.
truly speaking, our exposure time is 90% of the whole procedure, and tumor removal become only 10%.
That's always the case in pituitary tumors, unless it is a redo case or a
Yes, sir.
fibrous tumor. So, yeah, as you saw last time and in the previous case, the pulsation of the brain just expelled the tumor out, and it just purged out of the cellar.
Dr. Ravi, Dr. Jagat here. I have a doubt on recurrent cases. When you have a re-exploration, what precautions do you take at this stage? How do you preserve the already harvested hadad flap? Which other rescue flap do you think of?
Very nice question, sir. So whenever we encounter the recurrent cases, the problem is identification of sphenoid sinus proper. Because due to the primary surgery, we most of the time we lost your landmarks. So in that case, either navigation helps, otherwise one of the most beautiful landmark what we rely is the superior the roof of the maxillary sinus. We do the wide meatal antrostomy, and we define the roof of the maxillary sinus or the floor of the orbit, right? So we just follow it is approximately exactly at the line of our ostium, right, sir? So once you find the roof of the maxillary sinus or the floor of the orbit, we will follow posteriorly, and we always try to identify the sphenoid below the line. Never go above that line. If you go above that line, high likely you are going to enter the skull base. So if you go below that line, anyway we are going to enter the sphenoid sinus or the nasopharynx. This is the safest region. So the most important landmark in the revision case is the roof of the maxillary sinus or the floor of the orbit. Or if you have the navigation, that is a fantastic tool. You can get the sphenoid sinus.
Second, about the flap, already harvested hadad flap.
That's why, sir. That's very important. So that's why most of the time we never sacrifice the hadad on both sides.
Okay.
So here we preserved the hadad on the left side. Here also we didn't sacrifice. If we need, we can place it. The pedicle is intact. If you don't need, we can replace the mucosa back.
Yeah.
That's why we avoid the ablation at the floor of the sphenoids.
I think posterior ethmoidectomy helps in parking the endoscope so that conflict with the endoscope and the instruments are reduced, at least in some cases where there is lateral work required towards the cavernous sinus.
Sir, yes, sir. Thanks for this wonderful opportunity. I have completed my dissection. I am handing over to Dishwal sir. He will proceed with the rostral removal and further expansion of the sphenoid sinus. Sir. So again, before handing over to another surgeon or before going into the dura, always get the good hemostasis and orient the other colleague what you have done, what are the important structures. That is very, very important because you are oriented from the beginning. The new surgeon may not aware about your dissection. So before handing over, always do the proper decongestion and orient your colleague. That is very, very important.
Ravi sir, you have demonstrated the anatomy very well. I think there was no comments while you were saying because most of the people here have been mesmerized by what they were saying. And though Virat Kohli cannot bat and comment together, but you have definitely proved it that you can show and talk, you can operate and talk simultaneously.
Oh, thank you so much.
Dr. Astos, I am Abdesh Jaswal here. Hello, are you able to hear me?
Yeah.
Sir, I am very fortunate to have Dr. Ravi with us. And in fact, let me admit it that I have learned so many things from him. He's a wonderful surgeon, not only, he's a good human being also.
Right. So you mean to say you are not a good human being before you met him? So that proves...
And he is tolerating me for so long. Anyway, so sir, just let me tell you that you have seen very nice dissection and demonstration from him.
So you're fortunate that two people have tolerated you, first your wife and now Dr. Ravi. So okay, that's jokes apart, a wonderful dissection and exposition. I think it was crystal clear for everybody. And now we would see what the neurosurgeon now does.
Can I make it extended? So let me tell you one thing that Dr. Ravi this is a Karl Storz endoscope. He was using Clara and Chroma mode. And now I am changing mode to standard. And
Sir, why I prefer a Clara and Chroma in nasal work?
Yeah.
In most of the time, during the nasal work, we never sacrifice the middle terminate. We never work on the ethmoids. We have working in the narrow corridor.
Right.
It's a narrow and dark corridor.
Yes.
So when you use the Clara and Chroma mode, the illumination will be more deeper.
Right.
And the illumination is more focused, and you can beautifully visualize the deeper structure.
Okay, that's something new which I learned from you. Thank you.
Sure.
so what I am going to do, this is the posterior part of the septum. I will remove some part of this because it's coming my way.
Yes.
I can remove this one.
Yes, that is nice.
Ravi, can you hold it? So my assistant Dr. Vipin is now holding the scope with both hands. And you can see the beautiful view of the endoscope as if we are operating sitting inside this nasal cavity.
Yes, we can see this huge rostrum which is pointing a gun towards you, so you better take it out of the way.
So I'm using now 3 mm upcut. And it is engaged in the large sternocleidomastoidea, and just I am breaking it. And then after I will remove it with the biopsy forceps. So you see direction how my instrument is going inside, how it is engaging it, and then how it is removing it. You see, the spiculed bone is not touching the mucosa. Many people prefer to drill it, but we also drill it, but not always. We use drill at a place where it's really needed anyway. Of course. So I am doing sphenoidotomy, and this will be standard cavity in half purpose. Cavity means sphenoid sinus, and half means bilateral posterior sphenoidal cell. Half because it's only posterior sphenoidectomy, not
Right.
the complete sphenoidectomy. So I am using 3 mm upcut because it's quite safe to work here.
Yes.
Can somebody show the outside view how our resident Dr. Vipin is holding
We
the
can see
scope?
that. We can see that.
Yeah, I think it will be good to see, show.
Avdesh sir, this is Kuntal. I'll take a minute here. I request all the audience to kindly, if possible, shift to this side. On these seats, on the left side. The reason being, the international symposium will start now. And on the camera, it will be projected on that side. So I think it should not look vacant. So kindly shift on this side. Really grateful. Kindly shift to this side, these seats. Avdesh sir.
Yes. Kuntal, बताइए.
Sir, maybe in 5 to 10 minutes we'll have to stop this transmission to
No problem. Should we carry on?
You please carry on. What we'll do is with the permission of the moderator, we'll stop the proceedings here.
Sure.
You
So I'm
please
carrying
carry
on.
on.
Once you are free, just let us know.
Because the session starts at 4:45, and I have asked the speakers to join 15 minutes before the time.
Okay. So I'm stopping here.
Sir, you please go on.
No, you carry on.
You carry on.
We can see the thin wall of the floor of the cellar, which is thinned out already.
Okay. Yes, sir.
Yeah.
So I will let you know.
You carry on.
What should be the extent of sphenoidectomy?
Yes.
Because everything is important.
Yeah.
You can see here the lower part of the rostrum,
Yeah.
which is projecting it. You can drill it, but I would like to take a
Ronger.
not ronger, is a strong biopsy forceps which taking it out. Biopsy. Upcut. Down.
Here you can see the sphenoid septum is also deviated more towards the left side.
Yes. You should be very generous in doing the sphenoidotomy. The purpose is that your suction should be reached below the cellar floor. In this case, the cellar floor is enlarged.
Yes.
In the previous case, it was even more enlarged and almost filled the sphenoid sinus.
Yes.
The floor of the sphenoid sinus and the cellar floor in the previous case were touching each other.
Yes.
In this case, there is a space which is known as claval recess.
Yes.
So my suction should freely go inside. So that's why I am making this exercise and doing the removing the floor of the sphenoid sinus removal.
Absolutely right.
Sir, you believe me, if the exposure is good, tumor will not be a problem. Even your OT staff can remove the tumor if your exposure is adequate.
Yeah, please give them the half of your salary then. I hope anybody is not recorded this statement because they might go to the court that Dr. Avdesh gets operated by nurses.
No, sir. It was just making the thing little light.
So as you can see, the scope is lying on the upper edge. Am I right in?
Yes, sir, yes, sir, sir. It's 12 o'clock.
Yeah.
It's a 0-degree scope
Yes.
placed at 12 o'clock.
Yes.
You see, now my section is going freely.
Absolutely.
So I have done the inferior work almost. Now I'll go to the superior part.
And I believe in removing all of these sphenoid mucosa so that there is
Yes,
no
yes, yes, yes,
future
yes,
scope of any meningocele formation there, which can happen. Sorry, mucocele formation. Yeah. And when you remove this, there is some oozing, which just stops.
This stops usually with sir worm saline.
Yeah. You can use something what is called a telehankel forceps, which is used by the NT guys.
Upturn forces.
मान लो भैया पहले दो So I have removed the inter-sphenoid septa also.
Yes.
So now you can see this is the cavity. This was the sphenoid
I
sinus.
think we remove little bit of bone on the left side of the patient. Yes.
Yes. I'll remove. This is the posterior sphenoidal cell. This is the right side posterior sphenoidal cell. So this is the cavity in half exposure.
Yes.
So now I will take a drill.
ड्रिल लगाई साहब को
drill लगाओ. We use diamond drill here.
Okay.
So please remember, all bones obstructing your instrument maneuverability should be drilled first. So you see this bony projection is hindering my movement. So I'll first remove this first.
Okay.
Moving part, moving part. As I told in the so moving part of the drill should be under vision. You see?
Yeah.
So my moving part of drill is under vision. Withdraw. And it should be paintbrush. What Dr. Suri has told in the morning.
Yeah.
I learned from him. So it should be paintbrush technique. So now you see my movement is now become free.
Yes.
Every small things matter. Moving part. Yes. Out. So everything becomes now flat. सक्शन ब्लॉक भाई एक मेरे स्क्रीन कर दीजिए हाँ एक ब्लॉक है 2 ब्लॉक हाँ सक्शन भर गया भाई देखो जरा So how much cerebral fluid should be removed? This is now, first we should see the anatomy here. Intracellular anatomy. This is tuberculum. Okay? This is cellular floor.
Okay.
This is clavicle recess. Hopefully, this will be the LOCR.
Yes.
This is the carotid prominence here. This is the carotid prominence here.
You need some more bone removal on the left side of the patient,
yes,
I believe.
sir.
Yes.
And below tuberculum, this is optic. This is optic. This will be the chiasm. Okay? So I will first mark the area to be drilled out. Up to the tuberculum, I will drill tuberculum also. And then after I will remove this bone.
You will have to flatten the septum on the left side as
Yes,
well.
yes. Withdraw, please.
And most of the time, this lateral interspinal septum attached to the ICA. So you should avoid blind manipulation on these septums. Always use the diamond burr to lower the size.
Again, the plain brush technique is copious irrigation. When we started doing endoscopic procedure, we were not drilling this part. We used to, because you see the bone is very thin here. So we just take 1 mm upcut and remove it. Now we used to drill in every case.
You can use some upcut also here.
Yes, sir.
Jaiswal sir?
Yes.
Sir, Dilip Panikar sir and Dev Pujari sir both has also joined us in hall.
Welcome, sir. Welcome, Depujari sir.
Good going, Avdesh. I think you emphasized a good point. Though we can use upcut, I think I have also almost completely changed to using a drill because occasionally you can either damage the dura or something underneath with the upcut, which does not happen.
Yes, sir.
And if you have drilled it enough, sometimes...
I think, yes, sir.
Yeah. I mean, that thin shell can be removed even with a periosteum elevator or something like that.
Yes, sir. Actually, let me tell you one thing, what my colleague Kuntal says many a time. If you are doing same thing for years together, that means your mind is not working.
Now you start seeing the OCR, so that is the
Yes,
important,
yes.
that excrescence had to be removed, mainly to get your anatomical bearings properly.
This
More
is
than
still
you-
obstructing my work. Withdraw it, please withdraw it. Or withdraw.
So there is always this argument, should you remove, how much mucosa you should remove, how much you should drill. To get the pituitary out, it is not necessary to do all that what he is doing now. But this gives you the margin of safety, and if you have a extension going laterally or anteriorly, you have a possibility of taking it out if you wish to.
So this is practically become quite thin now. You can see it almost broken.
Yeah.
You see? Can anybody see it?
Yes, yes.
बल को दो भैया.
AV team in OT, can you show the radiology and the side screen?
Nice flap which has come out like a lid. You can even put it back perhaps.
Yes, sir. Yes, sir. Yes, sir. If required, we can put it back. You can use it for any purpose. So that's what we have changed from our time. Thanks, Dr. Kuntal, for giving me the idea that your mind should work.
That is what we used to do for quite some time. But though it looks very nice, it comes in the way of your instruments.
Unless you have a very roomy sphenoid sinus into which you can drop that and put it down. But otherwise that will always get in the way of accessing the inferior part of the tumor.
And you see, this is the cellar floor remaining part. I also break it. Just leave it here.
This is equally important because most of us open only the anterior wall of the cella. Many a times we don't open the floor of the cella. Even though we call it opening the floor, we end up opening only the anterior wall. So if you really want to do a radical excision, you need to open it all the way down to the inferior intercavernous sinus. This septum is ending exactly at the, where the clavicle carotid becomes the cavernous carotid.
So now this is very important step. We most of time, basically this is a tailored exposure. So because tumor is going supracellular area, very small some amount of supracellular is there. Did somebody show the radiology? So I have to see the tuberculum dura also, which is quite distinct from the cellular dura.
Sir, radiology is being projected, sir.
You have a contrast coronal there, please put it up.
And this sag
Sir,
also.
can you see the tuberculum dura now, sir?
Yes.
Yeah.
It's coming into view.
Yeah. So this is the standard upper limit of the cellular exposure. This is must. If you do not have any navigation, please see this area. Because if you don't open this, the chance of manipulation will be more, and moreover, the chance of remaining tumor is more. So this is natural navigation, what I was telling. You should utilize all the possible anatomical landmarks. here because we are a resource constrained country, so we know how to operate with less instrument, less gadgets. The standard teaching is to open the cellular floor till 4 blue line. I think in most of the lectures, Dr. Dev Pujari has mentioned this thing. Sir, your comment?
Yeah, I think we have almost, you can see the change in color of the dura. So unless it is infiltrated with the tumor, usually the change in color represents that you are entering the medial wall of the cavernous sinus. I mean, you are parallel to that. What
Okay,
we
you
do
can-
is if we really want to go laterally, at this stage I will use a Doppler, make sure that the carotid is exposed before I stop drilling or punching further.
Can you put a little bit of Surgicel on the left corner at 11
Yes,
o'clock?
yes, sir, I will do that. I just asked for a small
Or you
gel
can
foam.
you can do flow seal. Patel does not like it, but
No, that's at the end of the surgery, flow seal, not now.
Actually, we make some local flow seal type of thing here, brother. Brother, भैया, लो यार, छोटा कटन तो छोटा कटन.
What is your local flow seal? I've been a bit curious.
It's been nothing but gel foam which has been made very small pieces. Our brother and sister makes it, and I'll show you.
Okay.
And it works sometimes very well. You see, I have used that,
Right.
and just put a cotton there, bleeding stops.
so the commercial name of this is Surgi foam apparently. Ramesh is telling us.
I used it. I think there was one company promoting Surgiform and like a powder. Even the nurses can make it.
Sir, our brother Vinod Kumar Gupta is with us, and he has made this item.
Has he patented it?
You know, this works very well.
Working well.
You see the bleeding has stopped almost, okay?
Great.
So now dural exposure is complete. So I'm going to now make dural.
So we are all waiting to see how you do the opening ceremony of the Sela. I mean the Dura. There are at least 10 versions. So
Yes, sir. People will open dura in their own way, but what I feel comfortable. I use this 15 number knife. You see, this is not pointed one. So first I keep rest knife over the nostril, and then after I pass it under endoscopic vision like this. And then after I remove the endoscope, and which goes on the right side.
perfect. Actually, there is a special knife made by stores for this.
Yes, sir. Yes, sir. That
called
is expensive.
Capablanca knife.
Yeah, Capablanca knife.
But the biggest advantage is you can actually have it hidden and open it once it goes inside, so you don't injure the mucosa. But the disadvantage is it works for
So-
maximum 3 to 4 cases.
I make durotomy from U-shaped, just like this.
Excuse me, Avdesh sir, this is Kuntal
Yes,
from the
yes,
hall.
Kuntal.
May I be excused for stopping you right now? because we're going to start the international symposium, and we already have the 2 of the 5 illustrious speakers who have already joined the Zoom link. So I request the audiovisual team to kindly start relaying it on the screen. So I would request my colleague, Dr. Ashutosh, to take over from here and invite the chairpersons and our distinguished speakers for this evening. Over to Ashutosh.
Jaiswalji will please record it. We'll see some highlights later on.
Sure. Kuntak, you need not to get excuse from me because we are the host. Nice. Please go ahead.
Thank you, sir. Thank you for the beautiful demonstration. Now we'll move on to our next session, and it is the International Symposium virtual. We'll have 3 international speakers for that. We have been already joined by our chairpersons. The chairpersons for this session will be Dr. Dilip Panikar, sir, Dr. Dev Pujari, sir, and Dr. Ashish Pathak, sir. And over to you, sir. So, audiovisual team, can we have the Zoom feed onto the main screen?
Thank you, Ashutosh. May I invite, is Danny already there? Yes.
Sir, Dr. Ashish Suri and Dr. Manas Manegrahi, they are also here. Okay. I request them to kindly come forwards and join as chairperson for this session. Sir, so, on the right side.
New look, Danny. Welcome to the Indian Skull-Based Society meeting. I am Dev Pujari here, joined by few of my colleagues who will be talking or will be interacting soon. I hope you can stay with us for a little while more after your talk. Dr. Prevedello is Vice Chair for Academic Affairs and Director of the Skull Base and Pituitary Surgery Program at the Ohio State University in Columbus, and has been a friend of India. He's done some workshops with us, and I think we've learned quite a bit from not only his surgical exposition, but also some of the papers he has written from Pittsburgh and now from Ohio. So over to you, Danny.
Thank you so much. Really an honor to be here. Let me just share it. Can you see my screen okay?
Yep.
Perfect. Yeah, so really an honor to be participating, and at least we have these alternatives for Zoom now, and wish I was there. Every time I've been in need, it's been a pleasure, and it's really a great partnership and friendship over the years. Dr. Dev Pujari and so many others. Really I always enjoy my interactions. I always learn with the Indian neurosurgeons as well. So today here, it's an honor, a pleasure to share a little bit of our thoughts and our experience with the chordomas and where the endonasal surgery plays a role in surgery for chordoma. So when you talk about chordomas, I always show this slide because this slide was given to me by Bernard George. He had the pleasure to be his friend, and it was great. And at the end of his career, he actually gave me all his slides, everything that he had digital. And I keep these 2 slides for chordomas because he was a master in chordomas, and this was his main point. And this has not changed over the years, that surgery is the most efficient treatment, still is. And chemotherapy, so far, not great. I think things are changing, but so far it's still not something that can be really treated with chemotherapy. And radiosurgery or radiotherapy needs to go to a very high dosage to be effective, which that's why the radiotherapy technology is evolving with proton beam and carbon therapy to really reach 70 degrees on the tumor and avoid damaging the brain. And that's part of the issue, because if you leave disease next to the brainstem, is exactly the same area where the radiation oncologist is going to be trying not to damage. And that's exactly where it's going to recur. Dr. Shaker, I had another, privilege to watch his lecture, and he always says that if you leave it disease on the brainstem or on the soft tissue of the crâniocervical junction, these chordomas come back. And exactly for that reason, like particularly the brainstem, the proton beam or any other radiation, the radiation oncology will be trying to avoid causing damage there. So the other important aspect Bernard George was always putting in his lecture is like the resection has to be as radical as possible. And even if you need to add more than one approach, you should do it, because that's the most important part of the treatment is your surgery. So surgical stages or different angles, combining approaches is something that you should always consider in chordoma surgery, but don't leave a big chunk and then send to radiation, because that will be the issue. And this aspect of the brainstem, as I mentioned. These are old statistics from ourselves, but just showing that in our practice, more commonly, 1/3 of the patients will come with a previous radiation, so previous treatment, half of the patients. So it's disturbing, because that's more difficult to treat the patient afterwards. The first surgery, it's typically the best chance for the patient when it's a good resection. And in our practice, about 1/3 of the patients, they have associated approaches, like we'll do endonasal and afar lateral and combinations with middle fossa, anterior petrosectomy, everything it takes to get a good resection for these patients. Very important to remember that these tumors, because they are in the clival, they start in the clival area, they tend to go behind the carotid arteries. So pay attention on the disease behind the carotid arteries. So for that reason, we typically expose the carotid arteries on the surgeries to have a good resection of these chordomas. The other concept is that frequently they are extradural, but they are possible there's a good number of them that go intradural. So you have to be vigilant about that. The question is if the disease is extradural, should I remove the dura? I would say that yes and no. I tend to remove the periosteal layer that has been compromised by the tumor. But if the meningeal layer looks healthy and is guarding the CSF and the posterior fossa contents and the neurovascular anatomy, I'd rather not take that membrane. So I very radically resect what is in the epidural space and remove the periosteal layer, but not the meningeal layer, because I think it causes more morbidity. Tumors like these that you see a finger going in, you might be surprised that actually the dura was extended out there. This resection was actually extradural in this case, and I was expecting to see this intradural. So sometimes that's what you gotta be vigilant there. Recurrent chordomas, high frequency, if you look at the literature of carotid injury, this is the carotid. Because chordomas invade the periosteum, frequently you don't have a protection of the carotid artery, so you have to be ready to dissect directly on the wall of the carotid artery without the protection of the periosteum there. So here's just an example of a difficult dissection where periosteum has been completely removed by the tumor. And when we are dissecting, those carotid are naked there. You've got to really be careful. And then removing disease behind the posterior carotid artery at the petrous apex, very important. And as you see here, we're chasing the piece of chordoma that is right there. If you see my arrow, and you see this is the clival region, and that's the tumor coming from the posterior petrous apex there that after we dissect it. So very important to look at post-operatively and make sure that you got the resection completely there. Here are some other examples of different compartments. For that reason, I've been using intraoperative MRI for chordomas. You look at that invades the carotid canal as well as the epidural space here, and possible frequently intradural as well. So these are just examples of pre-op, post-op on chordomas with a follow-up after proton beam. One thing that I've been using is frequently here is this type of situation where you look at here, you almost don't see lesion, but if you pay attention where my arrow is here, this is happening more and more frequently. This patient had a sixth nerve palsy bilaterals, and after paying a lot of attention, it was called a acordosis salifera, but if you see here in DWI, you can see the tumor. It goes intradural. It was touching the sixth nerve bilaterally, not a large mass, but enhanced it a little bit. So I insisted in doing surgery on this because the patient had new partial sixth nerve palsies. This is during surgery going above and below the tumor, see the basilar. This is the ultrasound that we've been using, touching the clival area. And that helps us to define exactly where the tumor is, going above and below and defining that. Here with the use of Doppler, and see this is the brainstem in the back, basilar, and you can see the tumor hanging in there. And then we'll open the durex immediately below. We got the tumor out, and the patient did well, improving the sixth nerve palsy. So this is a recent that I did. Sometimes you have a narrow space between the carotid arteries, and this is a large tumor with an intradural component. And my point with this is to show the importance of bimanual dissection and the skeletonization of the carotid arteries. Here, I used to come from below, more exposing the median, but more and more I actually skeletonize by coming from the top. If you look at here, I drilled the medial to the carotid artery to optimize the exposure. And then once we get to the tumor, not always a chordoma was going to be soft. This is a chordoma that was very firm, invading the arachnoid. So we decided to go around it. And in order to go around, you have to use sharp dissection as well. Here, as you can see, cutting the arachnoid, dissecting that sac of arachnoid with invasive chordoma. You see the basilar artery. Here's when it's very important to have partnership. Like I did this with Ricardo Corral, and you can see that how nice he came close, a nice close-up of the anatomy, because my main question here, are these arachnoid bands there, or are those perforators from the basilar artery? And that's where the partnership and the collegiality and really working as a team makes a difference here, because you know, that he will help me out on this. I remember like yesterday, you know, is this arachnoid or a vessel? You can see the vessel there, and we will cut one by one and dissect one by one from the basilar artery here. So you can see, like, is this a vessel or arachnoid? Let's just cut. Let's see how it goes. Okay, this is great. So this is very important. And just to, of course, we don't want to go through the whole video here, but I like to highlight these aspects of these surgeries because it makes very important. And then we dissect the vertebral artery inferiorly and got a complete resection for this patient. This is the way we've been performing reconstruction. We call the gasket, soffit gasket seal, where I put a collagen matrix around and I put gel foam inside. This is early in my career. Now I put much more gel foam inside. I think it has a learning curve on this. But this patient did well, but he did have a leak. Rick had to bring him back, and we did a temporoparietal flap for reconstruction. You can see the post-op resection is pretty good. I had a couple cases where I had bleeding on the brainstem. I just want to show this tubo-apoplectic events or chordomas. This is a young girl, and here you can see, similar to the other case, we had to go around. You see the inferior cranial nerves, and sixth nerve is pushed up. This is 7, 9, and all the inferior cranial nerves. This is 12 cranial nerve here, and we perform sharp dissection. And on this case, you see the basilar junction with the vertebral basilar junction. The most difficult part was really posteriorly, as we had apoplectic event on that tumor. And here we're just dissecting, making it smaller, but the disease was behind the vert. And this is already late case, and this is not easy. We were able to go around it. She's young, 21-year-old lady, and we know if you leave this disease there, it's gonna recur. So we work very hard around that vert, dissecting that chordoma. I think it's very important to show this because this is not a case you just say, okay, leave it behind and go home and proton beam, because then it is not gonna work. So we spent a long time like really clearing the tumor behind the vertebral artery, and we were able to get this lady out of the table intact, even with the 12th cranial nerve working well, which was originating right there. So here's the post-op picture with the resection, and here's the post-op MRI as well. Very good resection for her, as you can see here. So let me just advance here since there's some combined approaches. The important really message that I want to say is that sometimes you have to combine approaches, and I want to show this case here. As Dr. Bernard George taught us, this is a patient already had surgery and radiation with this complex tumor. I came endonasal first, was able to resect this portion and not really all the way to the petrous apex laterally as the carotid was hanging in the breeze there. And we combined with the open approach. You see here dissecting between the cranial nerves and dissecting the petrous apex, and then we obtain a complete resection of this tumor. This is just one of the examples of combination of accesses to obtain a complete resection. Don't forget that that chordomas will more frequently have a carotid rupture because of that, what I mentioned earlier. And I have two carotid complications in chordoma surgery. This is one of them that I came with the drill as I was drilling. Let me go back here. I was drilling next to the clival area, and just with a very tiny touch, we started like looking venous, but very intense, but eventually turning into a real catastrophic bleeding here that we had to stent this carotid and put muscle. With muscle and a stent, we were able to keep this carotid alive. But I'm not going to go into details of those cases. Just want to show another one. This is another recurrent chordoma on the cavernous sinus. Patient had a very sick carotid with previous radiation as well, but she developed a third nerve palsy. We decided to decompress. And after 2 or 3 radiations, the carotid is actually a sick entity there as part of a live tissue. And we identified with the Doppler, we felt that this was a safe maneuver. This is the cella area, and we're going behind that carotid. And just with the ball probe, see, this is it's just a blunt instrument. And just by kind of dissecting behind the carotid, we got into the carotid artery. And this shows you like after radiation, you gotta be very careful. This carotid we had to sacrifice. We use muscle as well to control. We were able to get the patient out of the table. Not gonna go through the full details, but I brought her back later to decompress once the carotid was sacrificed and coiled. So you can see here, we brought a few days later, and I was able to decompress the cavernous sinus by coming. She had a full third nerve palsy there that actually got better. But I'll tell you the story. I actually had to bring her back as an open craniotomy later to exenterate the cavernous sinus with the craniotomy as well. So in summary, most patients do well with improvement of cranial nerves, but there's a lot of morbidity in chordoma surgery, particularly when you start dissecting tumors from the brainstem, as I had a patient with the facial palsy, swallowing disorders, hypoglossal issues, and had 2 carotid ruptures, and with one that we had to sacrifice the carotid, several, recurrences and a few CSF leaks. We had to take these patients back. It's not free of morbidity, and this is very important to understand that several patients can evolve the disease and even die of the disease. Proton beam has been our modus operandi after surgery, and I think the most important message is really a multidisciplinary team working with the ENT team and radiation oncology. So thank you so much.
Thank you, Dr. Prevedello. Any questions from you?
Thank you very much, Ashish Pathak here, one of the neurosurgeons. Thank you very much for a great exposition. Can I ask you, do you give upfront radiation, or in cases where you think that the images are showing clear sort of removal, you wait for anything to recur? What is your policy? Or you don't give any radiation
Uh,
after Reckers?
No, we do have a few patients with a very small tumor on the clivus that we decided to observe. This is something that I remember Giorgio Frank from Bologna, he was very pushing for that type of approach where you just resect the best resection and then just observe. We do discuss with every patient. Our tendency is to indicate proton beam radiation. Here in America, we do have several facilities. We're actually building our own. It's going to open in December now. But we have, I would say, is a minority of patients that we observe with the mild disease. And proton beam radiation is getting better as well. So I think in the past, when Giorgio Frank had a lot of complications with proton beam, it was not very precise at that time, like 10 years ago. And now is very precise, the technology, they have better softwares to deliver. So I feel more comfortable indicating proton beam for the majority of cases now.
Great, thank you.
This is Manas. Can I ask one? Can you explain on that video of you removing the coils? Like, can you explain again? One of the videos you were removing the coils. What was that case?
Removing the what? I'm sorry?
The coils of the aneurysm.
Oh, yeah. So I was just removing some of the coils to get space because what happened, that patient, the carotid rupture, then the coil was sacrificed with coils. Then I went back to decompress. I thought that was going to be safe, but the coils was in the way. So some of the coils, I had to take it out. I have 2 or 3 cases I had to take coils from the carotid. Of course, worried of bleeding, but I just removed some coils to get space to get to the cavernous sinus.
Okay, and what do you use to cut the coils, like when you do partial coil removal? Is it easy to cut them?
I use it is easy. I use those ENT, the same turbinate scissors, not the fine scissors that we use in neuro microsurgery, but with the ENT coil, the turbinate scissors, those large ones, then you can cut them. Okay. It's actually easy.
Thank you.
Yeah, micro scissors is not very good. They would destroy your micro scissors. You don't want to do that.
Thank you, Dr. Prevedello. That was an excellent talk and very, very informative. You have a vast experience, and thank you for sharing your work with us. May I call upon the next speaker, Dr. Kenan Arnautovic, from who is from the Sems Murphy Clinic in Memphis, Tennessee, to talk about visual preservation and improvement in paracellular lesions affecting vision. Is it possible? Dr. Kenan.
Good afternoon. Here is very early morning. Can you hear me?
Yes, we can, loud and clear.
So yeah, thank you, Dr. Kuntaldas, for this kind invitation. I think there is someone in the background with open microphone. Maybe it's good to silence it. Hello to Daniel Prevedello, my old friend. Also, I see Jorge Mura in the background, Dr. Roser, all my great friends. So it's really an honor to talk to you before my 2 tumors this morning that are starting shortly. But this is a topic that's near and dear to my heart. And I have been very intrigued about this topic, especially, recently I attend some of the meetings and everybody is talking about hearing preservation. Is it possible with retrosigmoid approach and acoustics and all that? Nobody talking about visual presentation. I'm not saying that hearing is not important, but how about vision? So I have nothing to disclose. And we all deal with this kind of tumors in our practices where vision is gone or about to be gone or partially gone, or at least it's not gone, but after resection of this tumor, we have to tell the patient, what's the chance of preservation? Can we really preserve it? Can we take it out? So what we do know is that most common lesion causing visual loss are, of course, pituitary adenomas, meningiomas, craniopharyngiomas, aneurysms, orbital tumors, and some other tumors. And it goes with direct compression, vascular impairment, or combination of the both. So what I do is I do this sequential approach to the lesion, including cranioorbital craniotomy, removal of the roof, lateral wall of the orbit, opening of the superior orbital fissure, lateral wall of the cavernous sinus, and then extradural removal of anterior clinoid, opening of rhinoid cisterns, releasing CSF, and opening of optic canal and mobilizing optic nerve before we even start removing the tumor. So just a brief kind of cartoon illustration of this approach. Dr. Almefti taught us how to remove the extradural clinoid, and I utilized it. Dr. Yashagil taught us how to open the cisterns around the basal cisterns around the chiasm optic nerve. I'm not going to dwell about it. So this is one of the illustrative cases that kind of raised some eyebrows for me and some of my residents, 57 years old with bilateral legal blindness for 3 weeks with fairly large, may say even close to giant tuberculous cell meningioma going over the carotid. I published it in the operative neurosurgery. You see here clearly bilateral blindness. You see the tumor here sitting, and I'll just go through this case, some of the important elements. First of all, this is this pretemporal approach. You can see frontal temporal lobe. This is retraction of the dura, the trick that Ali Krisht, my friend and mentor, told me. I do irrigation with copious, drilling with copious amounts of irrigation. Here is coagulation and division of meningoorbital artery. And then here we are coming, you can see here optic nerve. Here we are coming around the anterior clinoid. It thinned down, and we nicely decompress the optic nerve. And look after decompression of the optic nerve, how significant amount of decompression is achieved. In order to completely decompress the optic nerve, we need 270 degrees removal of the bone in order to completely decompress the nerve. Here you can see now finalization of the extradural approach, and then now opening the dura. I like to lift the dura and then open it very low. Professor Evandro Oliveira taught me this. We open very low the dura, and once you open the dura, you are right on the carotid cistern. And here you open the carotid cistern, release the CSF. You can see carotid and optic nerve. And once you do that, you then go on to cut the falciform ligament, because that's the last point tethering the optic nerve. You can see I like to use the hook. I like to use the sharp knife. And once you do that, you are pretty much decreasing all the pressure within the optic nerve and allows for much safer resection of the tumor. So we go on to that resection using CUSA, staying away from the optic nerve, preserving the planes and the arachnoid planes. Here we come to the contralateral optic nerve. Again, the same thing, opening of the falciform ligament and decompressing it, and here removing the last parts of the tumor where it's coming to the finalization of tumor resection. What's very nice at the end of the surgery, you can see here the carotid artery just below the right optic nerve, right genu of carotid artery. And then you will see the left genu of the carotid artery here, completely resected tumor. And then finally the picture of pituitary stalk. Always preserve the gland and the stalk. So patient wakes up and she comes with resolved vision. She can see again. She can, from being blind, she regained the vision. So I started, more and more looking into this, how does the vision get preserved? So I look into the studies with my residents, and it's hodgepodge of poor reporting. Nobody reports very well. Some people don't report preoperative vision, some don't report postoperative, some report one or not the other, some that don't report both. Very few studies report both. And then when you see which tumor types they looked into, mostly craniopharyngiomas, few pituitary adenomas, very few tuberculum cell meningiomas, clinoid meningiomas, and all that. But this is, you know, resection rate, gross total resection, 66%, just slightly over 50%. So if we don't improve the vision, and if we don't do complete resection, why? I ask myself then, should we stop removing these tumors and should we quit operating on these patients? And look at this visual outcome they offer, or we offer as a neurosurgeons in 57%, 58% visual field improvements, and then 57 visual acuity. So what is true vision improvement rate? Shortly, we have no idea. Does it depend on preoperative visual function, condition of retinal cells, duration of preoperative deficit, size of the tumor, type of the tumor? We really don't know really any firm, good scientific data about it. So I then looked with my residents and did the study where I tested the optic nerve tension in experimental environment. And I was glad to see that this article has been downloaded 290 cases recently in China. This is Chinese translation. So what we did is basically we used the manual tension gauge, and then we measured the pressure within the optic nerve, and de novo created space with this technique that we create. So first, we looked into the falciform ligament, and we looked into the histology of it, very similar to Dura, obviously. Then I looked into the vascularization of the optic nerve, what we know about it. And Ali Krish did a study when he was in Emory with Dan Barrow and the team, and what they found out that optic nerve intracranial, so there is proximal optic nerve intracranial, and then there is distal optic nerve intraorbital, and then there is this transitional zone, which I'm talking about, where the optic nerve is completely encased in the optic canal with the anterior clinoid and falciform ligament. So proximal optic nerve only receives 0 to 2 branches of superior hypophyseal artery perforators. And Bergland published back in '69 that he believes that all these lesions are most commonly causing blindness by ischemia rather than direct compression. So then I found this article of Weinstein, who measured the blood flow in the optic nerve in cats, and he found out that the difference between intraorbital blood flow is 50 and in the proximal is 13. So proximal optic nerve has 4 times lower perfusion or blood flow than the intraorbital one. So it all kind of fits into big picture, why the outcomes, why patients get blind, and why the outcomes are so poorly reported. So when we did our study on our specimens, on the left side, this is proximal, and on the right, distal. You can see distal optic nerve with abundance of vasculature here. You see central retinal artery, huge amount of intraoptic blood vessels. But look at this intracranial part. There are very few blood vessels, very scarce, obviously ophthalmic artery entering here, and all the blood vessels locating at the periphery, almost like diffusion feeding the nerve and not the true vascularization. So once we measure the pressure with all 3 stages, so we removed the arachnoid membrane, we removed the falciform ligament, and then we did anterior clinoidectomy and canalicular decompression, as I showed you. When we did that, so we did open cisternal segment of the optic nerve, measured the pressure, measured the distance between the carotid and the optic nerve. Then we did falciform stage, opened the falciform ligament, measured the pressure, measured the distance, and then finally the canalicular segment. What we found out that with each step, the amount of dip between the carotid artery and optic nerve increases, and the amount of tension decreases progressively with each step of this dissection. So completely validates that notion, that hypothesis that we had about decompressing optic nerve and decreasing the pressure of it and providing safer environment for resection and also safer environment for recovery of the already damaged preoperatively optic nerve. So these are the measurements that we did, and this is all kind of getting into the, you see here. The other thing that we discovered that optic nerve tolerates much better the upward elevation than the side elevation or upward pull and side pull. You see here the tension much lower with upward than the side pull, and then obviously with each segment of the dissection. And the dip, look at how much dip increases as we progress with dissection from 1.59 to 3.53, and from and the tension decreases from 3.3 to 2.6. So obviously, there is an effect of decompressing the optic nerve, opening of the falciform ligament, and allowing decreasing tension and safer optic nerve manipulation. And optic nerve tension and perfusion are inversely related. They decrease the tension and improve the perfusion, whereas early optic nerve decompression improves vascularization, especially at this optic nerve junction area between proximal and distal segment. As I showed, measured tensions confirm that optic nerve tolerates superior rather than lateral elevation. And obviously, one thing to know always that proximal optic nerve has very treacherous vasculature compared to the orbital part. So just to show you a few cases, I think I have about 10 or 8 minutes more, something like that. This is a case of he also published in Operative Neurosurgery optic orbital metastasis. Obviously, you can see here patient blind, almost blind on the right eye. This is just go through the video real quick. This is again, you see, very important to drill with the copious amounts of irrigation, because that's the way to protect from heating transmission. This is a very aggressive case. This is pretemporal approach, opening of lateral wall of the cavernous sinus. One thing that works very well during this dissection is gel foam powder. I prefer it over injection of the two-seal that Ali published, Ali Krisht, because I think it conforms more into the venous channels. So here we are starting resecting of the roof and lateral wall of the orbit, and you can see the extremely vascular tumor now coming into the view. Here is section of the tumor. The clinoid here, optic nerve is decompressed already. And here, finalizing the decompression of the bone. This is all bone involved by the tumor and very vascular. And I like for this part to use 1 millimeter microkeratine rongeur and gently dissect the tumor off. And then finally opening the dura and removing intradural part of the tumor. And you see how much space is gained here, and you see how much decompression we already see. And then finally patching the graft. And you can see here postoperative outcome of the vision on this particular patient with gross total resection. Another case of this giant involvement of the tumor in the roof and lateral wall of the orbit. You can see loss of visual field here preoperatively, and the resolution of it postoperatively with gross total resection. You can see here reconstruction of the bone. The other case is giant anterior clinoid meningioma. You can see here on the right side wrapping carotid artery, wrapping bifurcation, and then elevating the M2, M1, and then going to M2 segment. You can see here complete blindness on the right and 75% improvement postoperatively with gross total resection. You can see here this giant meningiomas of the clinoid with occlusion of the carotid artery complete resection, and patient improved his vision. You can see here this left giant meningiomas. I love those, wrapping everything. And you really need to go from healthy to healthy. You need to identify carotid artery proximally and MCA and M2, M3 distally, and then go from normal to normal and resect the tumor. This tumor was partially attached to the stalk of the pituitary gland, so I left it alone because I didn't want to cause DI, I didn't have heart to cause DI. So this is stable for several years, not changing. Another giant meningioma, clinoid meningioma on the patient with mild pronator drift, memory problems, visual. And this is the last case I'll show. Just kind of, this is the left side. This is tumor, this is temporal lobe, not a good plane that we usually see between the tumor and the temporal lobe, so we had to establish it. We are now going to the frontal part. This is all tumor. You see how the frontal lobe is smashed. I just get to the juice. So first, what I like, as I said, from normal to normal, I like to identify distal MCA branches. Remember, this is the left side. If you injure MCA, this is going to be a disaster. So you need really to be very careful. Now, you don't want to dissect these blood vessels under pressure. So you want to debulk the tumor further, go proximal here, and here is the other part of the normal. Here you are finding your carotid artery. Here you are finding your A1 and M1. And here you are kind of slowly going to the bifurcation of middle cerebral artery. So now I know where is my proximal part. Now I know where is my distal part. So now I'm going to finalize the tumor resection by slowly going along the middle cerebral artery. Remember, we are holding patient's livelihood in our hands here. We need to be very careful with this dissection. So we are coming here to the final part. This is bifurcation. Tumor is completely wrapping the bifurcation. You can see superior branch, you can see inferior branch, and the tumor here inside the bifurcation. So we have to split the tumor into two parts. We have to finalize this. Here is the bifurcation, final tumor resection, early temporal branch going into the tumor, and then here you will see the final picture with. So just briefly, a few more cases, preoperative, postoperative visual outcomes on this giant, or not giant, large tuberculous cell meningioma. This is craniopharyngioma, works the same way, same technique. I don't think we have time to show craniopharyngioma pictures, but this is a patient with craniopharyngioma with complete blindness on the left side, almost complete blindness on the right side, and significant improvement on both after surgery. His police officer. Another craniopharyngioma, fairly large. You can see improvement of her vision postoperatively. I actually just saw her yesterday in my clinic. She is working in the school as a food cook for high school in one of the suburbs of Memphis, postoperative resection. So I'll stop here. I really appreciate your attention. I'm honored to be here. I'll be very happy to answer any questions.
Thank you, Dr. Kenan. That was an excellent talk. I just have a question here. Was the recovery of vision in a person who had lost vision pre-surgically related to the duration of visual impairment?
I thought, hi Jorge. I thought it was, and as I showed you that one case that was 3 weeks blind, I thought after a week, and I was using to counsel patients that 1 week after complete blindness, it's impossible to recover. But that case proved me wrong. Then I started with my ophthalmologist looking more into that, and they look into the fundus and look the viability of retinal cells. And I think this is the most important thing, how viable is retinal cells in prognosis of their vision outcome. But as you remember, with any stroke, it takes time for stroke to develop at the proximal end, which is proximal optic nerve, until it reaches retinal cells. So it takes a while. We don't know what's that magic number of weeks or days. I think as a general rule, the sooner you decompress, the better. And you got to decompress, as I showed, the whole optic apparatus, and you got to decompress to take out the tumor. If you don't take out the tumor, basically you didn't do anything, because if you take 50% of the tumor, they say the bulk. I don't think you didn't do any service to the patient. Why subject the patient to the surgery, which is very complex, very complicated, and risk all that without any formative benefit?
Thank you. There's another question here. That was a great talk. And also that study which you did on optic nerve, I think is quite useful and impressive. It's actually not a question, but I'm thinking out loud. Some of these cases where you find that patients had lost quite a significant amount of vision, almost down to perception light. In case, some of the cases, even though I had decompressed the whole optic canal, with some manipulation to get the tumor out from the medial and inferior aspect, that patients lost the whatever remaining vision they had. So it made me wonder whether I should have left it and then tried to remove it from a more endoscopic approach or not. Because there is always some manipulation when you want, even though you had mobilized it, you will have some pressure on the optic nerve. Whenever that optic nerve is already vulnerable by long-standing compression, the chance of getting that vision back with removal through that approach is quite difficult, I thought. What's your view?
So I spoke with it. I don't know, Danny is gone. I spoke with Danny many times at the meetings about this, and I know he's a great endoscopic guy. And they always, you know, when you hear this talks by endoscopic people, they always say, don't cross the nerves. Well, how can you remove the tumor that's on the top of the optic nerve going to the other side and laterally? But that's topic for another day. But my point is, when we looked into the outcomes of endonasal endoscopic approaches and transcranial approaches, although the data, as I showed, are very scientifically not sound, the outcomes are fairly similar. And again, mostly they looked into craniopharyngiomas, which are completely different animals than meningiomas. So to be short, we really don't know the good optic nerve. And you know, it's not the optic nerve outcome in Danny Pravadello and myself and Jorge Mura and Dr. Roser. It's optic nerve outcomes in neurosurgical community, you know. It is optic nerve outcomes which we offer as a neurosurgical service to our patients in Nashville, Tennessee, in Chicago, in Mumbai, in Lima, Peru, or anywhere else. So it's not one or two people who do a little bit more of these cases, but we need to come to more scientific. And we had a recent meeting, Jorge was there in Harvard, where people discussed 5 hours about preserving the minute hearing remnants, and they take painstaking discussions about it. Nobody talks about visual presentation. For me, I don't want to get into discussion. Is it important to preserve hearing in acoustics or vision in clinodal meningiomas? But for me, I really love vision. I like to see, if I had a meningioma, that would be my main concern rather than anyway, I'll stop here.
Thank you, Dr. Ken, for bringing out a point that there is a difference in the blood supply of the optic nerve, like the intracranial and the intraorbital part. That's what we understood. Means you said the intracranial had a lesser blood flow than the intraorbital part. That is why it's more prone for ischemia. But if one looks at the brain physiology, usually the means the neurons which have a higher flow of blood, they are more prone for ischemia. Why does optic nerve differ in that way?
It's difficult to say. My opinion is that optic nerve obviously is fed, proximal optic nerve fed more by some sort of diffusion and some sort of secondary vascularization. And the vascular, this one or two perforators are already overstretched and thrombosed. So it's running on reserve gas. It's running on thin thread. And by doing dissection and not releasing the pressure, not allowing it to be soft or less tense, I think you are putting that last pressure on that already vulnerable optic nerve to crash it and to completely lose the vision. There are one more thing I didn't have time to discuss. There were a few articles with indocyanine green intraoperatively after decompression showing how well it recovers after resection of these tumors. So there is a clear pathway here, I believe. I know that Jorge has his own series with famous Mi Plata. Mi Plata, everybody knows his famous Mi Plata technique.
Yeah, one more question, Dr. Adil.
Hello, Kanan. This is Adil Chagla from Bombay. Regarding your presentation.
Adil.
Yeah, hi.
How are you, my friend?
I'm good, thank you. I just wondered, I completely agree and I share your sentiments about the optic nerve and the decompression on the optic nerve. But on the cells, on the side of the vessels, the MCA, the ICA, I have, and I'm quite happy, in fact, to leave some residual tumor behind. I'd like your comments on that, because I know that if you jeopardize that, you might even lose the patient. And I've followed these patients not for 5 years, but for 15 and 20 years. 27 years I've been at KM, and they haven't come back with a recurrence. Yes, the tumor has grown, but so very slowly that they have absolutely no symptoms. Vision is much better because you decompress the optic nerve like you showed. Your comments.
So, Adil, good to talk to you, my old friend. He visited us in Memphis, I remember, and went to my daughter's soccer game, right, Adil? So anyway, about that, I like to dissect the tumor of the internal carotid artery and middle cerebral artery. And I think Shekhar and Al-Mefti were discussing a lot about it 15, 20 years ago. There is or there is no a good plane, and there is also article by Al-Mefti showing the 3 types of encirclement of the carotid artery, whether there is preserved arachnoid membrane.
Yes.
So I'm not a hazard there. If I find a great plane between the carotid artery or MCA and the tumor, I go for resection. It's easy.
Fair enough.
Plane is preserved. It will get you into the tumor. You'll get it out. If you find that it is, I have another case. I leave always. You saw the case when I left the tumor on the stalk. If there is tumor on the bifurcation and there is no good plane, I will leave it. It's not going to increase in size over 20 years, 15 years.
True. Because
you devascularize, you kill that tumor in essence. So never persist for MRI to resect whole tumor 100%. Do 98%. Leave small piece if there is no good plane. Absolutely agree with you.
Thank you. Absolutely. Thank you.
Yeah, thank you, Dr. Kannan, for spending the time with us. And we'll go on to the next talk by Professor Florian Rosa. And he's the chairman of Neurological Institute at Cleveland Clinic, Abu Dhabi. And he's editor-in-chief of Clinical Neurology and Neurosurgery. And in addition, he is adjunct professor of biomedical engineering at Khalifa University. And I request him to speak on the 200 steps for successful removal of vestibular schwannoma in semi-sitting position.
Yeah, thank you so much. I hope you can hear me. Thank you, Dr. Kuntal Das and all my friends in India. I wish I've been able to join you in Lucknow next time going to travel again. It's only a short trip from Abu Dhabi. So without further delay, let me start on that topic. You know, when I'm one of the residents, I'm one of the last residents from Majid Sami, and everything was sitting at that time, and there was no question about it. So when I moved to Abu Dhabi about 10 years ago to set up the Cleveland Clinic here in the United Arab Emirates, you question yourself about what you did. Is it really necessary to do a sitting position all the time, and all these steps and all these dogmas we had? Is it really necessary? So we did it. We had the fortunate situation, we had time for mock scenarios, and we went away from preference cards and created procedure cards. So I'll just give you an example. At the main campus in Ohio, they have about 85,000 preference cards for all the surgeries, and we have at the Cleveland Clinic here in Abu Dhabi about 150, and for neurosurgery about 60 procedure cards, very much standardized for all these procedures you see. So whoever is doing sitting position, it's going to be the same setup, the same consumables, the same equipment, and that is due to pulling it down all these steps into very small steps and question yourself and the team. What are we doing? Why are we doing it? And if you leave one of those steps, you might run into trouble. So I give you in this next 15 minutes a short overview of these, not all of the 200 steps, of course, but at least of some of them. And some are more crucial than others, but I believe, and this has been published now in two sets of publications, I believe that most of them are really essential for a very safe, successful surgery. So let's start with imaging. Of course, we do MRI and CT scan. The CT scan should be a 1 millimeter spiral CT scan. Why? Because with a standard one, with 5 millimeters, you might miss the emissary veins, which are very important, specifically in the sitting position, because they can be the reason for air entry and potentially air embolism. So you see on that example that on the 5 millimeter, you almost miss it. On the 1 millimeter, you can follow the course, anticipate the course. When you want to do a nice retrosigmoid, you want to see how far lateral you can go. And then with the help of the emissary veins, you know exactly when to stop and where to anticipate the emissary vein. Of course, we also look at the dominance of the sinus, the lateralization of the semicircular duct. You should not drill that open. You might lose hearing. That has been published already 20 years ago from Tadajiba. He checked the high-riding jugular bulb and the pneumatization of the petrous bone. So all this is very, very important for the CT imaging. I never do one of these cases on MRI alone. Next is what we do to prevent air embolism is two things, right? So we have two central lines. One is in the right atrium and one is the standard central line for application of general anesthesia. And then we do a transesophageal echo placed over the two chambers to see the air bubbles very early on so that we will never have any problems with air going into the lung. So we check all these patients prior to surgery for an open foramen ovale, which is a relative contraindication. It's a very large vestibular schwannoma. We still think we're going to do it in sitting position. We're going to be extra cautious, but it's very important to have this study before and a good anesthesiologist trained in echo. The big question is about hearing preservation, as pointed out by Kenan in the first lecture. So there's not many randomized prospective study in Skullbase. This is one from Germany, where we participated in, and it showed, although it's questionable because there were 10 centers involved and 20 surgeons involved, and we tried to stratify these tumors into a comparable non-biased group, and it turned out to be that if you prepare the patient with a nimodipine infusion through the central line about 12 hours prior surgery and up to 24 hours post-surgery, there is a protective effect. It's in the American system, it's very difficult to admit the patient the day before on the ICU just to place a central line and put him on nimodipine. I rather switch a little bit in those patients who have hearing preservation. I irrigate with papaverine solution in those cases where the acoustic awoke potentials are critical. In large acoustics, standard electrophysiology applies obviously for the 7th, 8th nerve, SSEP, MEP for positioning and for brainstem compression. But if you have a larger acoustic, we also either place pharyngeal needles, or we have in addition a special tube where you can measure the vocal cords to the 10th nerve. So that is important to have control over the lower cranial nerves. And you see on the right picture, that is EEG monitoring, that's standardized with our anesthesiology team. So the needles are placed by the surgeons or IOM techs. They don't feel comfortable doing that, so we always do that themselves. And you see, I don't know if you see no, you don't see my cursor, but you see the needles are bent the other way around when you place them in the pharynx. That is just in order so they don't slip out during the surgery from the saliva. Sitting position, I'm coming into detail. You see this is a fast forward, but it's in real time. It's less than 5 minutes. A few team members, everybody's doing his part, from anesthesia tech, IOM tech, anesthesiologist. Very straightforward. My American anesthesiologists, in the meantime, over the last years, they love this position, even for obese patients. It's much faster. You can ventilate them much better. And as you see, it's not sitting, it's lounging, it's semi-sitting. You see the legs are at the level of the heart, so there's no pooling of blood, that you keep a good mean arterial pressure. So that is very important. Next point is this head position, very, very important. There's always 4 different aspects. It's extension, and then your translation, you rotate and anteflect. Why is that this way? You have to remember the anatomy of the temporal bone, and you want to shift the temporal bone in a very straight avenue for you. So you as a surgeon want to work straight along the petrous ridge, no matter what pathology you have in the posterior fossa. So in order to bring the temporal bone in a straight line, you have to rotate and anteflect. And in order to do rotation and anteflexion safely for the cervical spine, you have to extend and translate. So these 4 movements are very important. And this is happening under SSCP and MEP. And that is traditionally from my Sami time in Hanover. He had several NF2 patients which had problems after that positioning without IOM in the 90s because of cervical tumors. So since that time, there was one disastrous event of a patient got tetraplegic because of that rotational movement of the head. So all patients now get SSCP for positioning for that. And then the marking, we always mark, of course, the transverse sigmoid sinus, and then the intended craniotomy and a mildly curved incision amongst that. Double checking is only 2 fingers behind the ear. And I always mark the earlobe into thirds, and the upper third is exactly where the transverse sinus is running. So there's no need for standard navigation for that. If we have recurrent cases or pre-sigmoid approaches or similar, we use the navigation, but not for standard retrosigmoid. Next, and that is a very important tool, no matter what tool you have, but the main advantage of the sitting position is the bloodless field, that you can use both hands for dissecting the tumor, but that only works if you have a constant irrigation from the assistant surgeon. And you see here, this is a tool, you press the button, you have irrigation, you let it go, you have suction, and you have the different attachments, which is more angulated, like bayonet for the surgeon. And if the assistant comes, he comes over the top, that you always see the tip of the irrigation on the microscope. But that irrigation needs to be on the point of the dissection plane, sometimes even underwater. I show you later on some videos, the underwater technique. But this irrigation is much important because you want to really work in a bloodless field, and that makes the surgery so straightforward. Then the microscope setup, everybody says sitting position is so exhausting. And if you look at that picture, it is truly exhausting. It would never work. I could never work more than 10 minutes like that. Everybody tends to crawl into that sitting position and stretching arms and extending your neck, and this is not very healthy for you. So that is certainly wrong. Unfortunately, the microscopes, neither Zeiss or the Leica is designed for sitting position. You see the handle is always in the way, you're bumping on the microscope, so you have to do a smart move with at least the right handle moving outwards or inwards, so that you can easily and nicely look downwards in a very ergonomic way and move your hands horizontally, maybe a little bit upwards. And of course, you have a wrist support for your arm. This is something self-made we have, like a Lila bar, self-made, just for the wrists, that you are very relaxed and can do this for a couple of hours. Next it is very important in the sitting position that you have a very good communication with your anesthesiologist. They have to be always within 1 or 2 seconds be able to do bilateral jugular compression. So what I don't like is the anesthesiologist has to go around the patient and then find its way under the drapes and then looking where is it. So it's very important. It needs to be one hand grip on the bilateral jugular compression, right? And even before we do draping, the anesthesiologist confirms that he's happy with the position of the neck. There should always be 2 fingers width between the jaw and the sternum, that he has good way in getting there with his fingers for bilateral jugular compression. And again, if I anticipate a very large emissary vein, or if we do surgery with an open foramen ovale in sitting position, I sometimes ask the anesthesiologist to do 15 minutes continuous mild jugular compression to increase the central venous pressure to avoid air entry when I anticipate that. So that's they don't like it, but that's what teamwork means. Okay, coming to the first surgical steps. Sitting position, you open the dura in a safe area, so not over the sigmoids, the transverse sinus. You start laterally to the sigmoid sinus and you move upwards. Once you open the dura, you see at the way the folia of the cerebellum is, you see how high you are. If the folia is almost horizontal, then you know you're very high. And once you see that, you can anticipate basically where you are in terms of laterality. There's one tacking suture to laterally to reflect that you don't miss any millimeter. And then the first thing is always like release of CSF from the cisterna magna. And again, the discussion is always, in sitting position, you retract the cerebellum. No, you hold the cerebellum against gravity. So there's no retraction, it's just supporting. Majid says we are supporting the cerebellum. You see, we put a patty and then the self-retaining retractor. It's not compressing, it's just holding it against gravity, and then you have a beautiful view into the CP angle, right? And then you can do your arachnoid dissection and so on. But at the beginning, it's holding against gravity, nothing else. Then drilling of the internal auditory canal, that's about 180 degrees. It's above the tubingen line. We published this with Tanajiba that we have a very nice landmark where the dura gets wrinkled. This is where we drill. If the patient has intact hearing, I just do it with a diamond drill. Otherwise, we can start with a cutting burr. And then you start with a 4 millimeter diamond. You go down to 2.5 millimeters. You always have to make sure that you just don't open the roof. You have to open it really laterally to remove this balcony, that you can move the nerves within the canal, because that's why we open it, right? Not only to remove the tumor, but you want to mobilize the nerves. And if you go in with an instrument on top of the tumor, then you actually increase the pressure in the internal auditory canal. That's not what we want. So you want to really open it widely, open the dura, and then you can mobilize the tumor within the internal auditory canal. And this drilling is very meticulous, right? Even with the smallest drill, if you feel there's a small ridge which prevents this mobilization, you just keep going. And then the first thing I do always in the internal auditory canal, I mobilize the tumor from lateral to medial. This is the most tricky part. This is all irrigation under papaver solution. The mean arterial pressure is about 100. So really a high MAP to have a good perfusion. Then you see already on the right medial, you see very nicely the facial nerve. You can stimulate if you have any doubts. And that's all what it takes. I put a papaver soaked gel foam there in the lateral part, and then I leave it, and then I go to the cysternal area. But that first little resection here from the lateral part, you see it on the left video now, is very important, because now whenever you mobilize and move the tumor in the cistern up and down, you don't have this pressure on these nerves in the internal auditory canal anymore. It's basically the same than the nice lecture from Kenan before at the optic nerve. Same we do here, right? You open the canal first, that you're allowed to mobilize and to move the nerves around while you do resection. So the bimanual dissection is very important. Again, 2 videos in parallel. In the sitting position, you lift up the tumor with one hand, and with the other hand, you use the gravity to pull the arachnoid down. Never touch the nerve, just the arachnoid. And never use any BiPo in this surgery. There's no need. You have the assistant irrigating. You see that the tip of the irrigation is always visible, that he knows exactly where to irrigate. And on the upper video, you see very nicely that it's arachnoid dissection, not nerve dissection. That's the cochlear nerve there. The lower video is a larger acoustic. Now at the brainstem level, the dissection gets a little bit more tricky because you have to dissect away from the tumor, away from you. Dissecting away from you, like here on the superior surface, is always difficult than dissecting down. The superior surface towards the trigeminal nerve is always easier and less adhesive. Whenever you have a safe zone created with dissection, you can easily remove with a CUSA. I call it the safe zone resection. And then you have less tumor to grab. You have less tumor to hold and to pull. It's much more convenient, right? And again, this is towards the brainstem. The technique is a little bit more difficult because you have to pull away from you. And then in between, when you come to the medial-inferior surface, you have to do mapping if you don't see the facial nerve. This is what was a facial nerve probe. Then you lift up a tumor from inferior, and then you see a very nice nerve. Whenever you see a very nice nerve like this one in vestibular schwannoma surgery, it's not the facial nerve, it's the abducens nerve. I wish I would see a facial nerve like this sometimes, but this is most often not the case. And here at the brainstem level, really try to preserve the arachnoid, never any coagulation. I even don't put petties on that level. The irrigation is enough, right? Constant irrigation. All levitates down with gravity. So this is the best of all worlds. Okay, this is straightforward. It never takes longer than 2 or 3 hours unless the patient had previous surgery or previous radiation therapy. You see very nice plane towards the brainstem in this case. And then that is something I want to point out here. Remember, so there's a lot of venous bleeding, and even if you have arterial bleeding, try to irrigate and not using the bipolar cautery, right? Because, and this is a previous radiated and previous surgery, previous resected vestibular schwannoma, a lot of adhesions. You can't dissect it with a forceps, you have to do sharp dissection. And you're very, very tempted here to use the bipolar, but this can be shared vascularization from brainstem. So I really try to avoid. And this is what I call underwater technique, where the assistant is continuously irrigating, that you have a clear field, and even with the blurry vision underwater, you have an idea where the adhesions are, and then you don't give up. You see this, right? This is continuous irrigation. Once you stop, you have bleeding, but that bleeding will stop once you freed it, right? And it's still too hard. You see, it's not working. And then I can honestly share, I was really tempted in that situation to use the BiPo. And I'll show you in the next second. See, I have the BiPo already in the hand and put a gel from here. It was about to use it. But then as often as it is, right, at that moment, I felt now it's moving, and I removed the BiPo, and then now you overcome that very poor area, and then you will see the venous bleeding will stop, and you save the arterial coagulation for sure. It is very important that the electrophysiologist has a very good overview about anesthesia parameters and about the surgical view. They really are part of the team, and they look at the EEG, they look at the mean arterial blood pressure, If there are any A trains coming on the facial nerve, we stop dissection, we irrigate with papaverine and body warm ringer solution. So very important. And that is one of the reasons you see here, there's a little vasospasm at one of the arteries close to the brainstem. It would have been unnoticed by me, but the IOM technician said the acoustics go down. So you irrigate, you put a gel foam with papaverine, you leave it a few minutes or seconds even, and then you wait until acoustics recover, and then you remove the gel foam, and you see the papaverine did its job and it's back to normal. But for those times, you really have to increase the blood pressure up to a MAP of 100. That is after resection of a schwannoma. You see all this nice arachnoid plane. You know, whether you put muscle or fat doesn't matter, or muscle and bone wax doesn't matter, but you have to seal the internal auditory canal with any type of implant to avoid internal CSF fistula. Sami recently changed to fat. I still use muscle. I had no bad experience. And then what you have to tell your patients is that the first MRI will always show, I have to go backwards, the first MRI report from outside imaging will always show there's a tumor remnant, and they come freaking out. Oh, you told me, doctor, that you removed the tumor completely, and now there's a remnant. Because what the radiologist sees and doesn't know is that that contrast enhancing little area over the internal auditory canal. You see it here. That is not tumor. That is the muscle patch. So that is very important to educate either your radiologist or the patients about it. At the end of surgery, very important to do bilateral jugular compression. You see on the left hand how that works. Very strong filling of the petrous vein as a sign of jugular compression. And on the right side, you see an occult venous bleeding, which you would have not observed and you would have missed, right, if you wouldn't have done jugular compression at the end of surgery. Why is this important? Because every patient waking up after this type of surgery has nausea, vomiting, they're gagging, they have an increased pressure in the posterior fossa. And then they would have this ugly post-op small little hematoma in the CP angle, which we don't like. And if this would be a larger leak, it would even create more problems. So it's very important to do this jugular compression at the end of the procedure. Well, what I learned when we went through this process of standardization, that we removed some of the steps I learned from Sami, we added some of those, which we think is important. And we always try to improve over the time, over the years, with impact of the younger colleagues who have great ideas with the new toys we have. And following my mentor, I want to finish this, an ultimate plateau of learning is never reached. Thank you very much.
Thank you very much for Dr. Rosa for its beautiful exposition and rejuvenating the knowledge of the exact process of removal of acoustic schwannoma. It was really fantastic. One of the things which we had been taught, and I just want to get your concurrence, when we are opening the posterior fossa, the diploid veins can also be a source of air embolism. And that's why our mentors used to tell us that you should very nicely wax the bony margins also, because that can be a good source of embolism. And that is an important point. I thought if you agree with that, that should be also remembered.
Yes, I'm happy that you add the 201st step. I completely agree. This is always the situation where the anesthesiologist said, oh, I have air entry, and the surgeon says there's nothing, and then they do jugular compression, and then you say there's no bleeding, there's nothing, and these are these diploid, and that's what we always do after craniotomy or craniectomy. You just wax it right away.
Thank you. Any questions from the audience, please? Yes, there's one question. Yeah, please.
Nice presentation. This is sitting position which we in India we don't practice at many centers except few centers. But I would like to know, what is the size of the tumor? Do you have any preference to the size of the tumor which you operate in sitting position? Suppose the size of the tumor is large. Do you still prefer this?
Does the size of the tumor decide about your position? That's the question.
Very important question. And I have to admit, I changed my practice, right? So in the past, in Hanover, we did everything sitting. And the advantage of the sitting does only apply in large acoustics. In the small ones, right? You don't need this bimanual dissection. You don't need this. You don't have this much bleeding. You don't need an assistant irrigating. So everything T1 or T2 size, I do in supine position, like an MVD, like we call it the Janetta position. But everything larger, where you really want to do bimanual dissection, as I demonstrated, those who are previous radiated, all those I do in sitting position. And same applies to meningiomas, large petroclival sitting, huge advantage. Small ones where bleeding is not that issue, then or tumors like epidermoid can be super large, but bleeding is not an issue. So there's no advantage of the gravity, right? So those ones I don't do sitting.
Thank you very much. Thank you very much, Dr. Rosier, for this excellent talk. We really enjoyed it.
Thank you. Thank you very much.
I think, was there any question? Sorry, hang on, please. Professor Adil Chagla wants to ask a question. I'll just hand over the mic to him.
Thank you for that presentation, Dr. Sowa. I was just wondering, I had a look at your positioning, and in the positioning, you rotate the head quite a bit. My concerns are that when you rotate them and you have the petrous looking, let's say you're looking right down the petrous, it's a little difficult to drill the internal auditory meatus and around there. So I think it may be better when we don't rotate it so much, plus we will never have that complication of patients having paresis or any cervical problem as well, like your comments.
Yeah, very good point. So first of all, I manipulate every patient before surgery. I ask to rotate if they get any Sperling signs or any cervical radiculopathy. And then you're much reluctant to do that. Second, you rotate only as much as the petrous bone is angulate. So these 30 degrees, right? That's you bring the petrous bone outwards, right? Because we want to look straight. Because when you work very deep, and not so much acoustic, but more petroclivus, where you have to even go deeper, you want to work straight, and you don't want to, as a surgeon, work around the corner. And the looking downwards is important because in many cases in the CP angle, you want to have a look all the way up to the tentorium. So if you do a little bit undeflection and pull the patient downwards, then you can look upwards inside the skull. So this is a tailored position depending on what you do. If it's a smaller, straightforward acoustic, you don't have to do much of this rotation. But if it's very deep, or if you want to do transtentorial, then you have to bring the head, you have to undeflect the head, that you basically can look upwards. And what I always like is that I have some positional reserve capacity for the table to be in the Trendelenburg position, because if worst comes to worst, in plan B, there's a massive air embolism which they can't manage, you want to bring the patient as much down as possible. So this is why I rather undeflect the head a little bit more, but have capacity of the table to go down, right? That in the worst case scenario, I can almost flatten him down, that the head is below the heart. And that is why I rather start in that steep position.
Thank you very much once again, Dr. Rosier. We would love to hear you again. And
you will. Thank you. Bye.
Thank you. Bye-bye then. Bye. Now, it's my proud privilege to invite Professor Jorge Marcelo Moura. Professor Moura is Professor of Neurological Surgery, University of Chile, and he is in the Department of Neurosciences there. He's a past president of the Chilean Society of Neurosurgery, and he's the member Cerebrovascular Disease and Therapy Committee. Professor Moura, please.
Good morning to everybody. Before I start my presentation and share my screen, do you listen to me?
Yes, we are.
First, I want to apologize because I have my dogs. Today is holiday on Chile. I am in my house then, and when my wife arrived for her job, my dogs start to bark a lot, and then I apologize in advance with you, about 15 minutes maybe. And after that, I want to say that I'm very honored to be in front of you talking about my presentation in this. I'm privileged to be in between this very high level panel with a lot of friends, neurosurgeons that I respect a lot. And for me, it's a real honor to share with you my experience in something that is not new, but is new. I will try to explain to you the Mi Plata technique that my friend Kenan talked a little bit already. It's hard to explain this in 15 minutes, but I try to do my best. I'm just finished my presidency in my society a couple of days ago, and for me it was very important to do this. I think this kind of activities are very important to share, and this is the only way to learn the new things. And always that I listen to my friends, I learn something. I'm passionate to decompress. My philosophy was decompress since I started this 28 years ago. Since my first patient in the clinoidal meningioma or tuberculum sella, I decompress the optic canal. And wait a second, my wife is arriving. Give me 1 second, please. I'm going to. Thank you very much. Sorry for that. And what I'm telling you, this is the optic nerve decompression is the key. I think the endoscopy, one of the key of the success of endoscopy is because they decompress early and they see the perforators much better than with microsurgery. And what I try to do with my surgeries today is copy that. This is for the young neurosurgeons. Never fight with the new technologies. You need to embrace the new technologies. I do combine surgery, microsurgery combined with endoscopy. Not the review of the around the corner with endoscopy. No, operate first with microsurgery and second with the endoscopy. I made my fellowship with Dr. Evandro, and the people who know him, he teach me the discipline, the registration. Always I register all my patients with video, with the data and everything, because this is the only way that you prove the things is publishing. You need to publish. It's hard for me because I'm from South America. South America, we have a very low production in scientific literature. But we try to publish, and I publish some papers, and it's very important. But this is the only way to share with the rest of the world what you are doing. The other way, I think the pandemic helped us. Was not everything wrong for us. Was the possibility to be connected. Now I'm talking with you, the fine people in India. I'm from Chile, and we are separate for thousands of miles, but we can share the knowledge. With Kenan in the United States and Dubai, whatever, it's very important this. And the other thing for the young guys is the neuroanatomy and microsurgery are the keys. You need to be a master in microsurgery. Microsurgery is an art. You need to be master in microsurgery, because if you are good in microsurgery, you can separate the perforators, you can preserve the nerves, the things that we want to preserve in our patients. And the other thing is the neuroanatomy. This picture gave to me by Elder Tedeschi, my master in microsurgery, and Wen Hung Su, who teach me neuroanatomy in Brazil. Everything is here. If you see, when you do the classical transcavernous route, it's for the floor of the cavernous sinus. You need to take out the anterior and posterior clinoid. The philosophy of Pinko Dolens, Dr. Evandro, Ali Krish, they go for this way. But if you go for the Japanese way, you take the Kawase triangle. And the Kawase triangle is lateral to the fifth nerve. But if you see in between the posterior clinoid and the Kawase triangle, you have no bone. You have nothing. If you take out the tentorium, you have a wide exposure of the posterior fossa. And that's what I learned for the posterolateral way to see the cavernous sinus. Ali Krish was the first that started with this kind of very extended way to see the cavernous sinus, like a highway to reach the posterior fossa. I told you before, I did nothing new. I just copied to the good guys. I say always to my young fellows and residents that you need to pick up your heroes properly. You see, if you have good heroes, you can get much longer than them because you take their teachings. And we published this in 2021. The Mi Plata approach is not more than the minimal invasive posterolateral transcavernous transtentorial approach. The name is because of this, because we use the tentorium to get the posterior fossa. And I learned this from the sphenopetroclival meningiomas. Now I have more than 50 operated. The large series published in the world is 18 cases because a terrible tumor. But for me, it was a way to learn how to deal with the cavernous sinus, and I'm very grateful with my patients because they give me the experience to show you what I will show you today. And then the difference is the use of the extradural corridor. That's the key of the surgery, the extradural corridor, okay? Because when you use the extradural corridor, you can get a much more way to get the complete exposure of the cavernous sinus and the posterior fossa. This is the Japanese philosophy, it's not mine, okay? And in this very short video, I just want to show you one thing. This was an airplane pilot, okay? And then this was very important for him, the view, the binocular view. And he have a third and fourth cranial nerve palsy. If you imagine an airplane pilot with this kind of problem, it's terrible. It's not the same that for other people. For us, of course, it's terrible. It's not a huge tumor. It's a small tumor, but you have a problem with that. I talked to him about radiosurgery, but I said to him that we can free the nerves in the cavernous sinus with very good results. And this is a change of paradigm, because most of the people think that if you have a deficit in a cranial nerve, you must not operate. You need to send to radiotherapy or radiosurgery. And I don't agree with that. We publish, of course, this. And then I just want to show you, because we don't have time, the fourth nerve was completely compressed. Where in the entrance into the cavernous sinus is the same that the carpal tunnel syndrome in the head is the same. The third nerve is a peripheral nerve. It's completely different from the optic nerve, because the optic nerve is a tract, like the spinal cord. But if you see, the surgery is not as spectacular. It's nothing. You know, this is the optic, the carotid, the ecom, the anterior choroidal. But the problem of the patient was the compression of the third nerve in the entrance, the oculomotor or Hakuba triangle. And we freed the nerve. And the people who operate carpal tunnel syndrome knows that the median nerve happened the same. You see, it put red because of the compression. And after that, we freed the fourth. You need to remember that the fourth is completely different from the third. And we don't have time to discuss this today, but I have several tips in order to preserve the fourth, because everybody is afraid to take out the fourth and cut it. But it's not easy to cut if you have the proper technique. And the next step is very important, is the release of the fifth nerve. Why the fifth nerve is important? Because most of my patients in meningiomas and another kind of pathologies, the people complain about trigeminal neuralgia. Trigeminal neuralgia is terrible, but you can free the trigeminal nerve, and you need to remember the trigeminal nerve is between bone and the tentorium. And then when you have a tumor, you have a compression of the fifth nerve, and that's a problem, okay? And then in this case, if you see the control MRI of this case, it's not as spectacular. You see, it's almost, I take nothing of the tumor, but the patient completely recovered from the third nerve. He pilot again. And then I convinced in that time that, wow, this is good. We can help these people, these patients, okay? And then like Kenan talked to you before, we start with levels. I always like to talk about levels because we have residents and fellows. The first level is the optic nerve decompression. I put optic nerve decompression. I don't even put the technique. No. My goal is optic nerve decompression. In where? In paraclinoid, in clinoidal, in fibrous disclosure of the bone, in fractures of the optic canal. You know, this is very important to you to understand. You can do mini-pterional, and that's why this is minimal invasive, because I base my approach in mini-pterional, less invasive approach, described in 2005 and 2007. It's not mine, it's a copy. And the micro keyhole approach that I use for small lesions. Then you need to combine with transsphenoidal. You don't need to compete with endoscopy. You can share with endoscopy because Kenan show you that some carnopharyngiomas you cannot take out from the nose completely. Some tuberculum sella you cannot take out completely from the nose. And then what we do, we combine. We do 360 decompression of the optic nerve, and we preserve, and we have very nice results. And then you have the third stage, that's demiplata. Demiplata, you take complex lesions and into the cavernous sinus, into the posterior fossa. We just published a very nice video in operative neurosurgery in August, 2 months ago, with one of my former stages observers and operative, Arnaud Benet from the United States. He operated very nice. He worked in the Barrow. He's a very nice surgeon, and he made this video for us. And this is the QR code that if you take a picture, you can see the video. We showed there the technique. The first video showed the cavernous sinus technique. The second video is to show the posterior fossa technique, how you free the nerves, how you can release third, fourth, fifth, sixth, all the nerves you can see with this kind of surgery. And then we have 3 levels: the basic optic nerve decompression, the extended, mainly lesions into cavernous sinus or very close in the posterior fossa, and the full version when you combine with endoscopy, and you can reach the foramen magnum from the middle fossa. When I say this, nobody believed me. You don't need to believe me. You need to believe your eyes, because I show videos about my surgeries. I can be a liar and tell you lies, but that's why I show videos. And the second thing, this is nothing new. You must start to learn this kind of technique with paraclinoid or clinoidal meningiomas, because are the most simple way to learn about the roof of the cavernous sinus. You need to have the proper instrumentation. This instrumentation came from Japan. I learned a lot from Japanese friends, Rokuya Tanikawa and other ones. Professor Kamiyama have this nice scissor. Why I show you the scissor? Because the scissor have this shape, and with this shape, you can change the paradigm of dissection of the cavernous sinus nerves. Most of the people dissect from the cister to the cavernous sinus. I just dissect from the cavernous sinus to the cister because of the shape of the scissor. When you have the typical straight scissors, you hit the nerves with the scissor, and then you make a lesion. The results are not so good. And the other thing is a copy from endoscopy, the suction irrigation. The mini-pterional approach, that is based approach, is a complete equilibrium, in equilibrium approach. Half frontal, half temporal, in the middle, the sphenoid wing, and then the anterior clinoid. Okay, for 15 years, I did the classic surgery. I was a very classic surgeon, but I changed. We came with the key exposure concept. What is that? You don't need to do a fronto-orbitozygomatic approach. What you need to do is expose the cavernous sinus. It's open wide the cavernous sinus. It's not nothing. You gain nothing with in order to expose the basilar artery if you do a fronto-orbitozygomatic, if you have the posterior clinoid, because you cannot see the basilar artery. When you do the posterolateral way, you can see, but you don't need to take out the orbit because you are going from the lateral side and you go very, very low position. Okay, and this is because the extradural corridor. We published this. We have proper instrumentation. I almost never use drill in anterior cranioidectomy. I rather prefer to do with rangers. That's why I design special rangers for no drill anterior cranioidectomy. Okay, and of course the neuroanatomy. I'm going to end with this and one case because I have only 1 minute and I want to take 2.5 maybe. This is the neuroanatomy of the approach. This is Maxi Nunez from Argentina. Look at this. You can see everything, and this is the same that in surgery. The third, the fourth, the fifth nerve. You can see the Gruber ligament, the meningoepiphyseal trunk, and you can see the sixth nerve. Everything. When you take it out the dura, you can see the posterior fossa. And what happened then? You see the same in the surgery. Now I have 57. This is the optic, the carotid, the third, the fourth, the fifth, the basilar artery. Without take out any bone. We are below the brain. That's very important. If you put endoscopy, there's no limit. You see everything, both sides. And then this is, of course, a copy of concept of William Caldwell, was the very first that published the release of the nerves in the lateral wall of the cavernous sinus. And we, of course, published this in 2019. We made the volumetric analysis in the resection of sphenopetrocleidomastoid meningiomas. And I want to show you just this case of, this is a terrible tumor, sphenopetrocleidomastoid meningioma. What is the sphenopetrocleidomastoid meningioma? It's a petrocleidomastoid plus a middle fossa, plus a clinoidal, plus a cellar. And then a calcification of the tentorium. Terrible tumor. But this is a mini-pterional approach of the right side, mini-pterional. No retractor, no retractor, no retractor, no retraction of the brain. Everybody who do the frontal zygomatic said, no, you're going to retract if you don't do that. I'm not retracting. I'm showing you. This is a video. I can be a liar. Look at. Then I freed all the nerves. I followed the carotid, the optic, the third, the fourth, the fifth. Then I release the fifth nerve. I take out the tumor in the posterior fossa. This is Kawase triangle. And then what I do, I learned this from Spetzler. Okay, I never been with him, but I learned this. You don't need to take everything in one time. You can do a second stage. I leave the posterior fossa portion. What I did after, a normal, regular retrosigmoid approach. I do the park bench position. I'm not doing semi-sitting, but it's very similar to surgery, okay? And I just want to show you because I'm passing 1.5 minutes. This is the final view. The vestibulo-cochlear facial complex relief. This is the low cranial nerve. This is the temporal lobe. This is the cerebellum. Everything nice. We take out all the tumor. This is the MRI. Look at this. And the most important thing, the result in the patient. Look at the patient. Only a mild facial palsy. Okay, I'm going to skip this case. This is a superior cerebral artery aneurysm rupture that we treat with MIPLAT approach because we don't have time. I'm going to finish this. You don't need to do a very complex approach in the outside for the patient. You can do in the bottom. In the bottom is the important portion of the approach. You can combine with endoscopy. You can combine with robotic endoscopy, and you can reach everything in the posterior fossa. We are operating here epidermal cyst, here a BB junction, basilar artery giant aneurysm. This is the BB junction for the middle fossa. It's possible to see without a terrible retraction. The endoscopy gives us the limit. Thank you to my fellows. Thank you for your attention. Please excuse me, I passed 2 minutes, but it's very hard for me to explain all of this in 15 minutes. And thank you for your attention.
Thank you, Dr. Mura. That was an excellent talk and demonstration of the minimally invasive technique where you show that, where you demonstrated that it's possible to remove even large tumors without a very extensive approach. Just by using anatomical principles and releasing the cranial nerves from their attachments, and you make space between the corridors to reach the tumor and take it out. That was excellent. Do we have any questions from the audience?
Thank you, Dr. Mura. You showed this video where you don't use any retraction at all. Do you use lumbar drain or you don't use lumbar drain?
Yes, of course.
Yeah.
You know that's a problem of the 15 minutes. It don't give you the opportunity to show all the secrets, you know. And the secrets make the difference. Of course, we use the lumbar drain. If I have a ventricle with a big size, for example, in a huge tumor, sometimes these ones that are more clinoidal, you know, I put a drain in the ventricle. And the other thing, very important, this is a thing that we start to do just 6 months ago. When I do the craniotomy, okay, I made a opening in the most posterior part of the craniotomy, a small opening of the dura. I open the Sidman fissure in the distal portion, and I leave a cotonoid. And that maneuver is very good for the surgery, because every time that you are compressing the middle fossa for the peeling or any maneuver, the CSF go out for the hole that you did, even if you are not using the lumbar drain. And then we combine everything in order to relax the brain. The only thing that I don't agree is the people who do the middle fossa approach and put these stitches in the dura, because when you put the stitches and you retract the temporal lobe without take out CSF, you have like a trauma in the temporal lobe, and that's a problem. And that's why a lot of people say no, middle fossa is dangerous, you know, because you have brain swelling in the post-operative period or anything. But I think with the lumbar drain and the combination of opening, a small opening of the dura and release of the CSF is very nice. What I'm saying this, because a lot of people say no, when you open the dura in the optic nerve and in the carotid artery, you take out a CSF for the carotid cistern. But the problem that you must agree with me is when you have this kind of tumor, terrible, huge, that involve encase everything, you don't have the cistern. You cannot reach the cistern because the cistern is with tumor. And what you do then? You don't have cisterns to reach. And then if the lumbar drain fail, you are in trouble. And that's why I always combine the maneuvers. Lumbar drain, opening of the dura. If I have the opportunity, I put a ventricular drain. Everything that relaxes the brain is good.
Can I have a question? Wonderful lecture. I really enjoyed it. This is Dr. Ashish Suri from New Delhi, AIMS. Just one question. I've been doing these procedures the last, I think now 15 years, and I was trained by Vinco as well as Dr. Kawase. And I do a lot of extended temporal approach. I always do a zygomatic osteotomy because I feel that going under and then mobilizing the temporal dura extradurally is very important. I actually have a personal feeling that the CSF gives a tamponade. It protects the temporal lobe if you're doing a zygomatic osteotomy and you're elevating the temporal dura extradurally and you're doing an extended middle fossa approach. I'm slightly not in favor of the lumbar drains. Yes, I saw your experience, it's wonderful. But I feel that if you take off the CSF, you're directly retracting the temporal lobe. So I feel that there is, and the vein of Labe is protected that way. So this is a slight difference, but nonetheless, wonderful lecture. Thank you very much.
Yes, I did this since 1999. And I used the transzygomatic approach and the transorbital approach for 15 years. I agree with you that it's are good maneuvers, but I stopped to do the zygomatic cutting in 2008 because we don't need this. I know that this is hard for everybody who do this to say, okay, this one I live to do this, but you are talking with a guy, me. I was a fanatic of the transzygomatic approach. I always do when I want to flat the middle fossa. But if you think about this, and I try to see the surgeons who do the zygomatic, you never operate. If you want to use the transzygomatic, you need to be stand up in order to put your microscope just in the line of the muscle. The most of the time, the direction of your microscope is different. You most of the time, what you need is that's why the message I try to give you is in the bottom the problem, not in the surface. Okay, and I try to be honest all the time that in one case I made the everybody talk about this, huh? Modified transzygomatic. What I did, I don't like to cut the zygoma now. And then what I did, I have this guy with a huge temporal. I don't know, he was good for barbecue. I don't know my patient, but it was a huge temporal muscle. And what I did, I made my interfacial dissection. I went to the zygomatic arc and I flat a little bit the zygomatic arc, you know, and I get this 5 millimeters. And I completely agree with you. Nothing is writing in stone. This is an alternative. But if you must need to know how to do a transzygomatic, because I know how. And the other day, for example, I was in a cadaveric course with my residents, and I said, okay, you learn miniterional with me, but I'm going to teach you how to do a frontal orbitozygomatic approach because you need to know. Because sometimes you don't have the experience, you have a problem, for example, a brain swelling in the surgery, and you don't have a space. You need to know all the techniques. I'm not saying this technique is better than the other techniques. No, no, no. You need to know all the alternatives, and you need to pick up the better for your patient.
Thank you. Wonderful. Any other questions? Thank you very much. Thank you. It was a wonderful lecture and a lot of discussions. I wish we had more time for you. Thank you very much.
Thank you. I think the next talk is by Professor by Dr. Baskaya, who is a Robert Dempsey Professor in Neurological Surgery and Director of Skull-Based Surgery at the University of Wisconsin Medical School. I believe this is a recorded talk. Yeah, and the talk is on the far lateral approach.
First of all, I'd like to thank the organizing committee of the annual conference of the Skull-Based Surgery Society of India, and special thanks also goes to my former fellows and the organizing committee, as well as the Dr. Das. And thank you for having me. Unfortunately, this is recorded video, and the day of the meeting, I'll be traveling, and I apologize for this. So I'll be talking about the paralateral transcondylar approach and indications why we do this approach. All main purpose is to get the ventral anterior to the brainstem. Any lesion involving the brainstem anterolaterally located, or intraaxial or extraaxial in the clivus, lower clivus, and this is the perfect approach. And there's so many modifications, and because of the limited time, I'll just go talk about the far lateral transcondylar approach. These are the common lesions. The most common lesions former magnum tumors and the extradural tumors like chondromas or chondrosarcomas, or interesting tumors involving the brainstem and the vascular lesions. What are the advantages? Main advantage is minimize or eliminates the need for neural retraction and very short distance to the anterior former magnum and wider angle of the exposure. Disadvantage is you have to deal with the dissect the vertebral artery extradurally at the V3 segment, so you can cause injuries and you can cause cranial nerve injuries during the drilling. And sometimes if you drill too much occipital condyle, usually 30–50% of the condyle, you can cause craniocervical instability. The more you drill the condyle, much wider and much anterior, more anterior exposure, but most of the cases, especially space-occupying lesions, tumors like former magnum meningiomas, you don't need to drill the condyle at all. Lesions like chordomas or chondrosarcomas involving the bone, the more you drill is better because you are removing the tumor. the position and incision. I like to use this in a hockey stick incision. I learned this from Roberto Heroes. Initially, when he described like a lazy S, and then he noticed that those patients have more muscle atrophy and then the pain. So he changed this, and this is a long, big incision, but it works very well, and I explained that why. Because the midline incision is in the midline nuchal plane and avascular plane. If you do subperiosteal dissection, you are not devascularizing the paravertebral muscles. This incision is you leave a little muscle cuff along the superior nuchal line, and the rest of the dissection again subperiosteal. Is a big muscle bulk. You retract inferior laterally, but when I see my post-op patients, they have almost no atrophy of these muscles. So as long as you work in the subperiosteal plane, it works very well. Other proposed incisions, like I mentioned, it may work, but this works in my hands and my experience. Anatomy is important. If you are preparing the occipital artery, you need to know the anatomy of the occipital artery and skeletonize it for vascular lesions like bypass or aneurysms. Otherwise, you don't need to dissect anything. You just do one single flap. So you leave the muscle cuff along the superior nuchal line, and then another cut along the nuchal line, and you elevate this in subperiosteal plane. And then you can get a pericranium above the superior nuchal line for your dural closure at the end of the procedure. And then what you are exposing in the C1, you need to expose some of the C2 to relax these muscles. In some foramen magnum tumors cases, you may need to go inferiorly if tumor is extending to the C2 or C3. And then you identify the sulcus arteriosus and the V3 segment of the vertebral artery. Again, I'm going to skip these dissections. The craniotomy is a tear shape, and one cut is near the midline. You can extend your craniotomy, but most of the time you don't need to. And then you come laterally and make a turn towards the foramen magnum, and you skip the with your craniotomy, you skip the paracondylar fossa because the bone is very thick here. Then you drill this bone. Be careful when you are using a monopolar electrocautery to make sure there's no malunion of the C1. So you don't want to penetrate with your monopolar electrocautery inside the dura and injure the craniocervical junction. This is again drawing in the cadaveric dissection. So this is wrong. So you need to come like this. This drawing is not reflecting the true procedure. So if you come like this, your craniotomy is not. You're not going to come out from this, and you can injure the vertebral artery. And again, the more anatomical dissections showing there's a large venous plexus over the V3. You need to deal with it, but most of the time, if you don't need to transpose or mobilize the V3, all you need to do get the proximal control. You just dissect a little bit and get your short segment of the V3 exposed. And this is the final view before the laminectomy, craniotomy, and the condylectomy. And this is the exercise we do in the lab, showing how you drill the condyle, and you basically eggshell. Removing the 20%, 30% is more than enough. Most of the time, even 5-10% is enough. And in some large tumor cases, you don't have to remove condyle at all. And dural opening is, again, towards the bone opening and the midline and VT, so we can retract and get the tangential view to the craniocervical junction. When you are doing extradural dissection, be aware of your vascular variations. This is the extradural origin of the posterior inferior cerebellar artery. And when you have posterior inferior cerebellar artery extradural origin, be careful. You can have also posterior spinal artery originating from the extradural portion of the pica. So we studied this in the past and we published. Be aware of your vascular anatomy before you perform this kind of surgery. So I'll just briefly go over a couple of case presentations, case illustrations where we use this approach. The first case is the 51-year-old patient who presented with Hunter's grade subarachnoid hemorrhage, comorbidities include the morbid obesity. He was arrested in the ER and brought back, and we put the ventricle after the initial CAT scan, and the CAT scan CT angiogram shows a dissecting aneurysm of the initial segment of the pica. So this, after discussing with the endovascular colleagues, we decided to go ahead with the trapping and the bypass procedure. The plan A, pica bypass, if possible, and then trapping. Plan B, occipital artery pica bypass. Plan C, V3 pica bypass with radial artery or saphenous vein. But if you look at this anatomy, first problem is this extreme thickness on the bone and this angle of the foramen magnum and the posterior fossa. So in order to get low, you have to do torcular craniotomy, take all these bones, which took some time in this case. And pica side to side is the option, but as you see, this tonsillar loops of the pica where you're going to bring this together is quite high. So this is extremely high riding pica. So from the beginning, I knew we won't be able to do the pica bypass, but first, always before you decide, be prepared. And another problem with this case was the occipital artery almost didn't exist. So occipital artery pica bypass was not an option. So we prepared the legs and the arms for radial artery and the saphenous vein, and we start to expose. And after initial exposure, you see this is the venous plexus around the vertebral V3 segment. This is the muscular branch. It can be very difficult to get around this vertebral artery. So we take the muscular branch of the vertebral artery and then prepare the potential temporary clips. And after hours of dissection, so this is mobilizing the venous plexus around the vertebral artery. And then once we get that done, we're going to open the dura and explore, see can we do pica side to side bypass. And this is the opening the foramen magnum. And once we get there, I'm going to speed up. And this is the pica after extreme retraction of the tonsil. There is no way I decided I cannot do pica because I cannot retract two and resect two tonsils, and in that angle, very, very flat angle of the posterior fossa, I resected the one tonsil, ipsilateral tonsil, so I get enough length of the pica so I can do bypass. So we decide to go ahead with the vertebral artery V3 to pica bypass and trapping. When our plastic surgery colleagues were exposing the arm, radial artery got thrombosed, but luckily there was a cephalic vein. We harvested cephalic vein instead of saphenous vein. So as many obstacles we were faced, but we were able to come over. And this is the initial bypass and doing the arteriotomy on the pica. And there's retraction on the resected tonsil even, and still is very deep and very bad angle to do this bypass. But we did it, and after we did the final bypass, you'll see the vein is filling retrogradely. Then we did the V3 bypass, is nicely filling. Then what we're gonna do, we're gonna go ahead and trap that dissection segment and excluded that segment, preserving the brainstem perforators and doing the V3. And Hunt's grade 5, but improved significantly after 2-3 weeks, and now currently living independently. This is the very robust vein graft, and then we trap the rest. Another one is the chordoma case, very significant lower cranial nerve deficits, and very extensive chordoma involving the occipital condyle as well as the clivus. And the decision was first do the balloon test occlusion because vertebral artery on the left side was encased by the tumor. So these are the things I did. Unfortunately, I don't have time to go over, explain you guys every single step. But first we did the infralabyrinthine exposure to reach the highest point of the tumor, and then get the transsigmoid approach. Just I put the temporal clip on the sigmoid sinus to whether I can ligate it. The second stage became paralateral transcondylar approach, and the third stage, and these are the reasonings of those things. And if I have time, another time, maybe I come and visit you guys, I can explain this case better. So this is the far lateral approach again, and exposing the vertebral artery. And then in this case, you need to transpose because we're gonna drill all around the vertebral artery. That's very important. And then you have to get the full control of the vertebral artery. Then after that, you start drilling and taking the condyle, taking the C1 condyle articulate facet, and removing everything. And then this tumor this is long video, but I'm just going to briefly go around. And this is the encased vertebral artery. You have to do sharp dissection around the vertebral artery, mobilize it, and extradurally, then intradurally, because tumor is all encasing this where it's entering to the intradural segment. So you have proximal control, you have distal control, and then you go around it and remove this part of the tumor. So this is the tricky part, and you have to do sharp dissection. So this is the muscular cuff where vertebral artery normally entering. This is the tumor extradurally and intradurally here. So see, now we are dissecting the intradural segment. This is the transition. Once that's done, we can free all this tumor, skeletonize the hypoglossal nerve, and remove the rest of the tumor. And unfortunately, I couldn't get the entire tumor this approach. I had to do the third stage with the endoscopic assistant transoral, and then we got that part. So see, now we are winning the game because I was able to dissect and remove this part of the tumor from the vertebral artery. And the same principles, proximal control, distal control, like you are doing the aneurysm, and eventually this entire tumor goes away, and we see the hypoglossal nerve. We're going to skeletonize that where it is coming out. Although he has no function of it, it's good to preserve because these are peripheral nerves, and you can have a good. Sometimes they can recover. So I have to stop here and remove that piece, and then we did more. And these are the fat graft we put. We did occipitocervical fusion and came back third stage, and then the proton beam therapy, and he did very well. And this is the case, ependymoma, you don't need to drill the condyle, but you far lateral approach to get it, and we eventually got this tumor completely out through the far lateral approach. Hemangioblastoma, again, cerebellomedullary junction, and is a good case. You can do the far lateral approach without occipital condyle drilling, and you see this patient has a congenital alopecia and no atrophy at all, and very good results. Foramen magnum meningiomas are perfect cases. In these cases, again, drilling is condyle is optional. You don't have to drill too much. And this video actually you can watch in the Skullbase Operative Neurosurgery, Skullbase Journal, and the entire length of it. And hopefully I still have time and I can go further. So basically, once you expose intradurally in the foramen magnum meningiomas, you create windows between these neurovascular structures, between nerve roots and the arterial or branches. You cut the dentate ligament, and once you create the windows, you work between these nerves, and then you get to the base of the tumor, and then they start debulking. As you debulk and get to the base, you skeletonize more, and this is the base of the tumor in the lower clivus, craniocervical junction, and then we'll go remove more and debulk. See, that's the base, and working around it. Okay, so you exchange your maneuvers. Go debulk, dissect as you gain space. Go to the base, dissect more, and dissect from the brainstem. So and debulk more. So that's the dissection plane you develop, and then get more and remove more. Okay, working between nerves and then those windows you created. But the key is the initial arachnoid dissection, and this is the vertebral artery, and this is the, so eventually we're gonna see the contralateral vertebral artery and the contralateral hypoglossal nerve. So you pay attention not to injure contralateral cranial nerves, because having bilateral lower cranial nerve injury will be very, very bad. So you pay extreme attention not to do that. You see that the last attachment and then removing the entire tumor one piece. See, these are the contralateral hypoglossal nerve rootlets. And so these tumors has a wide, especially the very anteriorly located former magnum meningiomas will have a wide base attached to the clivus. And we can go ahead and remove last piece. It's beautiful feeling when you pull this tumor like that. I'm going to repeat again. It's very satisfactory. And then there's a little dural tail going over, and we're going to remove that. This patient was quadriparetic and immediate improvement, and she's doing very well with it. And another example is the dissecting aneurysm, and this is the perfect case. You need to do a little more condyle in these cases, and this is a fusiform aneurysm probably developed from the dissection. At growing, and indication of the surgery was growing aneurysm. Endovascularly access was difficult because she had all kind of femoral stents and the radial artery stents. So in these cases, important thing is the checking the perforators and making sure you are not including the perforators with your clip. You need to see the distal vertebral artery, and this is luckily is 180-degree fusiform aneurysm, not 360 degrees, so we can do clip reconstruction. And after initial exposure, you see I'm seeing the right now, I just got the glimpse of, yes, now this is the distal vertebral artery. I know where the pike origin, and I see the perforators. So I'm going to do clip reconstruction of this, and the idea is to preserving these small perforators. Okay, that's the one clip, and I'm going to enforce that with the second clip. So good enough exposure, and then dealing with this complex aneurysm in a brief surgery. Okay, looks very nice. And we're going to do ICG green. See, that's perforators nicely preserved, origin of the pica, and distal word. Good results. And this is also another case, previously coiled pica case, and same principle, drilling little bit condyle and getting it. So in conclusion, before you do these kind of approaches, you have to have better understanding of the anatomy, surgical anatomy, microsurgical anatomy, and use the principles of the microneurosurgery, which is as introduced by Professor Yaşargil, arachnoidal dissection, okay? Whatever skull-base approach you do, at the end, you are intradural, and you have to perform these arachnoidal dissections. So my advice to you, go to the lab, okay? These are the pictures from Professor Yaşargil. In 1953, he performed his dissections in cadaver cats, and he came up with this 3D slides. So he was the first one actually with this, introducing this 3D slides. So go to the lab, dissect, so you can learn better, and you can understand better, then you use those skills and the knowledge in the real operating room. Thank you for your time, and unfortunately I won't be able to take any questions because this is recorded video. I appreciate your time and efforts and then the future of, I think, microneurosurgery is in Asia, and my Indian colleagues, they are extremely good, and they are making very good progress in microneurosurgery, and they will carry the flag. Thank you very much.
So I think that finishes the evening session of international speakers, and Kuntal will make some announcements.
Thank you, everyone. With this, we come to the end of the proceedings of the day. So now we will go to the dinner venue, which is at MB Club. The transport is available right at the exit, at the parking. So all of you are kindly requested to go there. Our team will guide you to the MB Club. In the meanwhile, the EC meeting is happening, and the team will join us later. I would like to thank all of you for staying on, hanging on, and completing the day. Largely, it has been a successful day here as well as in KGMC, and we are really thankful. Tomorrow we'll be starting at 7:30. The program is quite packed. So I would request you to be on time so that the session doesn't get delayed. Thank you and good night. Let's see you at the dinner.
My ankle joint is gone completely.
सर बता देगा अच्छे से.
300.